Our first speaker of the day is Dr. Miten Sheth, who will be talking on unicompartmental arthroplasty.
Hi, good morning everyone. Happy Sunday, and thank you to the organizers for having me for this conference. It was a real pleasure learning and sharing over the last 2 to 3 days. When we transition from femoral component is spherical and the condyle is not, and the answer to that is, oh no, but there is a lot of evidence to say that that spherical component works. The meniscus is fixed, it's fixed to the tibia. No, but the mobile bearing moves and there's a lot of evidence that it works. So this entire talk is about the Oxford having a lot of evidence, but sometimes you can use better logic and do better things, and hopefully that logic will translate into evidence over a period of time. So you have to do the Oxfords in a leg hanging position with a leg holder, and there are different issues with draping. You have instruments where there is a propensity for some of them to fall off. You have to keep catching and holding and making sure everything is in place. And then if you want to, if at all, convert to a total knee, it's really difficult, because if you've already put the leg holder in, then you have to rearrange everything, put the patient into a supine position and redo stuff. Whereas if you're doing, using one of these robotic systems for a partial knee replacement in the supine position, transitioning from the UKA to the TKA is just the click of a button. So logic says that doing a robotics assisted partial knee replacement in the supine position makes more sense. If you want to place the femoral component, then you need to do those cuts. And when you're using the Oxford, you make an entry, put in stuff inside the canal, and it seems to be close to the weight bearing area, not the weight bearing area, but say in the trochlea where the patella could articulate. But Oxford has evidence that it doesn't make a difference. Also, you're using these femoral spoons to size the femoral component, and that's a variable from surgeon to surgeon, and you may go off, and there may be on the post-operative X-ray some overhang. We already know that the existing sizing of extra small, small, medium, large, that transition is not enough for our Indian patients. But Oxford has evidence that it doesn't make a difference for the outcomes. Whereas if you use a fixed bearing, robotics assisted partial knee replacement system with a lot of component sizes which you can match on the screen, the X-rays almost look the same case to case, case after case. But Oxford has more of post-operative radiographic guidelines to know how these components are, whether you've done a good surgery or not. I'm assuming with logic, we can also on these post-operative X-rays calculate our LDFA, our MPTA, overall limb alignment, and make sure that we are doing good fixed bearing UKAs as well. As far as the tibial cut is concerned, the depth of the tibial cut becomes the most important part of an Oxford surgery. And if you cut deep, or you cut in the wrong direction, or your recipro cuts a little deep, these are all risk factors for tibial subsidence and issues related to the Oxford. Also, if you are operating on a patient with constitutional varus, then if you see on the right hand side screen, you would have to move the jig a little bit, because you want the Oxford tibia to sit parallel to the ground, right? In a patient with constitutional varus, like you can see in the center, there is a propensity for the tibia to sit, the component to sit in valgus. All of this is offset and made much easier with the robotics assisted tibia preparation. So if you're doing the tibia prep, you're able to see on the screen, you won't go deeper, your resection depth stay at around 5 mm, 6 mm. You're also able to see how it's affecting the flexion and the extension balance and play on the femoral side. So the tibial cut becomes simpler, and there's lesser propensity for errors if you're using robotics assistance. Most importantly, if you get the tibial cut at the same level, case after case, which you may not with an Oxford, and if you cut deeper with an Oxford. So when I started the Oxfords, I was always taught that, oh, if you use a G3 clamp, then you may have a tighter space and then you may have to recut. So if you're a new user, why don't you use a G4 clamp so that you never have to recut the tibia? But all of this again goes to say that we may go wrong with cutting the tibia with an Oxford. Whereas if you're cutting right with the robotics assisted system, then you're able to maintain the joint line. If you're able to maintain the joint line, not distalizing the femur, I think now evidence says that this is better than otherwise. What about the implants? So as far as the Oxford's concerned, there's on the femoral side extra small, small, medium, large and extra large, and of course on the tibia it's site specific and you have AA, A, B, C, D. And on the fixed bearing side, at least for the Journey Uni, we know that we don't have a spherical femur. It seems more anatomic. And the transitioning, you can see the difference between what we receive as surgeons. There is more information. I know exactly how much medial-laterally each component is increasing by an mm. I know exactly how much the flexion space and the extension space will change if I change from a size 2 to 3 or a 3 to 4 or a 4 to 5. And this can be seen on the gap balancing screens during the surgery itself. So even as far as the implants are concerned, there's more information, more specific information available to us. As far as the bearings are concerned, we know that the clinical radiological outcomes, the revision rates and the survivorship is pretty much the same for both. But we know that the polywear is more common and there's more chance of aseptic loosening with fixed bearings, and there are bearing dislocations that are more common with mobile bearings. So how does that happen? Either ways, component malalignment could lead to problems with both bearings. How do you make component alignments better? With robotics assistance. If you undercorrect deformities or you have soft tissue imbalances, again, the bearing won't perform well. How do you do that better? By understanding soft tissue balances on the robotics assisted screens. How do you arrange the tibial slope better? By knowing the slope in the first place. How do you know the slope better? Again, on the navigation and the robotic screens. So the only thing where the robotics assistance may not really make so much of a difference is trying to diagnose an ACL deficiency or an instability, in which case both the bearings don't perform well. But that's clinical. If the patient has an ACL deficiency, you can make it out preoperatively. You don't have to wait inside. In fact, fixed bearing knees can potentially circumvent an ACL deficient knee as well and still perform better. Right? We also know that there is evidence that the rate of bearing dislocation is significantly higher in the Asian than in the Western population. So in summary, you can shift to a robotics assisted UK by doing surgeries in supine position. You're happier that a fixed bearing prosthesis has no bearing related issues. Better component placement. Of course, Oxford says that the spherical on flat design doesn't make difference if you have 10 degrees of varus or valgus in the femur, if the slope goes wrong on the tibia. So they have evidence for all of this. But in front of your eyes, if you're better placing the components better, if you can see the soft tissue balancing better and you can maintain the joint line better, I think you're a happier surgeon. Thank you.
Thank you, Dr. Miten. Please take your seat on the stage. Hello.
Dr. Miten, I think that was an excellent talk about conversion from mobile bearing to fixed bearing. But what we would specifically like to know is if there was any challenges shifting to conventional to robotics in terms of your operative time, your length of incision, because that's a completely different philosophy when you're coming from the Oxford, the mobile bearing, and you elucidated the differences in terms of the challenges of the Oxford. But coming to the technique specific challenges that you faced while doing robotic as compared to the conventional.
So most of the times, if you're shifting to robotics assisted surgeries, you're going to do the total knees first. So you already probably completed your learning curve while doing the total knees, and then you're going to attempt the partial knee replacement. So all the time taken to actually establish the pins and the registration and all of that process already sorted for you. So in fact, a robotics assisted UK would probably be faster and more efficient at and when the surgeon actually does it. You've already sorted the exposure and everything else.
Yeah, any more questions from the audience? I think we can call upon the next speaker.
While Dr. Rohit Ultra is getting ready with his presentation, I would like to invite Dr. Vinay Joshi to give his talk on imageless saw-based systems. I invite Dr. Adarsh Annappareddy and Dr. Kushal Hippalgaonkar to moderate this session, please.
Good morning, friends, and a warm welcome. It's my absolute pleasure to be here in Makkah of robotic TKR, where Dr. Vaidya has started the journey, and we all are keen followers. Now, when this topic was given to me, imageless saw-based, I was quite perplexed because I didn't know where to start. But then, diving deep into the topic, I realized that that is actually the base from where we have chosen our robotic system. Now, I worked at Kokilaben Ambani Hospital in Mumbai for last 12 years as a joint replacement surgeon. So I first interacted with robotic few years ago in Chandigarh, where I had a chance to work on a saw-based workshop, where it was only available for the UKI, and that was with the burr. And that put me off, to be very frank, and I was never interested in that, possibly because I didn't like the concept of burr. Then last year I got a chance to go to Florida, where I worked on a saw-based robotic workshop, and I was very much happy and was very much involved in that. Then I interacted with various experts all around the world, especially from New Zealand and America, and got to know much more details about it. And finally, practiced on a cadaver workshop in Bangalore and started my journey in this field. Mind you, I was not a navigated surgeon. So for me, it was a big jump directly from a conventional one to a robotic without navigation. So once a famous arthroplasty surgeon, Jakosky, has said that no industry has ever seen robotic technology being introduced and ultimately not show increase in the production capacity, improve accuracy, and lower the cost. Now, as we have learned in last 3 days, robotics really gives us enhanced surgical planning. It also gives us greater precision and accuracy, but for me the winner is it gives me a ligament sparing option. I'm always a CR surgeon and I like releasing less ligaments, so this is an excellent tool to give us less ligament release. Now, as you know, alignment is the key to get successful result because it improves the function, decreases the complication, and optimizes the durability. As against malaligned knee causes accelerated wear, component loosening, and in turn causes pain, instability, and stiffness. Now, it's very interesting. If you see a Google trend search over last 10 years, there is 4 times increase in the patient interest in robotic joint replacement surgery. So it's not a rocket science that all major companies have jumped into robotic technology. Some of them started with UKI, and almost all the major ones have now introduced their robots, right from Cori, Velis, Mako, Rosa, CUVIS, etc. And each and every one has got their own advantages and disadvantages. Now let's dive deep into history of robotics. Now, first generation robotics actually came into picture in early 2000, where there were 2 prominent robots, Robodoc and Casper. Now both needed a preoperative CT scan. And early study shows that there was much better accuracy and precision of an implant fit. But unfortunately, it failed to equate to improve clinical results as far as patients are concerned. And there were a lot of technical glitches and intraoperative complications. So that leads to cessation of their use. These all 2 systems, majorly Robodoc and Casper, were open systems where they were compatible for different companies' implants. So they used to just give us a base as a 3D model for various different companies to use their robo. Now it's great because different companies can use that system, but there was a major downside because once you use different companies' different implants, the predictability of the optimum implant positioning was quite limited. So it doesn't give us exact predictability how our implant is going to do. So almost all the new robotic systems are now closed systems. For example, Mako is for triathlon, Velis is for Attune, etc. So coming to image-dependent and imageless robotics, both these systems basically create a specific 3D model. Image-dependent one, you have to get a preoperative CT scan, as against imageless system derives its data from registration of the bony surfaces. And it's very important to have joint kinematics where the movements will dictate how you are going to do the surgery. Now, image-dependent system has one definite advantage that you get sufficient time to do preoperative planning, to choose the implant size correctly, to get the orientation proper. As against imageless system, you have to take all the decisions on table. But the downside of both is in image-dependent system, you have to get patient admitted before extra cost, radiation, etc. While in imageless system, you have to get absolute precision, registration, and good kinematics to get into the proper system. Because as you know, that garbage in is equal to garbage out. So if your registration is not good, imageless system is going to give you poorer results. So there are a number of papers which suggest that preoperative CT scan is required for accurate planning before the robotics. But it also includes extra costs. So patient had to get admitted before, CT scan has got extra costs, which a lot of people are not very happy about. And last but not the least, a lot of people come and say that, look, I don't want a CT scan because it has extra radiation. And mind you, each CT scan is equivalent to 100 to 250 chest x-rays. And again, CT-based system isn't infallible. So if you're thinking that CT-based is absolutely accurate, it's not. Because despite you having knowledge of CT scan, finally surgeons still have to open the knee and mark the points on the patient. So there is a possibility of introduction of human error there. Now again, why saw and not burr? So I'm doing TKR for last 25 years and I'm used to using saw for those many years. I don't want to change to something which I'm not used to using a burr. Secondly, I feel burr creates a lot of bony dust. It can be really messy in the table. It can obscure your vision. Your cuts can be irregular. They are not clean cuts. It's more time consuming, at least in my hands, and it can be really frustrating. And a lot of our surgeons now, like me, we do more than 2 or 3 TKRs a day. So if you're using a burr for that much longer period of time, a lot of surgeons are now complaining of hand pain, neck pains. So there is this factor you have to consider. Now look at this. The burr is producing a lot of dust which can obscure your vision. The cuts are quite bad and irregular. And a lot of time you have to use a rasp to get the cuts right, or you have to use a saw. So when you're using a rasp and saw, you're compromising your precision. And so what's the use of using a saw after using a burr? As against Velis, which is a saw-based technique, is a very, very slick technique. You've got a very good chance of getting a very clean cut. You can check and recheck. Now I have timed myself. You can finish all the cuts within 4 to 6 minutes. The cuts are very slick and nice. So finally, why go for Velis robotic? First of all, I am used to doing Attune knee for last 10 years, so I do not have to change my system. It's just a technical advancement of the same system which I am using, which is very, very beneficial and crucial. Second, it's a saw-based system which I love. I just hate using the burr. I do not need to have a CT scan. So if the patient decided that he wants a knee replacement tomorrow, we are ready to go. And it's a very compact system. So we do a lot of bilateral knees. So while I am closing one knee, my assistant can change the system and attach it to the other side while I am ready. So just within few minutes, we are ready to go on the other side. So it is very, very user-friendly. So finally, in today's era, you don't want to see a horrible picture like this, where the cut is almost in 12-degree varus. Every time we want to do a reproducible knee on the right-hand side, which is possible with a robotic system. So I feel robotic TKR is here to stay, and in next 5 years, you are going to hear more and more about it. Thank you very much.
Thank you, Dr. Vinay. So next, I'd like to call Dr. Rohit Luthra to speak on one of the latest buzzwords in hip replacement.
We have a slight change of plans. Dr. Suhas Kamble will be speaking right now about the learning curve with Mako, followed by Dr. Rohit Luthra. So I invite Dr. Suhas Kamble.
Good morning, everyone. Today I'm going to talk on learning curve in Mako. So once we start using robotic, we need to understand the components of the robotic system. We need to learn the pre-planning, CT scan and segmentation and the plan itself. We have to shift from a 2D templating to a 3D based planning when we are shifting from a conventional surgeon to a robotic surgeon, and that is a part of our learning curve. We have to shift our focus of intraoperative thinking from instruments using anatomical landmarks intraoperatively to landmarks as per the CT scan and the intraoperative system. We need to do adjustment of our preoperative virtual plan according to the intraoperative feedback. Intraoperative patient-specific customization has to be done. We have to think and we have to adapt to the thinking about resecting the bone thickness, considering the cartilage thickness also. So the system will show the values as per the bony landmarks, whereas we have to think about the cartilage thickness as well. We need to understand the effects of adjustment in one aspect of preoperative plan on the other parameters. So when we are changing we are adjusting the rotation of the femoral component, how it is going to affect the other component, that we have to keep in mind continuously. We need to practice and adapt the surgical skills for bone registration. So, I mean, how much deep we need to press the probe on a cartilage, how much on the bone we need to just touch on the bone, and that way, because the CT scan understands the bony landmarks. We have to learn to work in a space with limitations of non-obscuring the path between the arrays and the camera. So on the side where the camera is, we need to adjust the position of the assistants. We need to learn to juggle between the femoral array, tibial array, and robotic arm. We need to learn the art of capturing proper intraoperative gaps and understanding the ligament balancing based on these numbers. So we are always used to have the feel in conventional things, but we need to learn the art of capturing the gaps and converting them into numbers and then making the adjustments. We need to do coordination with the staff, the robotic technician, the nursing staff, surgical assistant. All of them have to be tuned to the new systems. Robotic arm is a haptic tool, so we need to use it to the perfection, and we need to believe in the robot. So we have to work with the how to use a saw loaded on a robotic arm. So we need to learn to believe on the robot. We need to have certain learning skills outside the OT also, to learn the economics involved, learn to emphasize on patient the advantages of the technology and pass on the advantages of the technology to them. How to make this learning curve easy? We need to read extensively, sawbone and cadaveric courses we should attend. We should watch videos on WooMedi, YouTube and other sites. Spend time to attend conferences, surgeon visitations to improve our skills, and repeatedly introspect, rethink and revise how is our own progress. So in these few papers, the learning curve has been, it shows that the improvement of the operative time, there is a constant improvement in the operative time from 6 months to 1 year. In this paper, Hannes suggested that the learning curve is between 14 to 43 patients. My own learning curve, after first 100 cases, we could, after the learning curve to be time equal was around 44 to 45 patients. And after, this is the data after 100 cases. Thank you very much.
So for that wonderful presentation. Please take a seat on stage. I would now, are there any questions for sir? We have one question.
That was a great talk, Dr. Suhas. We have been listening about the learning curves, all this conference. At the end, we are making learning curve is equal to operating time. How many would agree that it is equal to operating time?
How many cases you take to be time equal or what?
No. Learning curve, as you go through your talk, we have seen that we learn several things.
Right.
How you do your cuts, how you do your trackers, ligament balancing, component position, and all this.
Right.
And at the end, we come to operating time. But lot of the studies show at the end, we are just measuring learning curve is equal to operating time. Would you agree with that, or would you look at the surgical outcomes and the functional outcomes as a learning curve equivalent to your conventional compared to robotic?
We keep on mapping each and every step of the surgery, like how much time we are taking for registration of the bone, how much time we are taking for cutting, making all the bony sections, for making the changes in the plan. Each step we keep on mapping for every case, so that we revisit where we are going to save time next time. And then gradually all these aspects keep on improving to finally come to a particular time.
Yeah, completely agree with that. My just suggestion is we should not be focusing just on the time we are taking, the time change or time you are saving. I would say how well you have corrected your balance, how well you have done the
that is the final outcome.
That's a kind of change in the thinking which we need.
Yeah.
Learning curve is not equivalent to just surgical time, because you can finish off any surgery within 40 minutes. But are you getting your cuts right? Are you getting your balance right? That is the most important.
Yeah,
the focus when we talk about the learning curve should be more on those than just timings. Just a suggestion.
Of course. Finally, we analyze what are our results after every case. And after 40, 50 cases, you come to know that all the X-rays post-operatively look similar. That is the final aim where we all wish to proceed.
I do agree with that.
Yes, sir.
I would focus more on the outcomes than just times. Thank you.
Of course. Thank you.
One more message for the audience, so that this learning curve for robotics, if you just compare your learning curve for a knee replacement, a conventional, and then compare it to your learning curve for robotics, the transitioning from a trauma surgeon to arthroplasty has a much steeper curve compared to adopting technology and putting the robotic system as a part of your armamentarium. So I would say the second part is quite easier compared to jumping onto the arthroplasty learning.
Another point from my side as well, sir. Wonderful talk. Just that the transition, as Kushal said, from conventional to robotic TKRs is not as difficult as probably from a trauma, but especially if you've done navigation before, the learning curve will be even less. And if you're again talking about learning curve between TKR and robotic unis learning curve is even less, because learning a unicorner conventionally is not easy at all, as Dr. Mithin nicely put up. But when you're doing it with a robotic, you don't need to have much experience with a conventional uni to be able to adopt a robotic uni. So I guess the learning curve is shorter with a robotic uni.
Thank you. I would now like to invite Dr. Rohit Luthra to present his talk on the direct anterior approach using the robot.
Well, good morning, everyone. I hope I'm not the only black sheep here anymore. So coming to doing DAs and doing DAs with robots, so how safe is it? So we'll just see what basically I'm talking about. So THR has been one of the most successful surgeries in orthopedics since its popularization since 1960s. We all are aiming to get the perfect implant placement, perfect alignment, perfect limb length discrepancies, to avoid any limb length discrepancies, and to get the patient back to his foot as early as possible with minimal pain and earlier functional recovery. So the need for THR is increasing because of COVID pandemic we had. There are a lot of patients, a lot of young and active patients who are coming to us for surgeries. A lot of bilateral AVNs we are seeing. And the main target for all of us is to reduce or shorten the recovery time and to place the implant accurately so that the patient has good functional outcome without any complication like dislocation or limb length discrepancy. So the hip now can be approached through so many approaches. We all know there are the 360-degree approach to the hip. What we most commonly use is posterolateral, then direct lateral, anterolateral, and direct anterior. So I am a posterior surgeon. I was a posterior surgeon, so I've just crossed the line maybe 3 years back, and I've now started doing most of my surgeries through anterior approach. Now coming to why I shifted. Conventional THR provides very good, posterior approach provides very good exposure to the joint. It's easier to perform than the anterior approach. Then why change? Why change? Because it's like falling from a skydive. So you don't know where you will land at the end of the surgery. Most of the surgeons, even the best of the surgeons, have incidences, very rare incidences in which they have not put the implant in the right position. And they themselves know that no, this one thing is not went right today. So to avoid this is one of the reasons jumping to anterior approach. And limb length discrepancy being one of the most common causes in any other approach than anterior. If you're doing it conventionally, limb length discrepancies are very common with any other approach because the patient is lying on lateral position. And also there's a chance of dislocation, there's sciatic nerve palsy risk, and also component malposition. So all these factors actually were bothering me, and I wanted to start doing anterior approach. So why DA? Because also the patient is very comfortable in surgery. The patient is lying on his back. There's minimal discomfort, and most of it, my anesthesia is also very comfortable because in case if the surgery gets prolonged or due to some other reason, the plan of anesthesia changes, they can easily put in a tube and the patient can be put under GA. And also one of the reasons is DA being an internervous plane, so there's no, it's intermuscular plane, there's no need to cut any muscle. You just have to cut the fascia and you're at the hip, anterior capsule, and it's very simple. While doing any other approach, you are going intramuscular or you're cutting various muscles, you're cutting the rotators and then you're trying to repair. There's chance of dislocation and there's a chance of other injuries like neurovascular injury. So conventional THR by anterior approach is a muscle sparing approach. There's a smaller incision, there's faster recovery and offers less exposure. So the only pitfall is offers very less exposure of the joint. So you're looking through a very narrow window. So why now moving from conventional DAs to robotic DA? Pitfalls for conventional DA is the incision is very small. So you're looking through a very smaller window and you might struggle while placing the implant or the astral exposure. And there's a need for special instruments and table. There's also a risk of implant malposition if you're not doing under a fluoroscopy guidance. There's also a higher learning curve and there are complications like wound complications or trochanteric fractures which can happen in the early stages. So what are the methods to improve THRs when you're doing it through anterior approach? One is to do an intraoperative fluoroscopy. You can take C-arm shoots. So whatever position, if the patient is you're doing through a posterolateral approach or posterior, the patient is lying lateral, you can take C-arm, but it's a little inconvenient every time to pass in the C-arm, take shoots, and it's difficult. The other way is to use computer navigation, and lastly now to use robotic arm assisted guidance. So conventional DA, you can actually, when you're doing a supine, the patient is supine, you're doing a THR through anterior approach, you can actually position the implant and check under C-arm. You can check the offset and limb length discrepancy also. So I'm just sharing a few x-rays. So here you see, before putting the final implant, I'm taking a trial. I'm seeing how my version is, how the screws are looking. I'm broaching and putting a trial broaching, seeing whether it's in the center, how the things are. And this is the x-ray which you get before you shift out the patient in the OT. And this is the final implant which you put. So you can actually check every step while you're doing an anterior approach, and you can get exactly identical results, especially when you're doing a bilateral hip. You can match the offset, you can match the horizontal and vertical offset, you can get the exact length, you can get perfect implant placement. And you can also see where your screws are going, you're not going intra-pelvic. So the need for robotics in THR, so why to change to a robotic DA when you're already a conventional DA is very good. So the main idea is to reduce the incidence of LLD. Some amount of LLD can still happen with the supine normal conventional approach. To avoid that, you can use robotics, and also the acetabular cup inclination and anteversion can be perfectly aligned when you're using robotics. You can also restore the global offset and the center of rotation of the hip, which you cannot do it when you're doing conventionally. And you can manage acetabular defects. You can also manage spinopelvic deformities. So this is very important. So robotics, this is the only robo which is available, which is doing a total hip with full implant placement, and also it guides you with the version and everything. So coming to three components of robotic THR, what is more important is the acetabular cup placement. You can exactly plan how much anteversion you want, how much inclination you want, and you can execute it to the T. So, so that's how it is. Robotics is playing a very important role. So here you see if you are impinging or your cup is anterior, you can push it more inside, you can medialize it, you can put it inside, and you can exactly match what you're desiring. And also what's more important is the stem anteversion and alignment. You can get the perfect alignment with the stem. You can see how much neck cut you want to do, and you can try and match your offsets exactly as you're planning. And one more important thing which you cannot do in conventional DA is you cannot check for impingement. While in robotics, it will tell you the exact location and at how much flexion and extension is it impinging, and then you can modify your plan to avoid impingement. So that's how robotics helps in making good things better. So also, what is more important is limb-length discrepancy. I'll be giving another talk on this with robotics, how it is important. And you can exactly match your plan, you can exactly match the opposite hip in terms of, you can get as close to a millimeter in terms of the limb-length discrepancy. So advantage of robotics is it helps in accurate placement of components, it reduces the chance of dislocation, and it also helps in restoration of global offset. So all these three are making DAs more and more comfortable for the surgeons and giving more accurate results. With robotics, you can also do DA in femoral rotation deformities, narrow femoral canal, varus necks, acetabular defects, dysplastic hips, and also you can do revision THRs. Thank you.
Thank you, sir, for sharing your expertise. Do we have any questions for sir?
I do have a question, Dr. Rohit. So you mentioned that for your regular DA cases, you don't use the special table, you just do the regular table. Yeah. Do you need to use a separate kind of table for the robotics, or no, is it straightforward?
So nothing will change, it's straightforward, because see, why was the need for using a special table was to extend the femur and hold it in the right place. But when you're doing conventional with a normal, if you do proper releases, you don't have to, and you don't need a special table, you don't need special instruments. You can do it with the routine orthopedic instruments and routine table, and you can still perform the TA. And similarly, as you're doing conventional, so nothing will change. Robotic, you just have to put in the pins and do a routine.
Right, so nothing changes from your conventional DA to your robotic DA in terms
only
of
the
position.
arrays, yeah, that's it, nothing else.
Thank you.
In which cases you will go back to the posterior approach?
See, it's never happened that I've started anterior, I'm struggling, and I've gone back to my posterior approach. So if I'm going to do a posterior, it has to be posterior right in the pre-op zone when I'm planning the case. So posterior approach is indicated for all complex cases like dysplastic hips, CRO 2, CRO 3 deformity, and also for patients who have revision surgeries. So you should avoid DAs in patients who are very morbidly obese, who have a huge pannus, BMI more than 30, 32. And also in patients who have very short neck. So the bigger the area between the GT and the ASIs, the easier the case is. So the distance from ASIs to GT should be good. If the distance is very narrow, then doing a DA, you'll struggle a lot.
Rohit, one of the problems with the DA is to get damage to the lateral cutaneous nerve of thigh. Yeah. How common it is? Because is it just on paper, or you really see that?
So there's a technique. So when you take a normal incision, the conventional DA incision, it is more anterior. So what we have modified it, we take it more posterior. So we don't go exactly between the interval of the TFL and sartorius. You go maybe a centimeter behind that interval, and then elevate the fascia. The fascia will protect the nerve, and you won't have any injury. So you go a little more far lateral than as compared to a conventional DA. Little more lateral, so 1 centimeter behind the interval, and you can use that fascia to elevate it and protect the nerve.
Thank you, Dr. Rohit. Yeah. Before we move on to the next session, I request Dr. Srirang to felicitate Dr. Bhaskaran and Dr. Adarsh Annappareddy. We will be moving on to the live surgery now. It is my pleasure to invite Dr. Param Nagpal and Dr. Ashit Shah to act as moderators for this session. Are we ready in the theatre?
Dr. Vaidya, can you hear us? Dr. Vaidya, can you hear us?
Dr. Vaidya is yet to join us, but we can hear you loud and clear.
You're loud and clear. So,
just a second, sir. Your set of moderators are just joining up.
Yeah. This is a 57-year-old female with medial compartment arthritis on X-rays, and scanogram also shows wear in the medial side. And it's a CT-based robot, as we have been discussing image and imageless. So CT has been done, and I have done my pre-plan. And pre-plan is just to go through one initial plan, but that doesn't mean that you need to exactly follow the pre-plan what you do in the theater. So you have flexibility depending on our soft tissue balancing. We can change the size of the femur, we can push up and down femur, we can do rotation, internal, external rotation. If you want to do mechanical, you can do mechanical. If you want to do an altered mechanical, up to you. You can all do all this on the table, not a problem. So now this is the pre-plan, since the OT is getting ready. So the process is do a CT. CT comes to this pre-plan gets loaded. After the CT, there is a process called segmentation, which has two parts. One is manual and one is automatic segmentation. Automatic segmentation is done by the robotic software itself. It takes about 40-45 minutes to do the segmentation. That's the best part about this system. The lead time is very less. We don't have to wait for 10-12 hours. Though even an image-based robot, the lead time is about 45 minutes. If you do manual segmentation, there is something called manual segmentation, where if there are osteophytes or more, or if there are any metal plates and screws in femur, tibia, or rods, somebody can do the manual segmentation. That takes about 30 minutes. So CT done, segmentation is done. Then we mark few points on the femur and select the femoral implant and do femur registration. This is like the points which we register on the bone and gets compared with these points. Then there is tibia axis points, tibia implant choosing, and tibia registration. So if you see, there are 4 pictures here: coronal, axial, sagittal, and 3D. This is the hip center. Next one. Then we see the knee center. The hip and knee center becomes our mechanical axis. 2 epicondyles we do. Medial epicondyle on the sulcus, lateral on the highest point. This becomes our TEA. Medial posterior condyle, lateral posterior condyle. This is for our PCA. And then medial distal and lateral distal. This is for the varus valgus of the distal femur. Once these points are chosen, we go for selecting the size. What we do is go on the axial section and up. In axial section, we see 2 things. One is how the implant is fitting on the anterolateral cortex. Is there a notching or not? Once you fix this point, then you go to the sagittal section. Then you see how your condylar symmetry at the back. Yeah, this is the posterolateral symmetry. Posteromedial, sorry, and then scroll back, and then the posterolateral. Once you are convinced about your posterocondylar and posteromedial implant configuration matching with the bone, then you see using this how much posteriorly you resect it. So in the posteromedial it's 8.7, posterolateral is 5.3. I have done a distal cut of the distal medial of 8.4 and distal lateral of 6.5. Zoom this. So what it helps me in CT is how the implant is fitting. Mediolaterally on AP surface, mediolaterally distal surface, turn back. and how the implant is sitting posteriorly, whether C is big for this amount of distal cut, whether B has to be done for this amount of distal cut, is there any metal overhang or underhang, it shows. Once you freeze this plan, then you go and do the tibia axis. So again in tibia you take the tibia center, and then you take the center of the ankle. That becomes your mechanical axis. So we don't do any hip rotation or malleolar marking in the system. They're all inbuilt. Tibial tuberosity and PCL attachment. This rotation holds good only if you are using the tibia sizing by yourself. And I do the tibial cutting, but the sizing I do and rotation I do. But these are all academic points you have to fill in. Then there are medial condyle and lateral condyle center. This is for the varus valgus of the tibia. Slope. Then you select a tibia, 3D, go to 3D. 3D, zoom the 3D. So you try to select it, rotate it, back. You try to select a tibia where you leave a millimeter or two bone at the posterolateral. This is the business area where your artery and vessels are here. So since it's an active robot, you can leave a couple of millimeter. But whatever you have planned, even in the plan, robot cuts 5 mm less than what you have planned. So it will never violate the boundaries what you have planned. Unlike the other system where it's a haptic based, this is a boundary control, bone movement control based robot. So basically, once you freeze the plan, now you go and mark on the patient's knee, the error of CT marking and the error of what you mark here, they show the error. If the errors are acceptable, you can go ahead with the gap checks. During the gap checks, you can do all your multiple permutation and combinations where you can change the femurs if you want to downsize. If you want to increase the flexion of the component, you can. If you are a mechanical guy, stick to distal cut and tibia at 90 degrees. If you are altered mechanically, you want to give a couple of degrees tibia slope, tibia varus you can give. 1 or 2 degrees of distal femur varus also you can give. Now the OT is set up. This is how the OT setup is. And the robot comes on the side of the operating. So if you see, I'm operating a right knee, the robot is on the right knee. And this is the navigation camera, which will capture the knee anatomy. The saved pen drive is already loaded on the robotic software there. So whatever I'm going to mark now is the native femur and native tibia. I'm not going to create any 3D imaging of this because already we have loaded, 3D has been done, it's loaded on the system. And basically whatever points I pin in on the patient's knee are the same points which are generated through the CT scan. So I'll start marking now, okay? So if you see, it's a midline, I'm a medial parapatellar arthrotomy guy. So medial parapatellar arthrotomy, some meniscus removal in the anterior surface on the medial and lateral meniscus. And then the knee looks small, so either a size C or a size B should be the way about. So there are 2 pins. One is the femoral pin. These femoral pins are put on the metaphyseal area. Okay, it will come and you go that side. No, wires will be there. You go that side. So these are the metaphyseal. So the 2 metaphyseal pins. Initially we used to put it here, but since I've been navigating for 7-8 years, I don't mind putting in the diaphyseal region. Even if you put in the diaphyseal, just see to that you are not transcortical. Either you buy a 3 cortex, the 4th cortex should not be violated, be in the center and you go in. Never do an anterolateral to posterolateral or a posteromedial to anteromedial. So that is transcortical pins you don't put. Tibia is about 10 centimeter. If you see the tibial pins here, in a navigation, I was to put like this, but you see in the tibia, niche dikhiye. The pins are a little bit directed caudalwards because I get this room for my robot to play around. Okay? So now, this I start marking the knee now. Some registration points. This is called initial registration points. Then some points on the femur. Then some points on the registration of tibia. Then tibial registration. We know the errors of marking. Then using our numbers, what we have loaded on the software, it shows a gap check at 0, 30, 60, 90, 120, both medial and lateral side. Okay? So let's go ahead with the marking now. Yes, please. Yes, please. Yes, please. Yes, please. Yes, please. Yes, please. Yes, please.
Chandrashekhar, good morning.
Good morning.
Dr. Ashit Shah from the hall.
Yeah.
So these points that you are marking are fixed points, or it can be, a little different from what?
Back. No, they are fixed points, but you want to add some points, you can put it on the software and that's it, no problem.
So typically described in this system, the femoral areas that you put are from front, from quadriceps. But now I see that they are going on from the medial side. Would it not come in the way of burr because it's a fully automatic?
Yeah, that's what initially we start. Yes, please. So it is initially, I'll just come through. Yes?
Okay.
Yes, please. Yes. Yes, please. Yes, please. Yes, please. So what I do is, if you see the screen, the initial RMSE is less than 2.43. So for initial registration, it has to be less than 10. You can see what you have marked. Blue is yours, orange is CT, blue is yours, orange is CT. And these are almost in one plane, the epicondyle. That's the beauty of these robots, because the epicondyle marking can be perfect and you can cross-check what you have marked. And medial lateral epicondyle, see, they may not be touching each other, but if they are in the same plane, that's just the justice. So once this is done, now we go for the final marking on the femur. Go ahead now. Yeah. Yes, please. Distal medial. Wherever cartilage pierce it, yes. Wherever bare bone touch it, yes. 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 Now I am doing the trochlear surface, yes. 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 Now medial over distal lateral. Now I am piercing the cartilage because it's an unaffected medial side, unaffected lateral side. Yes. 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 Now I am doing the medial intercondylar notch. Yes. 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 Now I am doing the lateral side. Yes. 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 Now I am doing the medial side of the femur. Yes. 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 Now I do the anterior surface of the femur. Yes. 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 Sorry. Wait karo beta. Yes. 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 Now all the points in the, yes please. All the points on the femur are marked. So if you can see down, my initial RMSE was 2.5. The final RMSE root mean square is less than 0.52. Acceptable less than 1, 0.5 is a good luxury to have. Coming to your point, previously we used to do the pinch on the diaphyseal side, but now we are switched over on it. Just that some degree of understanding that how the pins and how this has to be faced so that the robot doesn't come into the picture. It took us about 7-8 cases to switch over, but now most of the cases we are doing with the pins inside the wound. Okay. So now, yes please, these are verification checkpoints. No need to put any buttons or anything. Yes, we don't need any extra button pieces on the femur and tibia. These are just checkpoints which are free. So once you move the leg from extension to flexion or any range of motion occurs, you can just check these points. Other parts are automatically calibrated. Now I go for the tibial registration, please. Yes, please. Yes, please. Yes, please. Yes, please. Yes, please. Yes, please. Now I see my RMSE is less than 10. The 2 points which are very important to me is the medial point, lateral point. If these 2 points are in the same plane and almost depth comparable, I am okay. If there is any variation in the depth, slight varus valgus changes can occur. So be careful with these 2 points. The other 2 points are okay. They are just boundary creating problems, nothing else. So there are no further signs on that. So let's go ahead and mark the more tibia now and then see the RMSE of the tibia. Yes, please. Yes, please. Yes, please. Yes, please. Yes, please. Now medial tibia is down. Now intercondylar, interspinous. Yes. 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 Second one. Yes. Retry pa. Retry the 3 points. I didn't see. Retry it. Yep. Retry. Retry. Retry again. Okay. Yes, please. Yes, please. Yes, please. Yes, please. Now the lateral. Wherever the bare cartilage, I am piercing the cartilage and never violating my bony marking beyond the bony surfaces. If I end up putting this pin in this probe in the soft tissue, then it will go to the soft tissue. So I don't think so anybody will violate it. Yes?
Chandrashekhar, if there is a large defect on the tibia medially for a varus knee, how will you mark these points?
Yes. 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 You can take the lowest mode point and mark it, yes? 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 Just remember what you have marked on the CT points, registration. You just have to get the same points. So if you feel there are some defective or bad tibias, so whatever you mark there, registration points, gets compared here, so you're safe on that region. So you know the depth what you have marked, where you have marked. Yes, please? So that's why initial registration points are always important. Yes, please? 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 Yes, yes, please? Yeah, yes, please? Yes, please? So now all my tibia markings are done. Ramesh is just showing more than 1.2. 1.2 is fine. We can take it, not a problem. If you are very clear, you can remark it, not required. Best registration. Yes, please. Yes, please. Yes, please. Now we go ahead and check the gaps now. So now the screen is generated. So it's a varus of like 6 degrees in extension. I'm just giving a valgus stress, still opening about correctable to 2 to 3 degrees from 6 degrees. If you see the chart now, internal is 0. That means for the TEA, my rotation is 4.2. My TEA for the rotation is 0, but for the PCA, I'm at 4.2. That's what I have done in the pre-plan. I have kept the distal femur at varus. That's I'm following a mechanical philosophy. I have kept the component at 2 degrees flexion, and C femur is what is shown. That's the top screen. Then come to the second screen there, 6.5 and 8.4. 6.5 is the lateral, 8.4 is the distal medial. So distal lateral and distal medial. And then tibia proximally lateral 6.8, medially 1.7. So using this gap, it is generating 6 and 3. 6 and 3 is 16 plus is and 13. That's what we calculate, add 10 to this in this software. And I usually give couple of millimeters to the existing thing because we have pierced the cartilage and taken the gaps. So I give a 0.5 on the femur and tibia cartilage, and then I give 0.5 for the burr in both on the femur and tibia. So if I'm planning somewhere around 7 gaps on the lateral side, it is 7 plus 10, 17 plus 2, 19. If I'm thinking of 3 or 2 on the medial side, it's about 3 plus 10, 13 plus 2. 2 for, 1 for the cartilage, 1 for the burr. So now capture knee. Okay, now let me see at 30 degree. It's a varus knee, simple knee, 5 and 3 again. Now the gap is again 7 and 5. It's almost a balanced knee by itself. If you see full range of motion, it's completely varus through and through. And the gaps also, if you see, is not touching, changing more. It's about 6, 6 or 7, 7 like that. So now once we do this, so we know how the knee behaves, whether it is varus or valgus in a coronal plane. In the sagittal plane is almost a neutral knee. It's a 0 degree flexion extension. No capture. So if you see now, this is option 1, where extension medial, if you see the down corner is 3, extension lateral is 6, flexion is 5, and flexion lateral is 6. So as I told you, we add 12 to it, 10 for the space, 2 for the burr and the cartilage. So basically we're looking at 18 on the lateral extension, flexion lateral 18, and flexion medial 15, and extension medial 15 and flexion medial 17. I think it's all a pretty balanced knee. I don't think so I need to give any varus to the tibia because I'm still not accounting for any of the small osteophytes left. So I won't like to go ahead with the plain mechanical alignment because this fits in very well. There's not much deformity on the tibia. So no need to give any varus because by giving varus, I'm going to loosen the medial space. Already is well balanced in flexion and also in extension. So the plan in this case is we are calibrating the unaffected side and making it equal. So my philosophy is, for example, if you have a 5 to 10 degree of flexion deformity, I keep my extension lateral 1 or 2 more than the flexion lateral, okay? And since I'm doing on the lateral side balancing, it's nothing to be bothered on the medial side. You have complete control. If you're a mechanical guy, you can remove the osteophytes, you do the soft tissue titration at the end. The beauty of this, any robotic system is it gives you the prospective vision, what you will feel like without even cutting. And I keep my medial tight because I can always come back and do the releases if required or just the osteophytes removal. Number one. Number two, if I feel in the CT, the B was sitting better, or if I feel here also the B is sitting well, for just academic purposes, I'll change the implant to B. Go to implant B, change the implant, femur implant. Implant size. Make it B. See, once I make it B, automatically all the parameters of the flexion changes. Now it is 19 and 18. And if I see my extension, capture this. Finish and capture. Yeah. So it is almost, Inga, he said. Yeah. Check now. Check now. Yeah, 16 and 13. Check now. Capture. Since I downsized only the flexion increased, the extension didn't increase. I can, if I am rigid at putting B, because my posterior condylar was good both in middle and lateral side, then the play is to go ahead and increase the distal mm by 1 or 2, and then flex it for another 1 degree more. So flex the component by 1 more degree. Femoral implant. Shift the implant. Shift distal 1 mm up. Okay, now come down. Finish. And now go to the femoral implant again. And if femoral rotate, give a degree of flexion. Yeah. Yeah, check now. Check please. Check. So if I'm putting B now, these are the changes I have to make. Yes, please. So I think I'm balanced on the lateral side. Even if I want to go for B, it's fine. And since as I've told you, 8 is 18 plus 2, 20. So I would like my tibia to cut 1 less. I don't want to go for a thicker plastic. Plan is at least a 9 or 11. Tibia 1 mm up. Yeah. Yeah. So I made tibia 1 mm. These are my intraoperative changes I did. I increased my distal cut by 1, flexed the component by 1. I changed from C femur to B femur. Then I did my less resection on the tibia, and these are my gaps, 7, 7, 7, and 4. So basically, I may be looking at 11 plastic. So now once these numbers are there, next please. If you see on the screen, yes please. There are 2 ways, full surface, yes. So if you want to do all your surfaces cut, femur, tibia, robot goes to the side, you know you have kept your medial side tight, so don't bother. You will always have some leeway to play. Manage your lateral gaps. Medial releases you do as per your calipers or as per your spacers or as per the trial implanting. If there is a need to release, you can do. Next, back please. You hold this thing, extension surface. See, in extension surface, the beauty is, suppose somebody comes up with a 20 degree FFD and a 20 degree varus, and it's just little bit you're not comfort to do the all resection on femur and tibia because you're not accounting a lot of osteophytes. In this case, you do your distal femur, proximal tibia, put the knee in extension, release all the extension osteophytes posteromedially, then put the knee in flexion. You can take a prospective oversized femoral component cut. For example, if you're planning EF, take a G posterior, that's it, only posterior. Know your gaps everywhere, then you can tell the robot to come and play it. Once you do the G femur, you can always go and do a lesser size. Like F, you can come back and do. So all these options are there. The present robot, this is called CUVIS 150. They also have something called guide hole technique. So there are 3 things you can do: full surface, extension surface in difficult knees, and then there is something called guide hole technique, because some of the surgeons have expressed their concerns that they are more happy with saw than the burr. So for them, what the newer things, what they are getting is probably it should be there in a month's time. So they are going to put your distal 2 pins, the robot marks distal 2 pins, anterior referencing 2 pins, and then the tibia 2 pins. You do your distal cut, tibia, anterior referencing pins are there, play the game as you require. So this is called guide hole technique or express pathway. Probably in a month's time it should be launched in India, and Korea is already launched. Okay. So now since it's a simple knee, Dr. Ashit, I'm planning to go ahead with the full surface. Okay? Am I audible, guys?
Yes, very well.
Very well.
Yes. You are able to see very well.
Sometimes silence, like, am I audible or not? That's what I was thinking.
So what is the role of that pump, that hydraulic pump that you're going to put? How does that distract? How much that distracts? Is there any measurement for that? How many pumps you have to put?
See, only in tough knees, for example, where the gap between the femur and posterior femur and tibia is less, okay? In that cases, this amount of pumping is okay. But since you are doing the femur, once the femur is there, automatically the tibial space is done. So the amount of pumping is not required in every case. But since you do the femur first and take out the posterior, so I'm putting 2 pins. This has been also a huge discussion, like why should we put a pin? These are all metaphyseal half pins. I don't think so. It's not a source of any concern. There are 2 ways of putting it. Either you can make a small window here, and don't make a small stab knife here. Either you can make a small stab knife, palpate the fibular head, tuberosity, go in the middle. It's a triangular bone. Try to aim parallel to the fore. Just aim posteromedially so that you buy more bone. These pins, whether they're parallel or not, doesn't make any difference. Just are fixing pins. So, okay. If you are preparing the keel by the robot, then see to that you put the pin little bit down, because if you are putting the keel. If you are not using the robot for the keel, as close to the level of tuberosity should be fine. So these pins may not be parallel, they're just a fixing pins. Now I'm trying to connect the robot to the patient's body. I've just told the robot, dear, this is what the CT scan marking, this is what I did. You are all sync, you are happy, I am happy, I'm happy with my balance number. So now execute what I want. So it's basically, it executes what you want. There is nothing like robot knows everything. Robot just gives axes and planes, but execution and understanding of the robot is by the surgeon, and gap balancing, changing the numbers, robot will never say. So if you see, one has to go for the screen, darling, one has to go for the screen. This one, yeah. It's running, separately it's there. So if you see on the screen now, the screen is very important. It's called robotic approach, okay? Table up, please. Yeah, up. Yeah. So all the lines to be illuminated. All the lines illuminated meaning they all know to each other where they are, okay? And now I'm locking the robot. The robot is locked now. So before I tie the robot to the patient's body, I see my 4, 7, they're all illuminated. See, if I block the tibia is blocked. If I block the femur is blocked. If I block the robotic marker, the robotic, that's just, you have to be in circles, superior workspace, top and side view, and then RX, RY, they're all bony positions of the femur and tibia. It's just that the arrays are meeting each other, they all know each other what they are. Now you make the robot static and connect the robot to the patient's body. If you are very worried about these pins, according to me, I never had any issues. These are metaphyseal small pins, not even violating both the cortex. So if you still are paranoid about the pins, I've heard some surgeons are very, very paranoid about the pins. You can always use the clamps. From me, this has worked well. I never had any issues. Next. So we go to the next now. I think robot. Next. Yes. This is just the calibration of the checkpoint. Now we go ahead with the femur resection. Okay. Wires, be careful. Huh? So now we start off, since we moved the limb, there are no transfixing or verification pins. They are just the pins which are placed, and you just have to be less than 1. Yes. They are the blue bubbles. See, now if you see, there is already a path which is done. You see the yellow boundary there. That is the path. How did the path came? It's not a haptic based robot. So the plan what I have done in the CT to the implant what I have chosen, automatically an arc and path is done. So CT based marking plus CT based and also we go and mark it. So these two gets compared, and with the implant what we have put, down, reduce kariye. So now we are cutting the distal femur. So distal femur, as per my this thing, if you see on the right side of the screen there are something called ML, AP and SI. This is the cutting position monitoring. So if there is any violation, mediolaterally more than 5 millimeter robot stops, anteroposteriorly 5 millimeter robot stops, side superior and inferior robot stops. So this is the basis of the safety features of this robot. Boundary is already created. If you see an yellow boundary, the robot is within the yellow boundary, and this boundary is created based on the CT finding, CT what I have marked and what I mark on the patient's knee. Until unless you don't mark the right knee in the right points, like you are arrogant and mark anywhere, any robot can be unsafe. So if you mark the right points, the intelligence of the robotic software is such that it picks up the right pathway and it works within the pathway. So now you see it's cutting distal medial and distal lateral. If you see all the process there on the screen, there is something called distal, anterior chamfer, anterior, posterior chamfer, posterior box. All can be maneuvered as per your needs. If now for some case you want to do a distal femur and then want to do a anterior chamfer anterior and go to a tibia and then balance extension, balance the knee in extension, then come back to tell the robot for 4-in-1. All up to you, all up to you. Either you can balance the knee from flexion to extension, extension to flexion. I'll just follow the mid resection, up to you. I will follow the extension to flexion for flow. That's up to you. So it's compatible for it. In difficult knees, I would advise probably do with the extension to flexion balancing. Nibbler? Nibbler, ma'am. So now distal is done. Now we go ahead with the anterior chamfer. I didn't give any mechanical varus of 2 degrees to this because it's almost, I may not require much releases. Maybe a couple millimeter tight on the medial side. With the sizing of the tibia, we should be able to get away. Even if you are doing an adjusted mechanical, I do in about 10-15 cases, I never ever make my medial space equal to lateral space. I still keep my medial space tighter than lateral in a varus knee because I am accounting for the osteophyte and the sizing of tibia. So instead of making a 20-20 space, if 20-10 is there in a mechanical alignment, 20 on the lateral, 10 on the medial, by adjusting the mechanical alignment with couple of degree varus and femur and couple of degrees on tibia, you can get it until 10, 2014 or 2015. But keep 5 as a leeway for your releases or for the osteophyte or sizing of the tibia. Okay? Yes. So now anterior chamfer, again you see it's created a yellow boundary there. So anterior is done. Now it's going for, anterior chamfer is done, it's going for anterior. For some reason, after you do the anterior cut, you feel that, oh, I'm a bit way higher anteriorly. I need to get my implant down. You can do it. See, whatever you want to do in terms like once you cut more, nothing can come back. Whichever conventional, robotics, navigation, yes. If you cut less, the system as it, you need to calibrate automatically the other points. Think that I do an anterior chamfer, anterior cut now. I feel I can go 1 mm down. The moment I shift the component down, the only option I have left is to shift the component down. I can't shift it up because already cut is made. I can shift it down. Automatically your flexion space also gets calibrated for a lesser cut. So now the boundary is formed. Unable to detect. Sense. Start. Yeah, resume. Now the sequence what I followed is the simple one which I do every day in the OR, distal, anterior chamfer, anterior, and now we will switch over to the posterior cut. Okay.
Chandrashekhar, being a fully automatic system, what are the safety features at this stage? You think that there is something going wrong, you can stop the burr?
Yes, yeah, you can just give the command to the person who is holding, they can stop it immediately. And if there is any movement of the patient, for example, patient does a violent coughing, the robot autopilotly stops. If there is this very bad sclerotic bone and you feel the pressure required for the burr to clear out the bone more than 5 newtons, the robot automatically stops. So it stops by extra force, it stops by movements, and already the boundary is made. If you see the screen, all the cuts, now it's going for posterolateral chamfer, already the boundaries are made. How did the boundary occur? With the implant what I have chosen, with the CT feedback, plus what I have marked, it is given. So there is nothing like you throw a garbage in and you expect a sweet out of it. So at every step, whatever we do in conventional, same precautions has to be taken. And if you are trying to mark way away and trying to check a robot safety, then robot doesn't do anything. We have to mark it well. And yes, no, I don't think any surgeon will mark erratically so wrong. So robot will show if you have done an erratic marking wrong. Especially on the femur, always try to be less than 1. So it's always getting married to what you have proposed. And then the life is easy.
Hi, Dr. Chandrashekhar. This is Dr. Nagpal.
Hi, Dr. Nagpal.
So, how long did it take for you to trust the robot and let it do what it is doing without any retraction? So, what I see the beauty of fully active robotics is that you do not need to retract any soft tissues at any point of time.
So the best part, Nagpal, is the femoral pins which are placed on the medial side. They also act like retractors to me now. So I don't need to ask anybody to hold it and do it. And you see in every cut, some bony island is left. Can you see the bony island?
Yeah.
So if you see now, the bony islands are left. Yes, when I started doing it, I was a bit skeptical to do this measured resection technique. I was always trying to do balancing flexion to extension to flexion. But now, over like 1,850 surgeries, I know measured resection is just a prospective planning of what you do. It can have a 1% error in whichever system you choose, but be humble, be gentle, accept it, and then if you feel there is a tight as a surgeon, please. See, robot helps you to get the numbers, but the feel is always a surgeon.
Doctor, do you feel any problems when this lug holes are being made or medial and lateral problems anytime? Do you feel sometimes it is exact the point which you want, or you feel sometimes it is either 1 mm medial or lateral?
It's a very good point, Dr. Nagpal. What happens is, especially when we change the size from, we just have to, when you go in the pre-plan, when you are doing it, think that if your size put C and you are happy in the boundaries and you go for a size B, just also see in the pre-plan whether the lug holes, when you change from size to B, has also the same mediolateral fit. The best part now is, Dr. Nagpal, in the next software, you can change the position of the lug holes mediolaterally. They're in the same plane, but you can change it. Suppose for some reason you are quite busy and then you didn't see the center of the holes and the implant symmetry mediolaterally well, you can abort this step, but in the future softwares, what they are adding is, they are also trying to add the mediolateral change of lug holes on the table. For some reason you feel that you are not center, you can change it on the table, but as of now it's not there, it's going to come with the future robots.
Yeah,
that's also the changes which we discussed with the R&D team from Korea, and they're okay to do it now. I think they might have already done
perfect,
it.
Yeah. That would make it perfect, yeah.
Yeah, if for some reason you feel you're not happy, see, spending all the time and doing a precision, you just can't have a mediolateral implant which is not fitting at your choice, right? So everything matters, every millimeter matters. Now the femur is done, I'll just remove the bony islands. Can you nibbler kudama? Can anybody give me a small spade, step? You have big nibbler, ma? Can you give a step? Big nibbler, ma? I'll just take out some of the bone now, and since it's in a position, so I'm taking the medial side, or I can do it later also, not a problem. I'll just see whether there is a space for the tibia to cut. That amount of bone I'll just remove. Okay? I think we should be able to go ahead with the tibia now. Tibia? Probe kudapa? Don't touch. So now go with the tibia. So just touch the bubbles. Don't have to kiss each other, but just touching is fine. Yes? No. Yes, pa? Okay? Dheere dalna beta. Idhar dalna. You can continue, please. So if you see, all the medial cuts are made from front to back, anterior to posterior, and all the lateral cuts are made from side to side, because to take into account the patella tendon and the patella. And tibia also, if you see, it's cut into two halves, medial half and lateral half. If you see, the moment it enters the tibia, in the mid tibia, the pathway reduces and shrinks. That is to accommodate the soft tissue issues. Saline, please. So again, it has formed a boundary. In every cut there is a boundary. So, and if you notice, within the boundary it cuts 5 mm less than. So, safety over safety. There is double safety, because it's an active robot. It's better to be actively, it has to be more safe. So, you see, at every level the safety points are there. So now once it is done, just wait for a second, pa. Just give me a small human, a radius human, or a small human. Where is it? Yeah. Recovery? It's coming, means it's okay. Do it off. So now, this is the most important question asked by the surgeons, who are is it who wants to go into active robotics? The first thing they think is it unsafe, because the burr is going blindly, and and there is nothing in the posterior. So when we plan itself, we leave about 5 millimeter of bone, and that's enough, and it will never violate it. What happens if it violates? The robot automatically stops. Saline pa? So just now you see the motion on the screen, the robot is going from anterior to posterior to anterior now. Now it goes to the posterior now. This is the business area now when it goes posterior. This is the area you have to be a little bit concerned, just lateral to the PCL, maybe just lateral meniscus root tear or radial tear. That's the area where anterior posterior root, that is where your vessels are there. But as we have already discussed and seen in many studies, there is at least once the knee is in 100-degree flexion or 110 flexion, there is sufficient amount of capsular laxity and the vessels are actually thrown out of this thing. It won't come to the bony side at all, but even then be careful, you have one chance. So try leaving a couple of millimeter of bone, you see posteriorly now. Even in the patella tendon in small bones, I use this retractor. Most of the time I don't use. Wait. Just 1 second. Okay, continue. Gauze piece. Gauze piece. The tibia marker I think was just blinking. Yeah, resume.
Any questions from the audience? Feel free to come on the microphone, please.
So now all the cuts are made, Dr. Ashit. Now, if I keep these 2 pins, I can still call my robot. For some reason, both my flexion extension tight, get a couple of millimeter tibia cut. If you feel that your extension is tight and flexion is lax, you can call the robot for a distal cutting. But as I've told you, any system where we are trying to match the unaffected side, so you'd have to have at least 1 in 200 cases where you may feel that there's a mild flexion extension mismatch. Be gentle, you are the surgeon, you are the boss, you can always call the robot, or if you feel for a 2 mm, my cuts are already done, my rotations are already fixed, I would rather do a conventional instrument and put it, that's up to you, because all the cuts, everything are made. So ultimately you should be happy as a surgeon, and numbers are just to objectify and let you know that you have done well, but also you have to feel the soft tissue by yourself.
Right, okay.
So now, so now I am sending the leg holder back because I don't need it, and I will also pull out the robotic pin, this thing, hold it now, because I'm removing these 2 pins now because I don't need it. So when I see the gaps here, I feel for a 9 or 11 mm, we are through, not a problem. So I don't think so I need any extra cuts. Give me the pin to remove it now. Give me the pin puller. Beta, up is taraf aate beta? You will come this side. Okay, you'll come now. Is the reverse, ma? It's in reverse, na? Yes, sir. Yeah. Le beta. Reverse, na? Yes, sir. So now I'll remove all the remaining bones. Just be careful a bit. Yes. Because I have to show the last numbers. So now, Homans, please. Yeah, well done.
So we can very clearly see the margin of the bone.
Yes.
Both on the posterior femoral condyle and on the tibia.
Nibbler, please. Yeah, thank you. Nibbler. So I will just remove all the remaining island of the bone and then probably show you the trial and also show you the numbers, and then once, if you are guys in, then we'll do the sizing, or you can proceed with the conference. But let me show you the numbers first.
Yeah, we need to go to the other room. So, once you put the trials, we'll have to
yes.
disconnected.
I need 3-4 minutes more, not more than that. Osteotom, please. Straight osteotom, beta. Yeah.
So
Gap check karna hai.
Dr. Chandrashekhar,
yes.
How do you think this robotic is better than the conventional in your hands? Like in case of soft tissue handling, or maybe you're not dislocating the knee when it is tight. So how do you think, what is different from a conventional when you are doing this, other than the gap balancing?
One is we always tell that we always are worried about the couple of extra pins what we put, but you also imagine the conventional instruments. You have to pin either distal cut, you have to pin for 4-in-1, you have to pin for a tibia. In that way, the number of 1 or 2 pins extra, it just gets nullified. The discussion gets nullified because you are not using any of the jigs here, number one. Number two, there are very subtle knees. Sometimes it looks, see the whole prospect is the rotation is unique because you know your medial, flexion medial spaces. You can play the rotation. You know you don't have to stick to 3 degrees at all, number one. And number two, if at all you feel that you need to give more rotation, you can give. Second. Third is something like think after 5 years in the room there, we all coming to a conclusion and then say, altered mechanical way is the way to go. Okay? Split open please. And do you think in a conventional instrument, it's easy to give a couple of degree VRS? Why take a stress, allow the robot to do? We can't manage those 2 degrees and do it. So that's one thing. Second thing is, please. So if you see some bone is already left posteriorly. Can you see here? So this is the PCL attachment, this is the posterior here. Okay? So just try this, nibble off. And again, for the critics who say that, oh, why are we doing this? There's a validation probe, you can check your cuts, not a problem. Okay? Suppose for some reason you start switching over to altered mechanical, giving 2 degrees manually versus 2 degree sizing, size 1 or 2 is more easy. Yeah. And next important thing is you don't violate the medullary canal at all anytime like navigation. So especially if you are a bilateral surgeon who wants to do regular bilaterals in 70 plus, I don't know that we need to come out with a big and huge data, but I feel it's good because you don't violate, and that violation is not a small violation. The next question is, you can play the sagittal offset very well. It's very difficult in a conventional instruments to give 2 degree flexion, 1 degree flexion. All those are not possible at all. Being that such small games, you can fit in the best femur in. See, after I started the robotic, my femurs have become much more accurate because I know the CT before, and at the same time, see either you have two options: manipulate the bony cuts for the soft tissue, or manipulate the soft tissue in such a way you get the best metal in. So you are the boss. Like for this, if I wanted to keep C, I could have kept C femur and worked more on the tibia. If suppose I knew that it was B, that's why I reduced my tibial cut. Because you have all your posterior-condylar offset, you have your posterior-medial lateral, how the implant geometry is, how it looks medial-laterally. Not all knees are 100% AP and ML matching. Some knees are AP bigger, some are ML bigger, and some are symmetrical, 50 knees. But these are the type of things which has helped in terms of placing your femoral component well. So now we are just removing the remaining osteophyte.
Chandrashekhar, in the cutting sequence, there is this thing to prepare a keel of the tibia also with the robot.
Is there, but for that you need to size it perfectly well, doctor.
So why would you not use that and go instead manually?
No, that many of my Korean surgeons are doing it regularly. It's just that our bones are a bit osteoporotic. Sometimes it's better to keep a couple of millimeter posterolaterally. But I had curved osteotomy. I had discussions with my Korean colleagues. They say, we also know that once we bend the knee, there is sufficient capsular laxity at the back and the vessels get moved away. So I did about 100 caliper. I did about 150 cases with the keel. But what happens, doctor, is once you, suppose for some reason, tibia shape, you change from 4 mm, you decide to go for 7 mm, then the problem is what you pre-planned may not really hold good because the bony anatomy changes. So for that also, what we have done in the next softwares which we are getting, the R&D thing is, for example, I do my 7 mm and on table I decide to go for 4 mm, I can go back to my pre-plan and see, and on the table, now they allow to move the tibia anteroposteriorly ML. So that's also done. So you can definitely do the keel, not a problem. Or if you are very worried, we are planning to make the tibia into 3 half, middle 1/3 and lateral, middle 1/3, lateral. So middle 1/3 and middle 1/3 you can do the keel, then do the remaining. So keel is very important because it gives the perfect rotation. So you don't have to eyeball at all. So the ways to do it, these are some of the R&D things which we have discussed. I think they all should materialize by the year end. Okay. So now if you see the gap, I know you might be thinking like my pressure on the arms may not be equal on both the sides, but yes, we need some sensors which can assess the gap independently without the surgeon opening up. But it looks good. It's 2019 as planned. So maybe I think we are going in for a 9 or a 11 plastic, that I'll see. So now give me the number.
So that reads what, 9?
Yeah, maybe 9 plastic kare. So again, it's about the same what we managed, 20 and 19. So we are good to go. Yes, I can definitely, there should be some doubts on the floor. So how do I know how much pressure Dr. Chandrashekhar has given on both the sides? But anyway, once we put the trial, we know it. Trial, please. 9 poly and tibia. Okay. You open the implant, please, and start mixing the cement, please. Yeah, okay? So, oi, sir. Is there fun? Check now.
Yeah, can we?
Can you see the gap? Make that screen bigger, please. Make that screen bigger, ma. Can you make that screen bigger?
Yeah, we can see the screen. 12, 12.
12, 12 is there. So RS is 0. Yeah. It's about 90-degree flexion. It's 12, 12. And now I keep at 70 degree, whereas 1 degree, 12 and 11. I'm okay to have a mild 1 mm leg laxity on the lateral side. Again 12 and 1, 12 and 11 at 40 degree, 1 degree whereas. Then you go deep 18 and 2. And now, as we were discussing, I think yesterday, every system, when they show the FFD, sometimes some systems show 5 degree less, 5 degree more, but here it is completely neutral. Okay? So if you see, it's a well-balanced knee, and this is the anterior-posterior toggle. The toggle is not much, maybe 1 or 2 millimeter toggle, that's acceptable. And if you see the knee, can you somebody show the side view, please? Yeah. So, right, yes. It looks completely knee and it's a supple 1 or 2 degrees. Yeah. I think it's okay to me. It's about 3-4 degrees it's showing and 1 degree varus, and numbers are balanced well. Guys, if you want to continue.
So one last question. In a severe varus knee where we have a lot of tibia defect, do you find these numbers not matching exactly in such cases because...
Release. If the middle side tight is there, after doing 3 degree of varus, then also if there is a tightness, then release is a better option.
No, sir, the numbers, sometimes in a varus case, when there is a tibial defect, we find that the 0 stays a 0, even if it is like 4 to 5 mm defect. But once you've done all the cuts and released, somehow the medial side, even if it is tighter, shows a bigger number than the lateral side. Have you faced such a problem anytime?
Bigger number on the medial side is not a good thing, because then the only other way is to...
But clinically you feel it is still tight.
Yeah.
But the numbers that the robot is showing...
Yeah, sometimes because the holding position also matters, doctor. Like, just like varus, valgus, if I change little bit, the numbers change accordingly. See now, I'm putting in external rotation, it's normal. I'm putting in internal, it's coming 12 and 11. So, if there is a variation of plus or minus 1, I'm okay. If lateral flexion is 2 more than medial flexion, don't bother. If medial flexion is 2 more than lateral flexion, maybe you will have to use a caliper, check it with the same pressure, and then if you're comfortable, you can go and implant it. Am I clear?
Yep.
Thank you very much, Chandrashekhar.
Thank you very much.
It was an excellent demonstration and a different system with very good balance. So give him a good round of applause.
Thank you, guys. Thank you.
Thank you very much. Unfortunately, we have to go ahead with the other program.
Yeah, please. I'll cement it.
Thank you.
Thank you, so much. Before we move on to the next session, I request Dr. Narendra Vaidya to please felicitate Dr. Sunil, a member of the Maharashtra Medical Council. I also request the moderators to be seated to chair the next session as well.
Good morning, Dr. Shubhang.
I request Dr. Ashok Kumar and Dr. Srirang Godbole to co-moderate this session.
Hi, Dr. Shubhang. Good morning. Dr. Nagpal here.
Yeah, hi, morning.
Can you listen us?
Yes, I can hear you.
Yep. Just let us know what stage you are on, what you're doing.
Dr. Shubhang, Dr. Ashit Shah.
Yeah, hi.
Hi. So, just take us through the...
Yeah, just a minute. No, you need to drill it. Drill दे सकते हैं? It's 3.2 ka bit. Okay, so the patient is a 63-year-old male. We are doing the left knee. We are going to use an Anthem PS implant. Can you hear me?
Yes. Very well. Yes. Very well.
Yes, so clinically he had a deformity about 10 degrees of varus and 5 to 7 degrees of fixed flexion deformity. Where varus is almost fully correctable clinically. So we've exposed the knee, standard medial parapatellar approach. We've removed the meniscus on the medial side, and we are just putting the pins for registration. So the bone is extremely sclerotic here, and we are just going to make one entry point for the pin. Yes. Okay. Pin, please. Okay, it's a little, it's probably come in the way. We remove this, put it more medially. Remove it, yes. Sleeve. Hold this. Yes. Okay, that's it. So coming to the tibial side, just hold it here. So like everybody's been telling you, 4 finger breadths from the joint line. I like to keep it a little inferior because the Smith & Nephew keel is a little longer than the others. So we just make a mark down to the bone. Hold it.
So these are essentially bicortical pins, or you just
No,
hit
this is a unicortical pin always.
and you go all the way up to the opposite cortex and just touch it, yeah?
Yeah, actually, you cannot really get that tactile feedback if it has touched. So the bone is usually sclerotic. So you just go about 5 to 6 millimeters, and that's what I look at. So one pin is in, the other pin can serve as a reference to that.
So Dr. Shubhang, since you shifted to robotic, has your psychology changed from mechanical to adjusted mechanical to kinematic or adjusted kinematic?
Yes, so these are very big names, and it takes a lot of time to understand what you are actually doing yourself. So, you know, most of us end up doing what we call a functional alignment. It has definitely changed. Can we see?
So what are your boundaries, like how much of varus or valgus do you play with?
So I generally don't like to give any valgus. Maximum 2 degrees of varus on the femur and 2 to 3 degrees on the tibia.
So a collective varus of up to 3 or more than 3 as well?
The limit is 5, but I've never done that. Okay. So if you see the screen, we are going to collect the joint laxity. We are using the PCA as our guide. Okay, so can you put the camera a little towards the tibia? Towards the tibia. Tibia. Yes, a little down, please. No, Amit, आपको हटना पड़ेगा. थोड़ा सा ट्रॉली को इधर कर लो. Is it okay? Okay, seen throughout now. Can you adjust it towards the femur? Yes, okay. Okay, right. Next step. Checkpoints, please. Next. Can you press next? So I like to put one checkpoint here. You have the option of not putting them and taking them directly onto the tracker itself. Okay. Another one. Okay, tap it. Tap. Hold the femur, please. Hold the femur. Yes. Okay, checkpoint. Probe. Okay. Press define. Santosh. Okay, the probe is not visible. Raise the camera up. Yes. Okay. No, still not. Hold it up, please. Hold it. Put it fully up. Yes. Yes. Okay. Tibia. Okay. And your medial malleolus. You have to put the camera. I think आप बीच में आ रहे हैं. थोड़ा सा camera आप पीछे उठ जाइए. थोड़ा सा हो सकता है? Yeah. Okay. This is good. Yeah.
Sir, in patients with ankle deformities, does this give you the same accuracy?
It does not. So you have to make sure that you are, so even, we've had this discussion yesterday about probe, upar, raise it up. We've had the discussion yesterday about, that flexion, residual flexion being seen. It's because of this. So we do the hip registration now. Now see, for the beginners, this is where you get stuck right in the beginning. Okay, I've also had almost 10-15 cases learning curve. When you start doing it, you need to actually loosen the side support to get this. Collect it, please. Only in very obese patients, I like to do it in flexion. Otherwise, you do it in full extension, it becomes easy. No, go back, please. You left it early. Yes, recollect. Recollect. Wait. Okay, that's good. So I like at least 0.8. Collect the neutral position. Yes. Just touch it. You have to adjust the camera, yes. It's, yeah, okay. Okay. Collect it. Keep it pressed. Okay. Now, mastoid. Okay, osteophytes, nibbler, bada nibbler. So we just remove the osteophytes, otherwise you always get, in all systems, you will get a falsely high or a bigger size. Move up, please. Okay, probe. Okay, can you give it to me? Yes. Okay. Can you hold that to show the probe? Yes, okay. Can you please hold it up to show the probe? Yes, okay. Yeah. So in full flexion, you can get the posterior most point. The morphing is much easier like that. Okay. Now we go down to the tibia. We've not done any release so far. Can you just push it from here? Okay. So there are some surgeons who would dislocate at this point. I like to keep it like this, no dislocation. And usually the anterior 2/3 of the tibia, if you're able to get your probe in and morph it, that's sufficient to size. Give me a spike. So we put one spike on the lateral side here, remove the mastoid, and we forceps. And we are going to make space just for the spike to go in on the medial side.
So during this registration, what I see, you just register the tibia as it is. So you do not pierce the cartilage, and on the medial side as it is worn out, you just map it as it is.
Yes. Spike. So now, if you see the X-ray, there is a small osteophyte there. We'll just remove that. So we've gone to the mid-coronal line, and one sec. Okay, nibbler please. Hold the femur. Yes. Okay. So we continue the registration. That's good. Okay. So I like to just quickly skip over this screen, and can you press next? Go straight to joint laxity. Okay. So that's the deformity, about 13 degrees of varus and about 11 degrees of flexion. And this is with whatever we have done so far, removal of menisci, it's correctable to 5. Okay, somebody has to press the orange button there. Orange, yes. Okay, no, it's okay, that's fine. Go back once. Start. So this is a stress range of movement. This is now in a valgus strain. You have a Z retractor. And this is in varus strain. So I put a Z retractor here. Lift it gently.
You do in patella averted the stress views?
Sorry?
Stress range of motion, you do with the patella averted or you?
Yeah, with the patella averted. Okay, so this is it. Now see, it's getting corrected in extension. Sometimes in flexion it's a little difficult. Can you just pull the femur? Pull towards you. No, don't touch the tracker. Wait, just one hand. Pull it towards you. Yes. Yes. Okay. Leave it. Okay, that's good. Continue. Okay, so this is how I plan. We just don't see the implant at this moment. If you see now, it's you've got a medial tightness in flexion of 3.3 millimeters and 2 millimeters in extension. So first thing I do, we are going to externally rotate the femur. Okay, so I like to keep the knee a little lax in on the lateral side. So it's almost 1.5 in extension, 1.9 in flexion, and we've not done any release so far. So actually speaking, this is a pretty balanced knee already now. Are you with me? So we've got a tightness of 1.8 millimeters on the medial side on both in flexion and extension. Right? We can take care of this.
Shubham, the flexion is 5 degrees. Is that deliberate or you kept that?
Femoral component flexion, it's a 5 degree.
And also the notching, I think we've not checked yet.
No, so I've checked the notching. You see, if you keep it, let's look at this here in 5 degrees. There's no notching as such, okay? Now, if I like to keep it 1 point on notch actually, you know, because there is an anterior offset here. The femur, if you see, can you show camera here? If you're not, okay, I'll show it in extension. You can see it now. So, forceps. See, there is a, you know, the difference between the anterior offset is there here. If you see on the medial side, that's the cortex. This is the cortex on the lateral side. And this is what you have mapped actually. So it's counting it from here. Okay, we like to keep it flush. So if you can just nibble this off and map it, you will understand that this notching is not actually notching. Dr. Rakesh.
Dr. Shubhang, you didn't take
point
the special,
well taken, yeah.
Dr. Shubhang, you didn't take the special points?
I didn't take any special points. I can take special points if needed.
It's good to have special points so that these notchings can be,
Yeah, we can always go back. That's the beauty of this system, that you can go back and take the special points, change anything at any point of time. Okay. Okay, so if you see you're worried about notching, you can actually run your finger across like that, and you see that the implant is not actually going into that yellow outline that you see is actually the bony marking of the patient. And the yellow dots that you see here, okay, my implant is pretty well touched, it's not going posterior, so it's not going to tighten up the gap. And that's in the yellow mark here, and distally also it's touching it. I think we are going to go with this.
do you want to give some varus in the tibia 1 degree?
Yeah, if you give the varus, it will take care of, it will take care of, yeah, so that's 1 degree varus. It takes care of about, maybe a 0.2 millimeters on the tibial side. But I think we are good here. We can take the tibia down and make it even lesser. It won't make much of a difference.
Dr. Rakesh, do you completely get the lateral tightness, laxity in this case, in planning screen?
Yeah, no. We do leave a bit of laxity on the lateral side.
In the
That's
planning
desirable.
screen.
Yeah, planning screen.
Always
But I have seen when you do final check, it seems to disappear.
Disappear because, yeah.
So we are just playing a little bit here. Okay, so that's without notch here, but I would like to take it to 1 and then 1 more. This is it. That's perfectly planned now. Medial lateral both are well balanced. We just go to the next. Okay, we will select a distal cut. We are showing a distal burr. We can always convert it to an all burr anytime during the surgery. Okay, burr all for the tibia. Verify points. Okay, can you move out of the way? Yes. Burr. Spike. I messed it up. So it's a thin patient, it's good, but usually this much is enough to keep the soft tissue out of the way. Okay, you'll have to hold this. Yeah. Can I do it myself? Okay. Right. So start, is the saline on? Can you put it on 2? I just want it on 2. Otherwise it's too much water. Point number 2, reduce the water. Yeah. Okay. Okay.
Can I have a question for the panel? The ones who are not here, the ones who are not familiar with the Cori system, you have, I think, two modes of burring. What are those, and what are the special points you talked about earlier? We are not familiar with the Cori system, so I would like to know that.
Dr. Shubhang, there is a question from the floor.
Okay, well actually the question was for the non-Cori users, but in Cori also you have two modes of burring. One is an exposure mode and one is a speed mode. So anything that you do with the sleeve on, you look at this sleeve, focus here please, camera. So if you see with the sleeve on, this is the exposure mode. So the burr will come out of this, only what it wants to cut, it will cut and go back in.
Shubhan, you can show it to the in real time. Yeah.
Yeah,
Keep
okay,
the-
so if you put it closer to the bone and it has to take something here, you see it's going to come out now. Go see, it's nice.
doesn't
Yeah,
come,
you can see that burr out here. Now if I go back to the white area which is already prepared, okay, so if I just put it here, the burr has gone in, nothing is coming out. So if you see there is a red mark, now if I just try to push it, it will create a red mark. It will just tell me not to go here, okay? It's not going to cut anything. It's not that I have cut more, but it's just telling me not to go there.
Shubhang, you can keep the burr and skin and show, it doesn't come out.
Okay, here.
It doesn't come. Even if he's pressing it with the foot pedal, the burr doesn't come. The burr works only in the color-coded zone.
Yeah.
That's where the accuracy works in...
Yes, exactly. The only thing rider here is that, anything that falls, there is boundary which is defined by the system now. Now, anything that falls between that and the burr, it will not see. So you need to make sure that the retraction is just enough.
What about the speed mode?
At the special point, sir.
Sorry?
What about the speed mode?
The speed mode is a mode where you then make a tunnel, the peg holes.
Okay.
So you don't have a guard, so protecting guard. So that into the bone, it makes a tunnel.
Okay.
So that's how the speed mode works here. But the special points is to counter yourself and make you more reliable on the bony landmarks. So you can take medial epicondylar axis. Though we use a PCA, additional reference points helps you, like in notching the cortex, you can have special point.
Okay, spike.
In fact, if you're doing a kinematic tibia, you want to do a medial tubercle, you can mark with the special points and keep. So a lot of extended indications are there.
The more information you give to the robot, the better it is.
Yes.
I know that special point is actually not for the robo, it's for yourself.
Yes.
It's for you to understand that what it's telling you is correct. So the green is actually the front of this burring handle and the blue is the back of the burring handle. So all you need to do is just align it and it will make a hole.
That's
okay. Same thing on the medial side. So in a distal burr we are planning to, that's it, that's usually sufficient. So that's good. Okay. Now you can recheck this, the center of the hole that you made. You can recheck it with your probe, and there's a special instrument for this step which will create a hole for your standard jig to go in. Standard 4-in-1 cutting jig. So you just put this, mallet it, hammer. Okay, standard angel's wing, please. Now you look at this camera, can you show it on top? Idhar dikhao. So you see there's no cutting. We are in fact, if at all, we may be just a little proud. Okay, that's your standard what you would cut. So to reorient yourself between conventional and robotics, this is how you would check, right? With this block in place, wherever you would put it. And we now put the digital angel's wing. Visualize cut, please. आप सामने से हटिए. Go down. Go down. Let me see the femur. No. Okay, but that's good. So we are not touching anything, and this is it. Okay?
Sir, so at this step, if you are unhappy with your femoral sizing, do you go for a change in the femoral sizing, or have you encountered any case where you had to change the sizing?
Yes, I have once or twice, and we've gone back and changed the sizing. Now, one more thing you can do is before standard femur 4 de do. Femur trial. Utar ke. Now you can actually put your femoral component reverse on the, before putting this jig, and cross check if it is fitting or not. And you know, the Smith & Nephew, this system has an advantage that you can convert to a narrow anytime. So it's a 4, we can end up putting a 4 narrow with no change in the cuts or burring. So I'd like to put the pin with this thing in.
Sir, so if you have changed your femoral sizing, do you again replan the entire thing?
Yeah, you will need to replan. You know, only if it is, if you think there is ample bone on the, on the anterior side, and you need to bring a size down, then it's possible. Okay, hold the femur. Rajput, you see now there's no notching at all. Nibbler. Okay. You see, it's nice here, but we would still like to go and see. Burr all karo, burr de do. Can you go to burr all? Yeah. Or just press refine actually. Put the screen down. Put this. Okay. Now you see, this is where we've taken out this much portion with a saw, right? Now, when we do a standard knee replacement, we put the saw and we take all the cuts and we feel very happy, nice and tight, snug fit. But you know, from the planning, this is the amount of bone we usually end up leaving with a saw. So we can just press the burr all. There is no way that with the saw, you can hit it by fluke. Okay, but there is no way with various kinds of saw blades available, various thickness, there is no way that you can get it 100% accurate all the time. So we just refine it like this. Still no notching.
You can also avoid putting the jig and just go all burr technique as
well. Yeah, exactly. We do all burr, but this is, I was asked to demonstrate a distal burr. It is good to do this so that you get a good understanding of comparison of robotics to conventional. So you can see what it's doing for you. Hold tight.
This step, Shubhang,
yes,
you can use a thicker saw blade, so your job is done, don't need to refine. So that's how the Wellis has got a thicker saw blade in their cutting tools. What, Dr. Vaidya, what is your take on?
Point taken. But I have a Cori, so,
But blade is thicker, you can use in the foreign cutting block, thicker blade in this step so that you don't need to refine back.
Okay, slap hammer. Curved osteotome, please.
Sir, in your practice, have you observed any differences between the distal burr and the total burr techniques?
No, I mean, it's just the method that you like. When you're starting off, distal burr is better. It gives you more confidence and you can cross-check everything yourself, but the robo is always right. So you can just convert it to a distal burr. You wouldn't have to refine, you wouldn't have to do anything else. Just relax. Okay.
Yes, sir.
Okay. So femur preparation. We can just cross-check it once. Okay. Yeah. Femur. Lift the femur, please. Okay. Yeah. So looks good medial laterally, but there's a little overhang on the anterolateral side. So we will take a 4 narrow. Okay. Pin. One pin is good. One more pin.
Dr. Shubhang, as
yes.
we know, Smith & Nephew comes with many implants, like there is Genesis and Anthem as well.
So the software, you can choose anything.
So,
you know, the software gives you the option for all.
So if you were doing a Genesis 2, would you plan your rotations differently, or because I believe it comes with a 3-degree inbuilt external rotation in
No,
it.
see, the thing is, it's implant specific rotation, right? Okay. So it will come accordingly. Whatever implant you feed in will come.
So you have to do your gap checks as usual, and it will do
yes, it will do.
cuts
Can you
accordingly.
press this down? No. Put 2 fingers here. Leave this from below. Just put 2 fingers. Yes, away from there. Yes, you would just do your standard. See, Genesis I use only when there is implant shortage, which is quite rampant these days with all companies, not just the poor Smith & Nephew guys. Are you with me, Nagpal?
Yeah.
For the implant shortage thing?
Yeah.
Okay.
Maybe in Punjab only. Never heard it from anywhere else.
No, Dr. Vaidya will vouch that it's here. He probably faces it the most. Okay, pin remover. We can try and leave this trial in. Relax. Okay. Okay, one more. Spike and then posterior spike. आप ये पकड़ें or you'll take it. Okay. So we've done no release, but you see this is the osteophyte that I left behind, because of which I planned that tightness on the tibia, on the medial side. That's it. Can you rotate externally? Yes, hold it here. Okay, leave it. Relax. Posterior spike. Okay, forceps, lines जो ये इनको दे दो, आप इधर से पकड़ो. There is a posterior horn of the meniscus left behind here. We just remove that. That's it. So you will have to, okay, आप छोड़ दीजिए. You will hold it, all three. Okay. We need to see the tibia on the. Okay. Can we go to tibia, please, on the robo? Okay. Tibia is seen. Okay. So we put a standard jig here. Now, if you see with the robo, you will always see. Focus on the jig here. You will always see that the slope given by the robo is lesser than what you would normally take conventionally. Okay. Visualize cut, please. Okay. Now, this is it. It's perfect pin. Okay, medial, put it oblique. Tibia is not seen, yeah, okay. Pin is not loaded properly. Yeah, it gets jammed sometimes. This is not the right pin. End slot wala pin de do. Yes. So there are pins which have got a circular end. They are not usually held by this thing. Okay, now wait. So what we are going to do is, we are going to take just for demonstration. Okay, go back to burr all, please. Okay, we are going to burr and make a trough here. This trough that you make actually tells you how much bone is going to be removed actually. Okay, you see it's nice and white there, and that's the extra bone. Okay, this much. So to save the cost of the burr, you can take a tentative cut here. The idea of making the trough is that you don't end up going deeper than what you would do with the blade. Forceps. Nibbler there. Yeah. And then we can just burr everything. We are going to show burr here. Up niche ho jao. Yes, that's good. Tibia niche ho jao bhai. हाँ, yes, thoda down. Yes. Tibia is not seen. थोड़ा नीचे आ जाओ. हाँ. The cameraman is standing between me and the robo. Yeah, now he's. How do they say? Khali huan. Huh? Yeah, yes. Okay. Give him a stool to sit.
Sir, since you've been using Cori, have you faced any pains in your wrist or carpal tunnel or any such issues?
So far none. I hope I don't. You think Cori users get carpal tunnel?
I've heard from one.
We are going to sue Smith and Nephew.
So there definitely is a issue, like even in the Mako, lot of vibration. One of my colleagues has got some neural issues happening. Whenever he takes a couple of days break, he's okay again. So definitely
I've heard the same.
It's possible, yeah.
It's the technique how you hold the burr. You should not put so much. It's a lot of surgeons, I think Vaidya and Rakesh, they have a technique how to hold it.
So,
if Cori is much most comfortable than the Navio's hand piece, yeah.
So, because that trial implant is in small nibbler. Refine.
There have also been
Small
reports about the sound pollution in the OT. And
Come on.
That's
Do you put music in the OT?
Yeah, they're using ear protectors while doing the surgery as well.
Again, Mako, I think, has the maximum amount of sound, equal to apparently a flight taking off. So a lot of the surgeons in the US are putting these industrial headphones on. Otherwise, they just use AirPods and put on some music.
Okay.
There was an interesting paper also on the, even the sound of the saw, routine saw. So it's not exactly only robotics, but everywhere. And the deafness also is more in surgeons who are doing arthroplasty. So we should be careful.
It might be helpful later in the age.
The other thing which really makes a noise is the suction machine. Just turn it off and see the silence which happens in OT.
On top of that, we all, I think many of us put loud music also.
Yeah.
Especially my colleague Satish Kale, his sounds are,
So we've got some high point here.
coming in the other OT also.
That is only after the spinal cord level or the wisdom stage the music comes in.
Yeah, okay. So there was an article in JBJS about 5-6 years ago about, it's called the orthopedic din.
Dr. Shubham, how much time does it take to take all the cuts in your usual practice? I know you're demonstrating here, so you're taking a little bit more
So it
time.
takes about 5 to 7 minutes actually. If you do a total burr. Cuts are similar. I've just added maybe 10 minutes to the surgical time.
All right.
So trial with 9. Okay, remove everything. PS de do.
The time taken in registration and maybe a little bit more time in burring is offset by the amount of time you're saved by planning. When you're like planning your gaps, you don't have to keep rechecking. So usually I would say you get time neutral after a few cases itself. We are in our robotic cases, we're actually faster than we would do in a conventional, at least 10 minutes.
So can you finish this? So this is where we are. Normally, because of the anterior femur bow, we have to keep it in about 6 to 8 degrees of flexion and it should feel springy. This is where we are. Okay? Yeah. So we plan for 1 degree varus and that's where we are. Collect range of movement, please. So that's the range of movement. Okay, release.
Shubham, can you put the pedal in?
Everted. Yeah, that's because I have the pins in here. So I would take that measurement again once we have the final implant in. Then it will be nicely clearly seen. So just do this once. Yes. Okay. So lateral side is opening up as we planned, about 1.5 millimeters. Okay. There's no opening on the medial side. Okay. Right, so we just...
Thank you, sir, for that wonderful demonstration. We'll have to cut the live transmission now because we are going live with Dr. David Robinsky, who will be joining us from Hawaii.
Okay,
So
great.
Thank you.
Thank
and
you,
a big
everyone.
round of thanks to all the anesthetists and all the OT staff. I would like to first felicitate our moderators, Dr. Param Nagpal and Dr. Sriram Godpole. I'd like to invite Dr. Narendra Vaidya to please moderate the next session. Are we live with Dr. David?
We are. Good morning. Is everything coming through clearly?
Dr. Rakesh, please join me for moderating. So I think, welcome David, always very nice to see you, and everybody is very excited to have you again. Next time we want you to be, personally present in the meeting.
That's my wish as well. My hope is for next year. So we'll start our presentation on robotic-assisted bicruciate retaining total knee replacement. I'm a professor at University of Hawaii. And my disclosures are I'm a consultant for Smith Nephew, OrthoGrid, and also VR. And this is a passion project for me. I'm a 55-year-old with knee arthritis, and I still have my ACL. So I started working on the design of this implant in 2004. We put our first bicruciate knee in a patient in 2014. So this is combined with the technology, something I've been really focused on my career. So I think we should be reminded that bicruciate knees can be successful. Certain designs are better than others, but the Cloutier knee and the Townley knee have 80 to 90% survivorship at 20 years, and these are the old style knees with cobalt chrome and non-crosslink polyethylene. And if you combine proper indications, an excellent implant, and intelligent technology, you can have excellent results. So the indications are fairly straightforward. Basically, someone who has medial or lateral compartment arthritis or even patellofemoral arthritis, but one additional compartment has gone bad. So more than what you could accomplish with either a uni or a PFJ. So this patient has medial and patellofemoral arthritis, and they've done well with a resurfacing implant, the bicruciate sparing total knee. And the advantages are faster recovery, better range of motion, and for the athletic population, retention of proprioception and a more natural feel to the knee. So when I think about indications, I look at four things: deformity, soft tissue, BMI, and bone stock. This really works best for someone who has minimal deformity, less than 10 degrees of varus and less than 7 degrees of valgus. Ideally, this is a correctable deformity, and they have a less than 10-degree flexion contracture with intact ACL and PCL. Better for a BMI less than 35 because of the tibial base plate. It's a short stem, and I'll show you an image of that keel. And they should have good bone stock. So typical patient, 5'1", 135, pickleball player with medial and patellofemoral disease. This is the bicruciate retaining knee replacement, and this is her at 6 weeks post-op. This is a larger patient. He's a softball player, again, medial and patellofemoral disease. This is his post-operative x-ray, and you can see it really is a bone-conserving implant. And this is him immediately post-op, about 100 degrees of flexion, and then about 125, 130 at 6 weeks. Now, the first question is the ACL present? Of course, you'll get that on history and physical exam. X-rays are instructive. If the femur is sitting posterior and you have more of a posterior pattern of where the ACL is likely insufficient, you want to see the femur located anteriorly directly over the tibia and have more of an anterior wear pattern. So contraindications, looking at it the same way: larger than 15 degrees of varus or 10 degrees of valgus with a fixed deformity is too much. A large flexion contraction more than 10 degrees where you might have to elevate the joint line is really difficult to deal with. And of course, an inflammatory arthropathy is no good. Use caution with BMI over 35, although I've done it in larger patients as well. And I don't like this as a revision procedure from a uni. I think that you should have really pristine tibial bone for excellent tibia fixation. Can you do it in a patient who's had an ACL reconstruction? You can if it's a good ACL reconstruction. This, you can see, has vertical tunnels. It's a non-anatomic ACL reconstruction. She doesn't have good rotational stability. So we did better with her with a bicruciate substituting design. So implant design is important, and the failures, I think, are related to a non-anatomic femur, so fighting the femoral shape of the implant, and tibia baseplate design. Either the tibia baseplates can fracture or they can loosen. So the design of this new implant is improved upon the failures that we've seen prior. So the femur is anatomic, and it's an asymmetric CR type design with a larger radius of curvature medially than laterally. And the tibia base plate has this large keel, so it's like an I-beam, so it's very, very stiff and very sturdy. And the shape of the tibia surface is concave medially and convex laterally, and we've mirrored this in the shape of the tibial polyethylene. And if you reproduce this normal anatomy with normal shapes and you get the femur located anteriorly over the tibia, then you can get normal kinematics and appropriate rotation as you go into flexion. Now, the key thing to note is that this is a much less constrained tibia polyethylene, so the ligaments really drive the motion. And for this reason, it's intolerant of raising or lowering the joint line, and this is why technology is very important to us. And the MCL and LCL balance is like doing a medial and a lateral uni. And we know we balance our medial uni different than our lateral uni, so you have to be mindful of balancing each compartment of the knee differently for a successful operation. So we use the CORI system that you just nicely demonstrated with computer-aided design, dynamic gap balancing, and robotic-assisted milling. So we have very precise execution of our three-dimensional plan. So a typical patient, he's 47 years old, a young fella, 6'4". He's a basketball player, and he drives the tugboat and helps unload the containers that come to our island. So he has tricompartmental disease. His major issue is patellofemoral disease, but he has enough problems in the medial and lateral compartment that a patellofemoral arthroplasty would not be sufficient. And his issues are trochlear dysplasia and lateral patellosubluxation. So we have to think of all this when we're doing the surgery. So I prefer a surgery without a tourniquet. I like a subvasous approach. I think this really helps with less pain and improves patella tracking. And we use the TraumaCAD system to template our operation so we know what implants we're going to use. The approach, we want to do aggressive and precise osteophyte resection and minimal ligament release. And especially this is important for a valgus knee, not to loosen up the medial side too much. And the osteophyte resection releases tight ligaments, but also gives the CORI system more accurate sizing information. I put my trackers on the femoral side within the wound and on the tibia side outside the wound. Defining the center of the ankle, as you saw, is touching the medial and lateral malleoli, and then the machine calculates the center of the ankle. The center of the ACL footprint and the terminus of the trochlea determine the center of the knee at the tibia and the femur respectively, and this is us collecting that data. And then rotating the hip in small circles gives us the center of the hip. So now we have the alignment in the system, and I want to generally undercorrect these patients and restore their pre-arthritic alignment, their pre-arthritic shape of their knee. And we define our initial range of motion, as you saw. We do that with a slight axial load. We map the femur. Again, this is all very standard. We just trace the outline of the femur. It brings up a mesh that's from the CT database. And then we refine the mesh. And I think what's elegant about the system is that it's real-time 3D mapping of the cartilage surface. You're not working off a CT scan, you're working off the cartilage surface, which is really the actual joint line location. So it takes about 40 to 45 seconds. The tibia is mapped the same way, but what's unique about this is we are careful not to map the ACL footprint, and we use special points to identify the rotational alignment of the ACL footprint. Because this implant is going to be relatively internally rotated. Typically, we externally rotate the tibia component at least 5 degrees, and this component matches the rotation of the ACL footprint, just like a medial uni or a lateral uni. So it's going to appear internally rotated to your eye. So when you prioritize the information, you have a lot of information with these robotic systems. If you're doing a bicruciate substituting knee or a posterior stabilized knee, you're having a large deformity. So I'm focusing on correcting the alignment, and I'm looking at my measured resection. I want to take, for example, 9.5 millimeters off the medial distal femoral cut to accommodate my implant. I'll look at the gap balancing information, but I'll be focusing primarily on the less affected side. So with this anatomic implant, if I get my lateral side balanced correctly, the medial side will end up where it needs to go. And then the shape matching is less important because it's a deformed knee to start with. And I'm also going to be doing some more ligament releases. With the bicruciate retaining design, we're primarily shape matching. We're focusing on that three-dimensional image and really resurfacing the knee to restore the pre-arthritic anatomy. Gap balancing is really important because it's different medially and laterally, and I'll show you how. And then I'm going to undercorrect, so I'm less focused on the raw numbers of the alignment, although I want to stay within 3 degrees for longevity. So with a bicruciate substituting design or a PS design, you're going to go for the largest femoral component without overhang because you really want to have a nice balanced gap and extension and inflection. And our goal for this implant is even gaps at 1 millimeter medially and laterally in extension. And we're going to externally rotate the femur aggressively 3 to 5 degrees, so we're really appropriately tight in that lateral compartment, and we have a nice rectangular gap in flexion. With the XR, the bicruciate retaining knee, we're generally careful to match precisely the posterior femoral offset. Now with the medial uni, I like 2 millimeters gap, meet in extension and in flexion. And on a lateral uni, I like 3 millimeters gap in extension, and I want it to gradually open up to 7 millimeters in flexion. So you can imagine when you put a knee in a figure of 4, you stick an arthroscope in there, it's going to open up nicely, and you can put a 4.5 or 5 millimeter shaver in there with plenty of room. So that trapezoidal flexion gap is our goal here. And for this reason, we don't add a lot of external rotation to the femur. We just match the anatomy of the patient. So it's usually only 1 or 2 degrees. And we can balance our extension gap by adding varus 1 or 2 degrees to balance the extension gap. Now, the initial implant placement on that first choroid screen is shape matching. So in general, we'll undercorrect the coronal alignment. I like to correct valgus knees to neutral, but varus knees I'll undercorrect by 1, 2, or 3 degrees. And the rotation is not aggressive, but you see here that we're really matching exactly the shape of those posterior condyles. On the tibia, again, very important to match the less affected joint line. This is an asymmetric implant that's 11 millimeters thick laterally and 8 millimeters thick medially. So this knee with a varus wear, we're going to be adding a little material back medially, but we're matching the normal joint line on this varus knee. Rotation of the tibia component is going to match the rotational alignment of the ACL footprint. And this asymmetric component fits the bone very nicely. And the sagittal adjustment, we really want to make sure that, again, we're matching the posterior femoral offset. And I like posterior slope to be 5 degrees on these implants. If you put too much posterior slope, then the tibia will want to go forward. It'll put a lot of strain on your ACL and could lead to early failure. So 5 degrees is appropriate. And then we have done our preliminary placement of the implants, which takes about 1 minute. And then we stress the knee, range the knee, varus and valgus stress using a Z retractor to augment our stress. And we get a curve like this. And then we can fine tune our balance based on these numbers. So in this case, it looks like on the medial side, I'm a little bit looser than I would like to be. So I can move my femoral component a little distal and perhaps a little tighter medially in flexion than I'd like to be. So we've adjusted our femoral component position, and we can look at this curve here, and we can see that, again, our flexion, our lateral side, which is purple, is gradually opening up as we go into deep flexion. But even doing the best I can, I'm still rather tight in extension laterally. And that's what you'd expect for a valgus knee. So I'm going to keep an eye on that for later and be, okay, I'm mindful of this, and I know that I'll get some release of the IT band as I do the procedure, but I might have to pie crust it. So we use a milling tool. I like the all-burr technique that I learned from Dr. Girani and Dr. Vaidya, and it's very efficient. And you can see here, we're not looking at a classic grand piano sign. This is a less externally rotated femoral component. But I just systematically remove the bone from top to bottom, use a tunneling technique to get the posterior condyles. And then for the tibia, I like a milling tool. I don't like using the saw because I'm worried about undermining that ACL. So I go from top to bottom anteriorly and then use the tunneling technique, as you can see here, to remove the bone posteriorly. And then I also like to use the burr to clean out my keel space. I want to have a 3 to 4 millimeter cement mantle around that keel for optimum fixation. So you have plenty of room. A lot of people are worried, can I clean out the back of the knee? You have great exposure. You can clean out the back of the knee. The implant is a standard CR implant. And you see lots of space available for the ACL, and this U-shaped tibia component cradles the ACL as well. Now, I'm a little tight with that IT band. I couldn't quite get a full correction, so I just did a little pie crusting watching the screen. I made sure I can get full extension easily. And then we corrected that, and we see that on the final screen. We got our neutral alignment. We have this information that we use and we review each week. It's helpful with the fellows and the residents, but it's also good for our data collection. And this is a postoperative film, so he gets nice full extension. It's a really bone-conserving prosthesis. This is what I love about this implant. And this is him immediately after surgery. He goes home the same day. This is him at 4 weeks post-op. And these patients really recover like a uni. They recover much more like a uni than a total. And they get back to pretty high levels of activity. So the challenge in my practice is surfers. Surfers love to surf. You have to flex your knee to 155 to pop up. You have to have great mid-flexion stability to surf, and you have to have proprioception to surf well. And this is a high-level surfer and surfboard shaper. And again, pretty moderate arthritis. I tried everything to talk him out of a knee replacement and did injections, but still he had recurrent effusions and pain. So this is an operation where I feel confident that I can restore his level of function that he's looking for. This is our planning screen, and again, varus wear, so we're matching the cartilage surface on the lateral side, but adding a little material back on the worn medial side to the cartilage surface, matching that joint line. You can see this rotation is matching the ACL footprint. This is his postoperative x-ray. This is him going home the same day. He has good quad control because we do the subvastus approach. And this is him back surfing. So I know that I've done a good job, and I see him out surfing all the time. So I think if you have good indications, a good implant, and use technology, you're going to have an excellent outcome with a bicruciate retaining knee. And be wary of doing a bicruciate retaining knee if you don't absolutely love the ACL and the PCL. So this system, you can convert very quickly and easily to a cruciate retaining that PCL, or substitute for the ACL and the PCL. So I'd rather have a perfect bicruciate substituting knee than an imperfect bicruciate retaining knee. Our patients have high expectations. We now have these great implants, and using technology really lets us hit the target every time. Thank you very much for your attention. I appreciate the chance to participate in this conference.
Thank you, David, for a very elaborate and very nicely explained procedure. Unfortunately, in India, still this implant is not available, and we are all after Smith & Nephew to make it available as soon as possible. There are a couple of questions, if you know, if you can answer them.
Of course.
Whatever X-rays you showed, many of them were, looking like even the UK or partial replacement may be enough for them. So what was your exact, what are the criteria where you make a decision, whether it is a patellofemoral thing, or which are the patients whom you do bicruciate retaining?
So I group my patients, the uni patients and the bicruciate retaining patients are in the same ballpark in my mind, and it's about 25% of my practice. And how much patellofemoral arthritis, for example, will you tolerate in someone who has medial arthritis is up for debate. So if you look at the Oxford group, they're more liberal. And of course, if you see medial facet wear, they're more tolerant of that. And if you see lateral patellofacet wear, they're less tolerant of that. So I engage the patient in the decision-making process, and I go in there with models of both implants, and I say the medial uni is going to be an excellent surgery for you. You'll have a great outcome, but you may in the future need another surgery for the patellofemoral joint. And with core, you can add a PFJ to a uni at a later date, which I've done. So that's an option. Or you can have this bicruciate retaining knee, which is essentially a knee resurfacing, a little bit longer recovery, but a more durable procedure.
Hi, there's a question I have. One of the arguments against the CR surgeons is the delayed rupture of PCL. So here now we have two ligaments to worry about. Have you come across cases where there's a delayed rupture of ACL? Because a lot of your patients are very sporty types. And then if it happens, what do you do?
That's an excellent question. And this is, the people who favor the bicruciate substituting or PS design say, why do I want to save a degenerative old ligament anyway? So in my practice personally, knock on wood, I have not seen any ligament ruptures, but we have a core group of surgeons and we collect our data, and we've had 2 cases of ACL ruptures from sporting activities after a bicruciate retaining knee. So one patient did well and with rehab, and we call them a coper. So, and this is why I'm pretty stingy about adding too much posterior slope to the tibia, because if you have a relatively flat tibia, then if they do rupture their ACL, then they're more likely to be able to cope because the tibia doesn't want to rocket forward. And then we had one patient who did not cope with that very well, and then they were treated with a revision to a cruciate retaining tibia base plate. So the tibia base plate was extracted, and a journey to base plate was inserted with a curved poly.
Are there any chances or some surgeons doing bicruciate retaining without robotics in Australia?
There are surgeons doing bicruciate retaining knees without robotics, and I did 2 years of it. I mean, I started doing the implant in 2014. We didn't adapt the CORI software to do the bicruciate knee until 2016. I think it's a harder operation.
Yeah.
It's
yeah.
really, it's much more challenging, but it's possible.
Okay. Any questions from the floor? Okay, I think, thank you very much, David, and for a completely different topic, and definitely we look forward to have you in the next meeting. Thank you very much.
Thank you. I appreciate the opportunity. You guys have a great day.
So we'll move on, we'll resume with our hip session. I would like to request Dr. Subhranshu Mohanty sir, Dr. Ashit Suryavanshi and Dr. Nikhil Likhate to come up and be the moderators for the next session. Our first speaker for this session will be Dr. Ramesh Sen.
Good morning. Dr. Sen needs no introduction. He is our ex-president of the Indian Orthopedic Association and an accomplished hip surgeon and pelvic surgeon. Let us listen from him that whether the robot helps in the complex total hip replacement surgeries. Over to Dr. Sen.
So good morning, friends. Thank you, Dr. Subhranshu. Definitely there is a very big question about it. For knee, it's a big area. Now everybody is into the knee, but for the hip, there has been a bias against, as I said. Though we understand it is 1992 when the first surgical robot for THR started with it. And as compared to knee joint, things have not been able to take care. While if you look at, we predict that robotic systems such as ours will provide surgeon with unprecedented degree of precision for the procedure like THR that was stated that long time back. We have appreciated that robotic hip surgery gives impressive accuracy, minimally invasive, expect a better patient satisfaction, natural filling, joints are all okay. Some downsides are reported like no tactile feedback, maybe injury to the surrounding tissue does exist. But if you look at the systems, every system, whether it is active, has got its own issues, semi-active has their own issues. We need enough studies for the hip also. The first robot which came, so-called robot doc walls, it proved that it can give a better stem alignment, less problem with the limb line discrepancy, less pulmonary embolism events, and had a less stress shielding when it was evaluated with the robot. And thereafter, we have got a reasonable number of publications, whether they were linked with the component alignment in the stem or the acetabulum, or component fit and fill in the stem, or the clinical outcomes. Enough number of papers got published into this area. And what has been said in all of them, there is a doubt, and I am talking about knee now. Some people feel that some experienced surgeons can meet or exceed robotic accuracy even in the knee joint also. But what about the hip joint? We have still to evaluate. As regarding cost effectiveness, yes, just like knee also, more the number of hips you are eventually doing, the cost is likely to reduce. Just like from 100 joints, it is 12%, rise to 300 joint, it comes to 6%, because obviously the needs are met accordingly. And this happens in other studies also. Now, what is the scenario in 2021 regarding hip? 224 clinical studies have been published on the robotic orthopedic surgery. Mostly we understand they are from US, and look, second number is China. We are India, still far away. Most contributions are coming from one hospital, that is from China, all the robots. And the most scholars in the world right now talking about robots are either Tainwai from China or Mount Michael from most productive authors. And top 30 articles, 29 publications are cited at least 40 times. And the journal which has published is Journal of Arthroplasty, that is robots. But question given to me was, what about the complex hip? Standard hip, things have come up very well. This is the cup. These are the anatomical parameters which you have to say. What about the complex when those anatomical parameters do not exist as comfortably as they happen in the knee joint? So there have been papers in dysplasia hip also that these kind of a patients can be taken for a hip replacement. And this paper says with a series of 79 patients, yes, it is an adequate and a useful method which can give us a good component positioning and an excellent outcome. Another paper also says that it, and this is from the American Academy of Orthopedic Surgeons, it can minimize the failure rates and the revision rates also. Yeah, we agree that it is a steep learning curve, the cost is higher, but it is still good. This paper in 2020 states that even arthro disease is not a situation where it cannot be done. Yes, it definitely, it offers good haptic constraint control over the depth of rimming. So that is also very much possible. Another paper also says the same thing, that it provides a real-time information and it can work well for the fused hip also. What about the obesity? Definitely. Now, as compared to knee, which is a very superficial and you flex with whatever the obese patient is, knee is very superficial. Here, the hip is a deep area. Again, a big complexity, but still, they have been able to find it out that here also, Robo can do the job. It can provide accurate and reproducible state placement of the cup. So it does well in that situation. And another paper also supported the same thing, that though it is challenging and can be associated with complications, but it definitely helps in precise cup position as well as the soft tissue balance, and they are definitely the major advantages in the hip also. Then there are case reports. Again, I am saying there are case reports of those complicated situations which are getting published right now. So we have lagged behind the TKR in THR robotic. We are still working on those complex situations with the case reports getting published in 2021, 2022, and maybe this year also. Another case of a complex hip is a kind of a trauma post-acetabulum fixation where the cup placement. But take care, here the anatomical parameters are defined. We can get our indicators. But if these are not there, though the paper says this, another paper says there is a bone loss dysplasia post-traumatic, it can work. If these are altered, just like in keriostomy also, it can still be working up and it can still provide that help in placement of the cup. Revision scenario, another situation which is likely to complete. Again, there are 7 reports and look at it. It was in 1998 when they did try the robotic in the revision also. Now the problem is the previous cement, so they had to take it out and they wanted to confirm by arthroscopy whether it has been taken out or not. So combining the systems, now where we are 20 years or 20, 30 years later is little more. Then there has been MECO only system where it has been found it out. Yes, it can work, and that is 2021. The problem comes, what exactly is the difference between knee and hip? Why in hip we are worried about? Because the anatomy is different. If the anatomy is standard, we know these are anatomic parameters, you can put it over. But what about these cases? They need much more than the anatomical parameters. No parameters defined. There only the surgeon can do the job. So we understand that surgery is getting into a standard hip arthroplasty. We still had more work to be done to support complex arthroplasty. Till that time, it is surgeon only. We understand our future success is directly proportional to our ability to understand, adopt, and integrate new technology into work, but we need to, and this is the desire. Thank you.
Thank you. Thank you very much, Dr. Sen. So, for the next topic, so everyone knows that the dislocation of the hip is very important, even if you put a cup in a safe zone. So, enlightening the topic regarding the spinopelvic relation, I would like to call Dr. Suhas Kamble to give or deliver a lecture. we'll have discussion at the end of the session. So please keep your questions ready at the end of the session.
Good morning, friends. Spinopelvic relations in THR is my topic. It is a bit difficult to explain it in 8 minutes. However, I'll try my best and try to be within time. As we all know, Levenick safe zone recommends us to put the cup in an inclination of 40 degrees and anteversion of 15 degrees plus minus 10. However, this paper by Matthew Abdel said, what safe zone? The results were 58% of the dislocated THRs were in the Levenick safe zone. So what must have gone wrong? Most probable cause is unfavorable spinopelvic relations. What adjustments we need to make? We have to do pre-operative evaluation very properly. We need to study the pelvic X-ray, AP X-ray properly. We also should take a standing, supine and sitting lateral radiographs of the pelvis and the lumbar spine to study the relationship. There are certain definitions which we need to understand when we want to know about spinopelvic relations. One is a pelvic incidence, sacral slope and pelvic tilt. These are the minimum which we need to study. The pelvic incidence is the angle which is formed between a line drawn perpendicular from the midpoint of S1 superior end plate and a line bisecting the center of the femoral heads. Sacral slope is an angle between a horizontal line and a line parallel to the superior end plate of S1. And the pelvic tilt. The pelvic tilt is the angle that pelvis forms with the vertical. The mean pelvic tilt angle in the standing position is 13 plus minus 6 degrees. And the pelvic tilt indicates the spatial orientation of the pelvis, which changes according to the position of the patient. In normal spinopelvic motion, as one transitions from standing to sitting position, the pelvic tilts posteriorly approximately 20 degrees in order to increase the functional acetabular anteversion 15 to 20 degrees to accommodate the hip flexion without any anterior impingement. But when there is a stiff spine and the patient undergoes a THR, when he changes the position from standing to sitting position, that it can lead to an anterior impingement and leading to hip dislocation. Spinopelvic stiffness, when we measure the sacral slope from sitting to standing position, if there is less than 10 degrees of motion of the pelvis, then it is considered as a stiff spine. Then there is a concept of pelvis which is stuck in standing, in which the pelvis never achieves a sacral slope of less than 30 degrees in overly anteriorly tilted, or it is stuck in a standing position. The sacral slope is more than 30 in standing and sitting. In this, the implant risk for the cup is if it is retroverted. It will lead to anterior impingement and posterior edge loading, leading to posterior dislocation in sitting position. The cup positioning which was proposed is 15 to 25 degrees of anteversion in this case. When the pelvis is stuck sitting, the pelvis never achieves a sacral slope of greater than 30 degrees in overly posteriorly tilted or stuck sitting position. In this, the sacral slope is less than 30 in standing and sitting position, and the implant risk for cup if it is anteverted. It will lead to posterior impingement and anterior edge loading, leading to anterior dislocation in the standing position. Then there are, if there is a kyphotic spine, sacral slope is less than 5 in such sittings, in a sitting position. It will lead to jump distance exceeded, leading to posterior dislocation in a sitting position. Wigtochik recommended the acetabular anteversion to making it to 30 degrees in this case. So we need to do alterations to the Levenick safe zone, and there is a classification in which if the spine is balanced and flexible as it is in healthy individuals, then the Levenick safe zone can be followed. If the spine is balanced and stiff, then in cases such as lumbar degenerative disease, prior lumbosacral fusion, then we need to increase the anteversion to between 15 to 25. If it is unbalanced and flexible, like in post-laminectomy or in neuromuscular disorders leading to kyphosis, then we need to reduce the anteversion. Unbalanced and stiff spine, that is long spine lumbosacral fusion, or in ankylosing spondylisis, we need to reduce the anteversion. And whenever in difficult situations where spine is fused, we should be opting for a robotic total hip replacement. Robotic THR will definitely help in such situations. This is a pre-planning video in which after doing the CT scan and studying we can enter the values of the sacral slope and the pelvic tilt in sitting position and in standing position. We can enter those values in the software, and it will tell us in which position the chances of dislocation are there. It will lead, it can give us a virtual range of movement, and one moment, it can, we can, put the limb in virtual range of movement and see at which degree of anteversion, in which degree of flexion and rotations it is going to lead to an impingement, either the implant to bone impingement leading to dislocation, and we can make the changes in the software accordingly, and we can alter the position of the cup depending on the impingement profile of the patient. So whenever there is a difficult and complex spinal pelvic relationship, we should definitely opt for a robotic total hip replacement. Thank you.
Hello. Thank you, sir. Please join us here. So, as sir rightly said that in spinopelvic for spinopelvic alignment, THR by robot will be giving us a good result. So, the next topic, Dr. Adarsh is going to tell us about robotic THR in stiff spine. So, Adarsh, please welcome.
I'd like to thank Annappareddy sir for inviting me here today. Thank you, sir. So most of the points I'll be discussing are already discussed very nicely by Dr. Kale. But I'll be speaking about a particular case that we have come across and how the robot build is out. So now we know that the latest discussion point in THR after cemented versus uncemented, bearing surfaces, dual mobility, dysplastic hips right now is THR in stiff spine. It's been discussed in every conference now. It's very confusing. But the beauty of the robot is it can bail us out in such a confusing situation. So the gist of it is, I think by now everybody knows that when you're standing, the pelvis is tilted anteriorly, and when you're sitting, it tilts posteriorly. So that is the basic gist of it. This is what a normal spinopelvic association should be like. So when you're standing, it should be tilted anteriorly, and when it's sitting, it tilts posteriorly. So patients with spinopelvic pathology who undergo THR have an increased risk of dislocation. So once this relationship goes awry, you can have a high risk of dislocation. So there's something known as the hip spine classification system. It's a simple and effective way to identify patients at an increased risk of dislocation. So this is the paper. I would like you all to just take a screen or photo and go read this paper. It's one of the most beautiful papers on this particular topic. It's by Wigdorczyk, and it won the 2021 Ortho Off-Rank Award as well. It's very beautifully mentioned how all these changes can be overcome. So what he proposed was this classification. It categorizes patients for total hip arthroplasty based on their spinal mobility and the hip ROM. So he's kind of categorized into 4 different categories, and it's widely used to guide the surgery and implant design for THR in patients with varying spinopelvic parameters. I've just briefly summarized the points of this paper. He says that there are 2 spinal issues which affect the pelvis position in THR planning, that is the spinal deformity as well as the stiffness in the spine. Positioning the acetabular component in spinal deformity relies on abnormal functional position of the pelvis rather than the native anatomy. So you don't look at the native anatomy. It depends on the functional position of the pelvis. So in the compensatory changes in posture, including the posterior tilt and spinal deformity, in spinal deformity patients is lost. Okay, so that's when this transition from standing to seating gets lost completely in these abnormal spines. So stiff lumbar spine limits this pelvic adjustment, and this leads to impingement, dislocation and bony impingement as well. So as Dr. Suhas has already mentioned about the different angles, sacral slope, the pelvic incidence, the lumbar lordosis and the pelvic tilt, all these 4 angles should be calculated, and this is how he has categorized the different patients. So if you have a normal alignment of the spine, that is pelvic incidence minus lumbar lordosis is less than 10 degrees, then you're a type 1 candidate. If your spinal deformity is there, that is a pelvic incidence minus lumbar lordosis is more than 10 degrees, that is more of a kyphotic spine, you're a type 2. Again, within that, if you have a normal mobility, that is, if the difference between sitting and standing angle, sacral slope angle is more than 10, you're normal. Less than 10, you're stiff, both in A and B, both in 1 and 2. So this is a summary slide. If you can just take a quick picture of this. In 1A, that is a normal spine alignment and normal mobility, you can go ahead with your regular low neck safe zones, 40 to 20 degrees of inclination and anteversion. If you have a normal alignment, but a stiff spine, it's also known as stuck standing. Here, you need to have a little bit more inclination and anteversion, so usually go for 45-25. If you have a flat back deformity, that you have a deformity, but a normal mobility, that usually gets corrected with a total hip replacement, so you can go ahead with your regular low neck safe zones. But if you have a deformity as well as a stiff spine, that's 2B, that's the most dangerous one, that is called as stuck sitting. You usually want to reduce your anteversion, because you're going to end up dislocating if you keep a regular anteversion. So again, quick summary: 1A, normal, 40-20. 1B, stuck standing, go for a little higher, 45-25. 2A, it's an anterior pelvic tilt from the hip because of flexion contracture, so again go for regular 40-20. 2B is when you try to reduce your anteversion. This is confusing, but Mako makes this easy. So Mako not only helps in all these cup sizing, femur sizing, cup depth, it's also nowadays helping in stiff spine. The brief workflow is the pre-op planning, then the pelvic array, then the checkpoints, then reaming. All these things were there before, but now with, and because of that, we're able to plan 3D planning. We can get a 3D reconstruction with pre-op limb assessment, and you can actually plan out the different lengths and everything. You can also place the acetabular cup properly. You can choose what angle you want of inclination and version. You can restore your hip center. But now with the 4.0 software, which has launched a few months ago, we can also do the functional hip positioning. You can put the hip wherever you want depending on the virtual range of motion, which is shown very beautifully by Dr. Kamble. So you can now measure the pelvic tilt. You just have to take one extra X-ray, lateral sitting and standing, calculate your sacral slopes, okay, and then you enter it into the robot, and then it helps you with your virtual range of motion. So a quick video on this. So as you know, in sitting and standing, how the position of the spine and the pelvis changes.
Based on the patient's unique pelvic tilt or sacral slope angles for supine, stand, and sit poses. First, the surgeon takes the standing and sitting lateral x-rays. Mako product specialist inputs the pelvic tilt or sacral slope value into the Mako pre-plan for the stand and sit poses.
Okay, so once you've entered that, you go through the virtual range of motion. So let's see, this patient is at 40-25 degrees. In sitting, I'm going up to 70, 90 without any impingement. This is a normal hip. Okay, normal spine. And then I even check in internal rotation whether there's any change over there as well. So in neutral interrotation, there's no impingement at 120 degrees of flexion. Now what about standing? So this gentleman, we kept it at 40-25 for this particular patient. If you can see at external rotation of 5 degrees and 30 degrees, 5 degrees extension and 30 degrees external rotation, it is impinging here. So you can make a modification in your anteversion in the cup, bring it down, and that gets rid of that impingement. So these are small adjustments you can make. And after that, you can also check your femoral anteversion and make more adjustments accordingly. So I'll just show you one case. It's a young gentleman with ankylosing spondylitis. You can see that the fused sacroiliac joints, bilateral hip arthritis, it was an angst. And if you see the sacral slopes, he had less than 30 degrees in between standing and sitting. He had 15.4 in standing and 8.5 in sitting. So this is stuck in sitting. This is a type 2B. So as per what we have learned, we have to reduce your anteversion, right? So again, we get the pre-op CT template. It tells us that we have 1 mm shortened and we have a combined offset difference of 11 mm reduced. So we went ahead with a regular plan, CT-based planning of the cup. We've measured it, 40 degrees, 20 degrees. We found no impingement in standing and sitting position. So we were okay with the regular 45-20. We didn't want to increase it. But then this is where the confusion came in. This gentleman had a retroverted femur. It's a minus 11 degrees of anteversion was there. So retroversion was there on the stem. So now we're really confused. As per the stiff spine classification, we're supposed to reduce our anteversion in the cup. But if you see here, the stem is retroverted. So are we going to end up posteriorly dislocating if we put it in a reduced anteversion? So all these questions will be erased once we go into the robot. We feed into these sacral slope values. If you see at 40 degrees, 20 degrees, we are impinging, and because there is a highly retroverted stem. So what we did is we actually increased that anteversion to 25 degrees in spite of it being stuck in sitting. And we found that there's no impingement in standing or sitting. And we went ahead and we got a nice good reduction values. But even then, just to be safe, we put in a dual mobility. And we reconfirmed, we got a 45-25. We had a beautiful stable hip, and we had stability in all the different post captures. Okay, so this is just a brief view of how these anomalies can be taken care of by the robot. And a quick view of our study. We're evaluating now Indian patients to see what categories majority of our Indian patients are falling into. And till now we've collected 72 patients. We found around 6 of them falling into the 2B category. So we are using the robot to operate on these patients without any confusion at all. Thank you.
Thank you, Adarsh. That was an excellent lecture about the THR, robotic THR and stiff spine. May I invite Dr. Rohit Luthra to tell us about how to adjust limb length disturbance with the help of the robots.
Well, good afternoon, everyone. It was interesting talks with Robo in the hip. So let me take it a little further. So limb length discrepancy, we all know, is a thing which can cause nightmares to us and some difficulty in convincing the patient post-op. So what is limb length discrepancy? When the patient has unequal limb length after the surgery of undergoing a total hip replacement, the patient will have unequal limb length and be very unhappy. He might have symptoms like pain, stiffness, difficulty in walking, and a lot of psychosocial problems like depression and anxiety and all. So what is important is, intraoperative challenge for the surgeon is to correct the limb length inequality without compromising stability. We all want a hip to be stable, yet it should be equal to the opposite leg. Or when you're doing bilateral, you want both the hips to be equal length. Both the legs should be equal. So there are various problems which can happen while doing a hip replacement surgery. And if you end up leaving the patient with some discrepancy, especially in the West, the people are trying to get some legal actions against the doctors and extract some money. So same thing, as we know, even our Indian patients are now becoming more and more high demanding, and they also want equal limb length. They want equal treatment. So what are the causes of LLD in THA? So the most important cause is inadequate pre-op planning, implant malpositioning, over-tensioning of the hip, which we all do to avoid any dislocations. We don't want dislocation, which is again a big nightmare. So we try to over-tension the hip, and pelvic obliquity, as we already saw. And the approach, so you can reduce the dislocation by changing the approach. If you are doing a posterior, you can go to an anterior and still reduce the dislocation rate. Also, you can reduce your limb length discrepancy because you can go at the foot end of the patient and measure the limb length. So limb length in conventional THR, when you do a posterior approach or a anterolateral approach, the patient is lying on the lateral position, and it is very difficult for the surgeon to assess whether the limb is exactly equal or not. While if you're doing a supine position, anterior approach, you can still reduce that gap by actually patient is supine, you can go at the foot end and check of the limb length. So it is much safer to do an anterior approach and you can reduce the chance of LLD. Now what are the consequences of LLD in DA? Patients who have unequal limb lengths will always complain of some backache, abnormal gait, difficulty in walking, there's pelvic tilt, and there are a lot of dissatisfaction is there, and patient not unhappy, is very unhappy, and he also goes around and asks for a revision surgery to some certain extent, and other problems which start with limb length discrepancy. So what is unacceptable limb length? Unacceptable limb length is basically for the surgeon, if it is even more than 5 millimeters, we think it is unequal and we are not happy. But for the patient, if it is shortening of more than 10 millimeters or there's lengthening of more than 6 millimeters, the patient is unhappy. And any LLD more than 10 millimeters, the patient is very unhappy. So this was published by Dr. Desai, and this is what the literature says, that if the LLD is more than 10 millimeters, the patient will be very unhappy. So what are the methods to reduce LLD in THA? One is to do a proper pre-op templating, which is very important, intraoperative measuring devices, then patient positioning. Supine position is always better. You can check the patient at the foot end and feel the malleoli. And then there are various intraoperative fluoroscopy, then there is computer navigation, and lastly robotics. So pre-op templating is very important. So all cases you should do a proper templating of the cup, of the offset, of the vertical and horizontal offset, what stem you're going to use, how much neck cut are you going to take. So this will reduce your post-op limb-length discrepancy. Next is lateral position. If your patient is doing a posterior approach or anterolateral approach, your position of the patient should be correct. It should not be moving. The sacrum should be stable during the procedure. You don't want it to move. And correct position involves the surgeon standing behind. And if you're doing an anterolateral, use a leg bag. And that's how your position should be. But there's a lot of eyeballing which is happening when you're doing a posterior or approach in which the patient is lying on the lateral position. So the surgeon is trying to see whether the limb length is equal. He's asking assistant, "Theek dikh raha hai? Is it okay? Am I good? Are we okay? Or how is the limb length?" And you also rely on an anesthetist to just check the sacrum, whether the sacrum is perpendicular to the floor. Is it tilted forward or backward? Then you try to pull the pelvis behind. So there's a lot of eyeballing happening. So to reduce this further, there are other intraoperative measurements, like you use the vertical offset, which is the AB distance, and the horizontal offset with AD distance, to see whether your limb lengths are equal. Still, when the patient is, for this measurement to be equal, you have to make sure the abduction, flexion, and the rotation of the leg is at the same when you checked it before resection and after resection. So your abduction, flexion, rotation should be same, and you usually end up not putting the patient in the right position. So if your abduction or adduction changes by 5 to 10 degrees, the limb length discrepancy will change by 8 to 17 millimeters, which is a very significant value. And more than 13% of patients undergoing a total hip replacement. So this study has studied that more than 13% patients have limb length discrepancies of more than 10 millimeters. So these 13% patients are very unhappy with the surgery. Now next, to reduce further, you can use fluoroscopy, you can take C-arm shoots, you can see whether your horizontal offset and vertical offset is equal on both the sides if you're doing a bilateral. So these techniques have limitations. The position of femur, the position of sacrum, you have to be very calculative and keep on eyeballing. While in supine position, the patient is supine, you can go to the foot end, but there's one problem with this, it cannot deal with fixed pelvic obliquity. So this is a problem which cannot be tackled except when you use robot. So robot is a newer technique, it uses pre-op CT scans, and it helps in accurate implant placement and reduces the risk of LLD. So what robot does, it helps in placement of the acetabulum cup in the safe zone, so you're not going very proximal or distal. It restores your offset, and also it is accurate irrespective of the patient position. If you do it in lateral position or supine, the robot will always be accurate. So there are various studies which say that if you're doing a robotic THR, the discrepancy, the cup position in which ML, AP, and superior inferior is within 1 millimeters range, and the cup orientation also is very good, and also the limb length is not more than 1.6. So this is a cadaveric study which was done for 21 patients in which the limb length was not more than 1.6 millimeters. So coming down to that millimeter is very good. Now coming to the big question of spinopelvic obliquity. So this also is very important if you're doing a THR. So that's a simple example. This patient has already undergone a right hip, needs the left hip further. The left hip is 4 millimeters short, but the patient also has a pelvic obliquity. So when you see this, actually the patient is short by 25 millimeters. And a scanogram shows there's a 25 millimeters gap. And if you try to see the correction, if you use robotics, you can do actual calculations. Now you're trying to match, and there's a 13 millimeter gap as compared to the opposite hip. And if you plan it, so this is a surgery, post-surgery, you correct it, you bring it back to normal. So you're trying to lengthen not by 4 millimeters, by 13 millimeters to correct the obliquity. And the patient gets a good limb length after the surgery, and the results are very good. So that's how robotics helps in planning and getting the equal limb length. So it's improved accuracy with implant placement, reduced risk of LLD, and shorter surgical time and faster recovery. So that's how robotics helped in THR. Thank you.
Thanks, Dr. Luthra. That's an excellent lecture on limb length discrepancy. Any questions from the audience? You can come onto the mic. You can take a couple of questions. In the meantime, my question to Dr. Sen, that many times in this, complex cases, you need bone grafts to be put to augment the defects. So do you think that robotics will make a difference? Because, pre-operative planning you cannot do with the bone grafts. After putting the bone grafts only, then we'll start reaming and you will get to know what is the floor of the acetabulum. So how to go about it in these kind of cases?
Yes, that exactly is the perspective with which we are looking at it, because unlike knee joint, where if you look at the knee joint, that half of the condyle is away from the place and then you plan, then probably it's not being planned. In hip, these are maximum chances that with those kind of defects, you don't have those right anatomical parameters which you will reconstruct beforehand, and then you can have the templating for the cup alignment made. So it cannot be isolated robotic which can be done. It has to be a combined effort of recreating and then getting the robot to align the cup accordingly. That is the way we look at it. It cannot be isolated.
Any of the panelists have got any experience of putting bone grafts
Yes,
or augments
we can,
using robot?
Yeah, we can quantitate the defect also that way, that this is the amount of graft buildup we have to do it out by planning beforehand. That is a possibility.
Okay. And for Dr. Suhas, is there any questions, or we'll just have one question for Dr. Suhas? How do you assess your intraoperative impingement test using robot? Or it's just manual as we do in the manual surgery? We feel it with our fingers, the surgeon's perception.
It will be our clinical judgment itself.
Okay. Others, any add on that?
Yeah, as sir said, like what we seeing the virtual range of motion is pre-operative only. So, but we also have to keep checking intraop because there's soft tissues and things like that. But at least gives us a basic idea that where we can be going wrong if we put in a particular position. So now it's called like the functional placement of the cup, like functional alignment in the knee. The term has come as functional placement of the cup, depending on each patient.
Okay. Dr. Rakesh, yeah.
Yeah, I've got a question for Dr. Kamble first. You told that you can change your version of the cup depending upon whether you are stuck in sitting and standing. So I want to ask you, how much can you change? Can you put a number to it? That this is the amount of degree I would maximum go?
Yeah, I mean, as per our standard teaching with every, 0.9 degrees of version for every 10 degrees of tilt. That is what.
How much maximum will you go?
Can I answer, sir? If you're.
Yeah. Is there a maximum limit of version that you can give?
Yeah. So I had another case, a dysplastic hip, where the femur was antiverted almost like 20 degrees or something. Antiverted, like very highly antiverted. So usually we don't reduce our antiversion of our cup more than like 15 degrees, but that case we actually brought it down to 8 degrees of antiversion. And we still had a very beautifully stable hip because we were compensating the excess antiversion on the femur. So even brought it down to 8, seeing that virtual range of motion. So we have that freedom to move around.
The others, do you just, in addition to that, so when you reduce to 8 degree, do you look for any combined antiversion there on the table?
That's the thing. So it gives us that combined antiversion as well because it's giving us the stem antiversion as well as the cup combined came up to still 25 degrees. So we were quite happy. Just about 25 degrees.
But it is difficult to adjust the version of a uncemented stem on the table, correct?
Correct, exactly.
Usually it matches the proximal anatomy of the femur, unless you do a cemented kind of hip.
So that's why we compensated on the cup by using the virtual range of motion, and it gave us a very stable.
But the non-robotics would do osteotomy and actually do the correction.
Yeah, and
so
you would be
that's
scared
how
to put it
we've
down.
all grown up, and you should correct where it is problem. If it's the problem is the stem, correct it in the stem. Why change cup for that? The cup should be only changed if the spinopelvic parameters are problem. Let's say if there's a sitting stuck in standing or sitting stucking, and as far as I knew from my studies, it's a 10 degree maximum I could go. But in some of the cases you were showing, there were extremes to that. So I was asking if we can push, because I have a robot now to check impingement and all that.
Sir. So we had pushed, so that's what I wanted to say.
Yeah, so a question to you, Adarsh. You were showing in a case that you had a bilateral ankylosing and there was a leg length discrepancy of 1, but the other side is not normal. That's
Correct.
already shortened.
Correct.
So how do you take that into account
So
then?
we know that we're going to operate on the opposite side. So we aimed for around 5-6 mm of lengthening. We were okay.
So you would lengthen this one?
Yes, we lengthened. We note this and we match it on the opposite side.
Okay. And the last speaker, Rohit, you had a pelvic obliquity. Did you find out before, is it fixed or thing? Because when we do a normal conventional THR, we tell them that even if you're a bit short, because you've been walking with a abnormal, you will gradually stretch out. And we've seen this, the shortening or the lengthening, in fact, would actually correct over a period of time. But in robot, you are actually planning to correct it there itself on the table. So then that means you will force that patient to remain like that.
So this is a fixed pelvic obliquity. So
this is a fixed one.
So for such cases, you have to actually change your plan. If you do it in a routine way, so you will end up undergoing. It'll still be short. So you have to overcorrect. Basically, you're trying to overlengthen it so that you match the opposite thing. And one more point, in case for discussion. So like your first question, you asked that if the problem is in the acetabulum, why not to correct in the femur? So in such cases, I think we can use a round long stem as we discussed. So maybe a distal fitting sort of stem, which you can dial in. You can like a cone, like a cone Wagner.
Very well useful, particularly for these sort of issues.
Wagner. So
it's both fixing, both proximal and distal.
So to question to all of you, can you do a cemented hip using robot, or it is not designed for that?
We can, sir. It allows you to do the exeter hips if you want to do it. You can do it.
Yeah. And question to Dr. Rohit. Whatever you showed about, robot assisted, indirectly you are telling that, the limb length is restored and all because of accurate positioning of the cup and all these things. But directly, does the robot help to restore the limb length like we do in conventional surgery, Ranawat's method, Armstrong's method, even Bijabos method?
Yeah. So all these methods which are described, like the measurements, so these can vary with the limb abduction or adduction, the way the patient is kept. So you have to exactly match the before taking the neck cut, what it was, and you have to match it after placing the implant. The limb should be in the same position, which you usually can end up, because most of the time when you're doing traction, reduction, the pelvis moves forward or behind. So you can lose that position. In the pelvic tilt can also happen, or the pelvis can get tilted. So to avoid that, the robotics will definitely place the implant in the right manner, because you're comparing with the CT scan. So when you're planning it like that, you're doing a proper planning and you execute it the way you want it to be. Yeah.
Sorry, you want to go?
Yeah,
please go.
To be honest, many times, I mean, we cannot assure the patient about perfectly equal limb length. There is a chance that there can be about 10 mm, 1 centimeter discrepancy can be there. I mean, it is impossible to eliminate in every case.
Correct, sir. But at the same time, yes, you can do the pre-op planning, but in the enhanced workflow, it will also tell you that you have matched this much. You can actually see it real time as well, because you're also registering the femur. It even knows the position of the femur as per the pre-op position. So it tells you the real time as well, if you're matching or not.
Finally, one final question before you close, that how do assess the soft tissue laxity using robot, and how do you address that? Like we do shock test on the table and we adjust the offsets. How do you do that?
That's where the surgeon comes in. We can't let it do it on its own. We have to have our feel as well.
Thank you. Thank you, panelists. Thank you, audience, for an excellent session on robotics in hip surgery. Thank you all.
A big thank you to all our speakers and moderators. I would like to request Dr. Srirang to felicitate Dr. Nikhil Likhate, please. So we've all eminent surgeons now. Now we'll be going live with Mr. Andrew Burton, who's going to be talking on the perspective of engineer's perspective on whether robotics will be useful. Over to you, Mr. Andrew.
Hello there, and good morning. Can everybody hear me okay?
Yeah, we can hear you fine. Good morning.
Fantastic. Good morning. My name is Andrew Burton, and I'm actually, while I have an engineering background, my disclaimer is I am now Director of Marketing for Vestigial Surgery here at the PUNE Synthes. And the title of the talk I've been asked to talk to today is Robotics in Total Knee Arthroplasty. Will they be useful? We've been pursuing innovation in the OR for decades, and until relatively recently, the majority of that innovation has been focused on providing implants that are backed by clinical evidence and designed to keep people moving. As an industry, we are now elevating the clinical experience by combining implants with tools and technologies to enable more accurate, efficient, and reproducible surgeries. Also, as an industry, we are accelerating our focus to address unmet needs before and after surgery to further advance the patient experience and their outcomes by creating connected technology platforms to capture data and generate meaningful insights to make surgery smarter and more personalized. But that vision can only become a reality once we have interoperative tools that accurately and precisely execute surgical plans, but importantly, do so effectively and efficiently. I don't just believe that robotics are useful. I would go as far as saying robotics is crucial to realizing the potential that technology can bring to total knee arthroplasty. As you all know, arthroplasty robots have been available for a number of years, but many of the solutions are complex, cumbersome, and costly. Many of the solutions add OR time, have complicated preoperative planning tools, long learning curves due to the complexity of the solution, and some have the requirement for additional imaging and therefore radiation exposure for patients, and of course the associated costs to the hospital. Last year, DePuy Synthes launched its TKR robot into India, the VELYS robotic assisted solution, which is accurate, precise, and reproducible, was designed to ensure surgeon autonomy, or surgeon control throughout the procedure. There's no requirement for a CT scan or any additional technicians in the operating room, and it's incredibly compact in terms of its footprint, which allows it to be portable between ORs, particularly for surgeons wanting to run multiple operating rooms at the same time. Since our first clinical cases in the US back in 2021, we're now seeing patients, surgeons, and hospitals benefit from the efficiencies in OR time, recovery periods, and patient-reported outcomes. We are actively building out our VELYS robotic assisted solution platform, and we announced to the analyst community earlier this year that we'll be launching our unicompartmental clinical application in 2024. So, coming back to the title of this presentation, will robots be useful? I would say yes. And to help me justify that, let's focus on how they address accuracy, efficiency, and outcomes. Robotic TKA has been shown to improve implant alignment and positioning. Both Chin et al. And Agarwal et al. Published a meta-analysis of robotically assisted surgeries versus conventional total and unicompartmental knee surgeries, and they found that robotics increased the accuracy of implant alignment and surgical reproducibility, which they claimed can help shorten patient recovery and reduce post-operative complications. They also found that robotic TKA can help achieve desired component alignment and positioning more often robotically versus manual TKA procedures. At DePuy Synthes, we also found that through a 80 cadaveric knee study, that when using the VELYS robotic assisted solution, there was a statistically significant improvement in the ability to achieve target alignment with robots versus manual instruments. And that data was published by Doan et al. In the Journal of Arthroplasty just last year. With the addition of any technology to a hospital, we need to understand that the technology will create value for the system. There are many studies that show robotic TKA can be associated with reduced lengths of stay, more optimal discharge destinations, reduced readmissions, and reduced healthcare visits. Pierce et al., for example, showed a statistically significant reduction in hospital stay and associated costs with robotic TKA when compared to manual TKA. And Cool et al. Showed a decrease in both discharge to rehabilitation units and nursing facilities, creating significant efficiencies and savings for the hospital system. And then finally, patient outcomes. With robotics having been in the market for a number of years, there's a good amount of evidence to demonstrate that robotic TKA can improve patient outcomes and, in some studies, improve prosthesis lifespan. The first ever use of the VELYS robotic assisted solution, the first user of the VELYS robotic assisted solution, Dr. Mark Clatworthy in New Zealand, recently published his early experiences with the robot and compared them with a cohort of his patients where he'd used the BrainLab Knee 3 navigation system. He showed that using the VELYS robotic assisted solution led to reduced pain with activity and improved function at 2 and 6 weeks when compared to navigation, no significant difference in surgical skin-to-skin time, and a positive trend in patients assessed at 1 year, specifically around patient satisfaction and pain score. So clearly, we can achieve improvements in terms of outcomes even when compared with an elevated comparator such as navigation. We're at the beginning of a digital era in orthopedics, and we're starting to see clinical applications that will allow us to elevate the standard of care for patients throughout their entire treatment pathway, from pre, intra, and post-op. Robotics will be a significant element of the future of digital surgery, and with the right robot, we're able to improve accuracy, economic efficiencies, and patient outcomes. Thank you.
Thank you, Mr. Andrew, for that beautiful presentation. Are there any questions from the audience? So there seem to be no questions, Andrew.
Okay.
Thank you so much.
You're very welcome. Thank you.
So our next speaker would be Mr. Ridit Mitra, who's also going to be speaking about an engineer's perspective. Mr. Ridit, can you hear us?
Hi, good afternoon. Can you hear me?
We can hear you loud and clear. Though we don't have any video.
Oh, let me try that once again.
Yeah, we have the video now. Yeah.
Okay, awesome.
Can you please share your screen?
Yeah, give me 1 second. I'm going to be sharing my screen at this point. So let's do that. All right, can we see my screen now?
Very well, yep.
Great. Well, firstly, thank you so much for having me here at the 4th International Symposium on Robotic Joint Replacement. I would like to thank Dr. Narendra Vaidya for his kind invitation and his continued collaboration and engagement with the industry on the robotics front to take orthopedics to the next level. I would also like to thank the Society for Robotic Arthroplasty, the team at LOKMANYA Hospital, Pune Orthopedic Society, and many others who have helped make such world-class symposiums such as ISRJR possible. With my background in robotics, AI, and computational engineering, I'm here to share my perspectives as to where we see, as a part of Smith & Nephew, the robotics industry going in the space of orthopedics and healthcare. And the future of technology will be shaped by the macro trends we are experiencing in the space of healthcare today. And to begin with, one of the major trends is that of a shift in point of care. We are seeing globally trends towards more elective procedures moving to outpatient settings, with reduced length of stay being a primary focus. With careful selection of patients and further enhancements in surgical techniques and procedural improvements in recovery and safety, we expect this trend to continue to percolate globally. Over the past decade, we have seen trends of rising consumerism, where we as consumers of products and services have more knowledge of choices and are selective with options that are more personalized to our needs. This is seen with the rising levels of engagement in surgical selections with higher expectations are the type of care patients can receive in the US as well as private pay patients across the world. And of course, with the growth of robotics and the fundamental adoption of robotic surgeries. When knee and hip replacement surgeries are following very similar trends as other healthcare industries that have seen robotics become standard of care. As we stand here today, more than 30% of knee replacement surgeries in the world are being performed robotically as per healthcare reports. And finally, another major trend being acceleration of healthcare technologies and investments, where we have almost seen a 3 times growth of investments in robotics, artificial intelligence, augmented reality, and digital health solutions, which we anticipate to continue shaping the orthopedics market over the next 5 to 10 years. And this is leading to a new definition of value that is expected from customers, which are surgeons, which are patients, for our implants and technologies. Traditional value creation was defined as the quality of a product or service and the outcomes it provided, divided by the cost of said product or service. But now, it is trending more towards quicker innovation due to more data from surgeries, a stronger relationship and partnership between healthcare industries and surgeons such as yourself, leading to a generation of meaningful data through and from technology that drives innovation and value creation. And it is this new definition of value that stems the new era of change in our design and development thought process for the industry. Traditional product design and development in the medical sector has been perceived as slow moving, but is now morphing into a much faster paced revolution of connected, intelligence, and automated products that serve an ecosystem of care. And this is where the combination of implants, material science, design personalization of those implants to anatomic characteristics of patients, but also with intelligence and standardization of techniques with robotics planning, balancing, and smart execution comes into play. As a part of Smith & Nephew over the past decade, we've had more than 20 launches in the market, averaging about 2 launches a year, along with the only second-generation robotics system with CORI as a platform solution to scale robotics to support knees, hips, and other indications. In the space of knees, CORI supports partials, totals, and is the only robotic system that's FDA cleared for robotic revision replacement surgery in the knee space. And in terms of the near future as to where we see this technology going, stemming from the thought process of value creation, we see, and we have just launched personalized planning in the US that is powered by AI. And we see that as our future. And the way it works is that beyond just looking at alignment in a 2-dimensional plane, in the coronal plane when someone is standing, with CORI surgeries, we have the ability to analyze data, the surfaces that a patient has, the ligament laxity that a patient has in 3-dimensional space, and see the changes and personalization choices that US surgeons are making for different categories of patients. And when clustered using machine learning principles, we are able to get more information and get engines built behind it that can look at patients with similar deformity classifications in 3D space and allow you as a surgeon to personalize a plan that belongs to that patient for your philosophies and their preferences. And to show you how it works and how we've built it all together, we've made these AI clusters available in CORI in a stage called personalized planning powered by AI. This is now a part of your profile in the system, which will allow you to select the implant of choice and the type of deformity you want to personalize for. And from there, you can choose your philosophy for where CORI will start your patient's implant plans. As you do more and more cases, this algorithm just keeps getting stronger within your system. And you can personally change these starting positions and preferences for different deformities. And this is just the start of the journey for us in AI. We also recently announced the launch of our CORI digital tensioner in the US, which is the first and only device for robotics that can measure ligament laxity consistently before making any bony cuts. So with tools like this, you can quantify the gap balance in a knee and use that data to guide all your cuts on the femur and tibia so that you can optimize space and cuts with the potential of reducing the amount of ligament releases. And this before any cuts have been made. And this robotic procedure with consistent balancing, AI tied to our solutions, we believe will shape the next frontier of 3D plane personalization with soft tissues in consideration. all of it powered with robotics in your hands. And while we focus on improving efficiencies with handheld milling and add more techniques of bone cut execution, we are also fundamentally looking at procedural efficiencies that we can bring in today, where we are building tools that add value to the CORI surgical system. Speaking similarly on the knee space, we are building tools that can bring pinless bone tracking as an option into your practice with CORI. And not only that, add solutions so that you can utilize tools to have fast, efficient execution within a robotics platform with saws. And then you can adjust those guides so that you can make saw-based cuts, but then finally fine-tune with handheld precision milling. And that ties in all together to have an end-to-end complete procedural solution. We have launched our revision knee application and indication with the CORI system in the US and scaling globally very shortly in the near future. And not only that, but the CORI system is a single platform that also supports hips. In the hip application side, we have two fundamental elements. One, our image-free pre-op planner, which is our RI hip modeler. With the RI hip modeler solution, surgeons are able to now look at implant choices of cups and stems and their selections of neck lengths and inclination, anteversion, and stem version, and really see for different activities of daily living, which you can see on the bottom right-hand side quadrant, what are the potential chances that a patient might impinge. Now, while this is implant-to-implant impingement, the key is optimizing that goal. Because if we can optimize that goal and aim for precision of what should a plan be, then we can execute that with handheld tools with the CORI system with RI hip in the intraoperative space. And that is where we've started our journey with hips, but expect to continue the same and continue building upon it and add more robotic elements onto these applications. And that really drives down to the goals that we have and the vision that we have, which is delivering transformational technology solutions to our surgeons to serve our patients to live life unlimited. Evolving this with tools, with digital tools, with outcome assessments, as well as digital apps, we are really looking at shaping the future of orthopedics with robotics. And all of this will be made available for you to analyze with our data outcomes platform called RI Insights. And as we look further into the future, with RI Insights that is available in select markets today, not only can you see the types of cases that we are doing with robotics and the amount of time we're taking, but we have tools to essentially look at previous cases and say, how have I treated patients within a certain category of, let's say, varus or valgus and certain gap deformities? And not only can we look at within those conditions, how have you as a surgeon specifically treated patients, but also look at how has a region and a geography or the entire world been treating such patients, and then tie that back into the system. And that essentially is where we see man and machine working in perfect harmony. This is where artificial intelligence, along with robotics, machine learning comes together in your hands to provide our patients with real intelligence for their surgeries. And that is where we see the future going in Smith & Nephew. Thank you so much for your time, and thank you for the invitation to allow me to speak at ISRJR this year. So with that, I'll stop there and see if there are any questions.
Thank you, Mr. Ridit. I don't see any questions, but thank you for joining us. We'll be moving on with our next session. I request Dr. Ashish Suryavanshi, Dr. Satish Kale, Dr. Vikas Sonali, and Dr. Pachanke to join us as moderators. I invite Dr. Shubhranshu Mohanty sir to present his talk.
So, good morning, dear friends. So, I'm going to talk to you about whether we require robots for a total hip replacement surgery. Now, why are we talking about this? Because as we know that from the literature, the incidence of dislocation in the hip replacement or primary total hip replacement is to the tune of 1 to 4% at different centers. More so, now for the last couple of years, we are talking about functional anteversion, spinopelvic relationship, and we discussed it during the earlier sessions today as well. Now, basically now Mako system has provided us software to do a, total hip replacement with assistance of the robot. Roja, though they have a, software system to do a total hip replacement surgery, it is not yet available in India, I believe. And Cori also they have developed, but it is not yet available, and I couldn't find any publications related to the total hip replacement with a Cori assisted robot system. It is yet to come to India as well. So basically we will focus on the Stryker, Mako and Zimmer Biomet Roja system and conventional hip system for comparison. The first thing is the preoperative planning. What Mako system, it is based on a city-based planning before the surgery. It has got additional costs of doing a CT scan, additional radiation exposure, and of course it reduces the operating time. So what you plan the acetabulum, and you know what is the placement of the acetabulum, the orientation of the acetabulum, and on the femoral side you only decide about the neck cut, but it doesn't tell you about the femoral anteversion. Whereas Roja, though it doesn't have a city-based planning before, so that reduces the preoperative radiation, but intraoperatively it depends on the intraoperative fluoroscopy. So again, there is additional radiation exposure to the patient, though the cost reduces, but the intraoperative time increases because of intraoperative fluoroscopy-assisted, decision about the placement of the cup. Whereas in the X-ray or digital planning, what we do manual planning by drawing these lines in interteardrop line and various other lines in order to restore the center of rotation of the hip in all the three axes, like restoration of the center of rotation in vertical offset, horizontal offset, as well as the anteversion or anterior offset. Next, we come to surgical preparation and approach. Mako system permits you to do by posterior approach as well as by direct anterior approach, whereas Roja system is only designed for direct anterior approach at present, and probably they are developing for posterior approach. Whereas conventional surgeons, they can approach anyway, posterior, anterior, anterolateral, direct anterior, trans-trochanteric, blah, blah, anything you can want, you can do extended trochanteric osteotomy also. So in that way, conventional approaches are more versatile compared to a robotic system. Let's come to the surgical technique. In Mako system, you first do the registration and then do the cup, decide about the cup placement and the version and inclination of the cup. So that is then you just directly you take a reamer, and depending upon size of the reamer, only one reaming you do and put the cup directly into the acetabulum. So in that way, this part of the Mako system is the most versatile system, and it is very useful probably with the assistance of the robot. But on the femoral side, you have to do a sequential broaching like you do manually. And of course, we do not have any software probably for the cemented hips. Whereas on the Roja system, you have to use a C-arm intraoperatively, so fluoroscopy guided, you have to decide of the position of the cup. And on the femoral side, again, sequential broaching, and there is no, assistance for the cemented hips. Whereas conventional system, you do sequential reaming, go from a smaller size reamer, gradually increase your size of the reamer. So in which each reaming, you get a feeling of the, your reamer placement, so that you feel that the anteroposterior wall has got a good fitting of the acetabulum, and that provides the stability of the cup, the feeling of the stability of the cup. And on the femoral side also, like any other system also, you do a sequential broaching, and of course you can do a cemented cup and cemented stem on both the sides. Next, the intraoperative test, that what we do, we measure the vertical offset, measure the horizontal offset, and see the flexion, abduction, in external rotation in order to look for impingement posteriorly on the posterior lip of the acetabulum, do a abduction to look for the greater trochanteric impingement on the supraacetabular margin. Then you do a coplanar test of combined anteversion in about 15 degree of flexion, and in about 30 to 40 degree of abduction, in 30 to 40 degree of internal rotation, your margin of the acetabulum and margin of the head remains coplanar. This is the shock test to look for the overall tissue stability, soft tissue stability. This is the over test to look for the tightness of the fossa lata. And finally, you do a flexion, adduction, and internal rotation
to look for the impingement anteriorly along the anterior acetabular margin. So all these tests is a feeling of the surgeon, and no robots provide assistance in order to check for this, soft tissue test, what you do for impingement in order to prevent a dislocation. Now, intraoperative limb length disturbance, we follow the traditional Dr. Ranawat method, where you put a Steinman pin in the infracotyloid notch before dislocation, and again you check it during the trial reduction whether you have achieved your limb length disturbance or lengthened or shortened. And or you can do a Amstruz method or a Bijay-Bose method, whatever method you can follow, whereas your robot do not give you any direct measurement of limb length discrepancy. So the current controversies which are remaining, that accuracy of the implant placement in more challenging cases like ankylosing spondylitis or dysplasia, there is a possibility of development of heterotrophic ossification, because you need to have a greater soft tissue exposure from the pelvis in order for the placement of the pins. And leg length discrepancy, as I told you in the earlier part in my lecture, and the functional outcomes equivocal both in the conventional and robotic system. There is a possibility of increased operating time leading to increased blood loss and the infection rate, and of course the cost benefit analysis, how much your cost is weighs against the outcome for your patients. These are the challenging cases like protrusio, post-acetabular fracture and ankylosing spondylitis cases, where you need to restore the center of rotation, your vertical offset, horizontal offset, as well as the anti-version or anterior offset. Manually you will do much better job rather than using robots. In our study, we studied our outcomes in younger patients less than 35 years in 2017 in 110 hips, 110 patients, 160 hips, and the maximum age was less than 35, and minimum 5 years follow-up shows that our average acetabular inclination was around 40 degrees, anatomical anteversion was restored in about 82%, and limb length discrepancy was within 0.6 centimeters. But incidentally, we found 0.5% patients who were able to sit cross-legged and squat. And this is one of the patients, 32 years old male, avascular necrosis, 4-year follow-up shows using a 32 head that there is no impingement, and we took the X-rays in squatting and cross-legged sitting position. The cup placement, there was no impingement, he was able to do ground level activities. Moreover, some of the cases like 67 years old man, cemented total hip replacement, and this is 6 years follow-up, so he is able to do all squatting, his, all the toiletry activities in squatting position for last 6 years. That is because of the cup placement, and there is no impingement, and hence it doesn't dislocate and less of wear. So again, I go back to my editorial in the special issue of arthroplasty. I was a guest editor, so I conclude that march of robots in total joint arthroplasty cannot be ignored. We need to change with time, use these technologies to the best of our ability to enhance our technique and outcomes, and one must not go away from the basics and fundamental as principles of arthroplasty, and of course we need to see the eventual benefits in terms of patient-related outcomes. Finally, again, for the beginners who are confused, less than 5 years, post-MS, you need to at least do 50 to 100 hips using the conventional, technique. You need to understand what is vertical offset, what is horizontal offset, what is anteversion before you, march onto the robots. Those who have adopted already, they are evaluating their outcome, they are improving on their outcome using the help of the robots. And the third group like me, we are observing that we are seeing, we are evaluating our results, and we are seeing that whether the robot can give a better result than what we have done in our last 20-25 years or so. And most of the seniors who have already decided not to take robot, of course the robotic hand doesn't reach them until now. I thank you for a patient hearing, and again I appeal you and request you that to provide your kind support for my endeavor in the Indian Orthopaedic Association elections this year for the post of Vice President. Thank you. Yeah, Adarsh.
Yeah. So I absolutely agree with you. Said we should not jump to this without doing at least 100 conventionals, and definitely it's not required to do it, but it just helps us. Few points that I just wanted to, maybe the latest software have negated a few of the points that you had mentioned. For example, approaches, we can do hard hinge, posterolateral as well as DA as well. Cemented also can be done, exeter stem is allowed to be done, but the cup obviously not. The limb length discrepancy with the enhanced workflow, we can also check that intraoperatively. And about the pins, there's only one pin array which needs to go into the pelvic in the iliac wing. So there's not much chance of, there's not too many pins there. It's just 3 pins in the iliac wing which doesn't cause any heterotrophic ossifications.
Yeah, these are the suggestions which I found from the literature.
The latest updates are these.
These are the concerns about robotic surgery at present in 2022, 2023.
Right.
Yeah, Dr. Suhas.
Even the incision, you said a larger incision is needed. I don't think so. There are offset trimmers which will make you remake through a smaller incision. Even a MIS technique is definitely possible with that. So the length of incision.
No, I never told in my presentation that you need a larger incision. I told approach only. Posterior approach or direct anterior approach. Incision I have not told. Today at least.
Yeah, thank you, sir, for a wonderful lecture.
Okay. Thank you. It was my last lecture, and again I thank Dr. Vaidya and team from LOKMANYA Hospital for this opportunity. Thank you all.
Thank you, sir, for sharing your valuable insights. I now invite Dr. Adarsh Annappareddy to please deliver his presentation. It will be a live inbox robotic assisted UKA.
Once again, thank you for inviting me here today. So I'm going to try to summarize a robotic partial knee with a Stryker Mako robot in just around 14 minutes. So I have to have the audio for this video. Can I just play with the audio? And if you want to ask questions in between, I can pause it and we can go ahead. So today we're going to be demonstrating a robotic partial knee replacement surgery with the Mako. It's a right knee. And the varus X-ray is showing collapse of the medial compartment. There's no collapse in the lateral compartment. So this is a 67-year-old gentleman with medial joint line pain. So let's confirm our findings once we open the joint. So this is the beauty of a CT-based robot. You can do your planning pre-operatively. So this is a pre-op planning that we're going to do, which helps us with the sizing beforehand. And after the ligament balancing is done, we can modify these. So first we start with the tibia planning. So as you can see, we're using a size 3 tibia, and here you have a transverse view, you have a coronal view, you have a sagittal view, and you also have a 3D view. So now let's see if a size 3 is actually fitting. This is a CT based robot, so the product specialist has done the segmentation of the CT slices and made a 3D model, and he has done a tentative planning according to the model that he got. So now let's see if the size 3 is matching. Let's scroll through. Keep scrolling, keep scrolling, keep scrolling. You can see that the magenta line is right outside the implant. And we're not overhanging and underhanging. If anything, you can downsize and adjust it later. Okay, if you look at the sagittal view, the slope is around 7 degrees, matching my native slope. I'm quite happy with that. The proudness, if you see, of the tibia is 3 mm. We are allowed to go in a range of 2.5 to 3.5 mm proud. If you go anything lower than 2.5 proud, then we'll be cutting too much of tibia. This looks good for me for now. Let's go to the femur. Okay, let's scroll. Again, you have the same transverse, coronal, sagittal and 3D views. Can you scroll through the transverse view, please? You can see a nice, the other way. Keep going, keep going, keep going, please. Keep going, keep going. Yeah, you can see a nice fit over there. And in the 3D view also, you can see that it's nicely fitting. So if you see the sagittal view, the magenta line is nicely bisecting the implant. The part of the implant which is outside the magenta line is where the cartilage would have been were it not worn out. So my pre-operative planning of the femur is also done. So this is the OT layout. I have my MPS, that's my Mako product specialist over here. That is the camera, and next to it is a screen which I will be seeing. This is the robot, the Mako robot behind me. This is the deformity of the limb. If you can see, there's no FFD recurvatum, and the varus is also a correctable varus. So this looks amenable for a partial knee replacement surgery, which we will confirm again once we take a incision. So my incision is slightly smaller and medial to what I usually take. Regular medial parapatellar orthotomy. Sorry, you want me to mute? You had a question?
Yeah. In planning graph, you have shown 7 degree of slope. You usually keep 7 degree of slope in every patient, or you change?
It depends on the patient. We can match the slope. We are allowed to go up to 10 degrees in Indian knees. And international knees, usually they give a limit of 7. But here we have a leeway of going up to 10 degrees if required. But we just try to match the native slope as much as possible.
And femur also, you lateralize the component, or you?
Yes, that depends on the tracking. So at the moment we just keep it in the center of the condyle. As I'll show you when I go ahead, if the tracking is not good, I can adjust it, which I'll show you once we go ahead. So what I've showed you till now is only the pre-op planning, which we haven't even taken the incision. That's the advantage of the CT-based robot.
Adarsh,
yes, sir.
I have a question for you. You've shown pre-op X-ray. but one can clearly see patellofemoral compartment is involved in it. I think it looks like arthritic completely. And the lateral compartment also doesn't look very healthy to me. So what are your stringent selection criteria for UKs?
So first of all, we don't do MRIs. We keep TKR ready at all times, including robotic cases. We segment for a TKR as well.
Okay.
But after, we used to get Oxford series done, varus and valgus stress, to see if there's any closure of the lateral compartment. But now just looking at the AP X-rays, we're able to get an idea. So once I open, I'll confirm my steps.
Okay, the lateral shows it clearly, patellofemoral.
It was not much at all. I'll show you in the case.
Okay.
Maybe a small ulcer. I don't mind a small ulcer.
Osteophytes are there. You can see superior and inferior patella.
It's not a contraindication for us.
Okay.
We don't keep that as a contraindication.
But it won't affect future,
no.
patient pain or flexion extension?
We haven't had any issues with that at all.
Okay.
Yeah. I'll just show you. Intraoperative findings also I'll show you now.
Hello, Adarsh. One more. Here.
Yes, sir.
Yeah, you're using CT in this Mako, I think.
Yes.
So the requirement for CT is like something slice, like it is recommended that this slice CT should be used, otherwise it will hamper your pre-operative planning.
Yeah, so they don't require too many slices. They have particular. I don't remember exactly how many slices they need, but they just need to take a few slices through the knee joint and one slice near the hip, so that you have the mechanical axis as well. So they've actually done a study where they found that the exposure to the CT is not much more than an X-ray. So I can share that details of that paper as well. Yeah. Important thing is to check whether we're amenable for a uni. So I'm going to flex and check for my 3 criteria. My first criteria is a medial bone-on-bone arthritis. As you can see over here, it's worn out completely. The second criteria, small ulcer on the patellofemoral, which we don't consider this, we don't mind going for a uni in this kind of cases. Is the lateral compartment should have pristine cartilage. There's no wearing out over here. The most important, the ACL should be intact. I'm going to put in 4 eye pins. Okay, these are 2. The 4 finger breadths above the femur and 4 finger breadths below the tibia. We have to attach what are known as the arrays. Okay, so these are visa discs. The camera has to be able to see visa disc very clearly. I hammer it in. These are the checkpoints, the femur and the tibia. This has to be in a place where it does not move during the case. And now I'm putting in my tibial checkpoint near the tibial tuberosity. Again, we should make sure that after we hit it in, it should not move throughout the case. As you can see, as I'm making circles, it is registering the center of the hip. Yeah, please.
As you can see, there is an ulcer in the patellofemoral. But if a preoperative symptom is pain while getting up or climbing stairs, then does it change?
So, as we mentioned, if the symptom is there, then I don't even think of the uni. When I ask a patient if he's able to pinpoint it's only on the medial side, then only, even if the X-ray looks like an AMOA, if he's showing vague symptoms, I won't go for uni. But sometimes they just show this is the point, the medial. For this patient who is having that kind of a pain, so then even if I see an ulcer like that, I don't mind going for a uni.
Okay, thank you.
So Adarsh.
Yes, sir.
Yeah, you have placed the pin in distal shaft. What we are saying since 2 days that the femoral pin should be in the metaphyseal region. So Mako don't allow it to put it in metaphyseal.
You can do intra-incisional pins as well. I found this quite it's just 2 stab incisions, and it's far away from the field. It gives me a more area to play around with.
Yeah, but the literature said that the pins in the like distal third has having a disadvantage.
You mean the tibial pins?
No, the femoral pins.
Okay, right.
So it has having a disadvantage of getting a fractures. So most of their surgeons have changed their method to put it into metaphyseal region just because of that.
Some of my colleagues do put it intra-incisional. We have done more than now 5,000 knees, TKRs and partial knees. We had only 1 pin fracture. That was also because of faulty placement. Okay. So we've never faced that issue actually.
I think one thing we should remember is that most of the UK has a minimal access surgeries.
Yes.
We are already making a bit bigger to actually map the femurs. So we should probably put the pins out because you don't want to unnecessarily put incisions because you want to get the pin in.
Yeah, in the uni definitely I agree.
I was going to point something asked about you said you point at the medial side. There are enough studies, and one was done by Azunin from Bristol, that clinical where patients point has got actually no relevance because we were doing this study in relevance to actually patellofemoral arthritis because we were selectively developing called A1 patellofemoral replacements. And we found that even in selective patellofemoral, well, absolutely radiologically you have normal looking both medial and lateral compartments. They are still pointing to the medial side as the area of pain. and they have patellofemoral. And even they were not complaining of symptoms going up and down. So all this trying to correlate symptoms with where the disease is absolutely useless.
But we've not found any issues with the anterior knee pain in these patients, sir. That's what I was trying to
It won't
mean.
be an issue, that's what I'm saying. This is a different pathology.
Got you.
So even if you have radiological arthritis, unless you have lateral bone on bone, it doesn't make a difference.
Yeah. I'm going to feed to the robot some other major landmarks. So I'm going to use this green probe, which is a blunt probe. So here it's similar to the Cori in terms that you're feeding the major landmarks in. The malleoli
So now
and the
the robot
checkpoints.
has some idea about where the medial malleoli and the lateral malleoli are. It's going to have an idea about the mechanical axis of the limb. I'm going to use this sharp blue probe for the fine registration. I'm going to use this foot pedal to help in my registration. So this step is to make sure the robot knows that the CT scan is matching the real-time bone. So that is called as registration.
So the difference here between this and the Cori is instead of painting it, we're just mapping 40 points, and because the CT scan is already there, we're just overlapping the real-time bone onto the CT scan. Unless we have an accuracy of less than 0.5, it will not let us move forward. That's a fail-safe mechanism. So if you see this
Now the fine registration part is done. If you can see here, the accuracy has to be less than 0.5 millimeters. Only if it's less than 0.5 millimeters accuracy will the robot let us go forward. Now we have a step known as verification, where these 40 points are conglomerated into 6 bubbles. We have to burst these bubbles.
So this is done, it takes another 5 seconds. And then we go on to the tibia. Again, the same procedure where we're taking 40 points. So here, somebody had asked earlier whether we need to be on the exact spot. The placement of the bubble is not important, it's the depth is more important. We have to reach the cortical bone and capture.
See, my accuracy is 0.3 again. Now I do my verification step. Okay, so now my registration step is done. Now you can see my knee moves in real time. So whatever I do here, it reflects on the screen. So this is what we are aiming for by registration. Now it's important to take out the osteophytes. So now I'm removing the osteophytes.
So we don't remove the
It's important I
osteophytes
take
earlier.
out these osteophytes after registration because the CT scan was fed to the robot with the osteophytes intact. So 6 degrees flexion and 9 degrees of varus is my native deformity. I take a screenshot of the deformity. And now I have to take 4 post captures and throughout the arco motion to see. So I'm going to give a valgus stress to see how much it's correcting. First in 10 degrees of flexion, capture.
So we're seeing how much correction we're getting at
45
each
degrees
post
of flexion.
10
So I'm
degrees,
putting the
45.
limb against my abdomen so that I can get a nice control over it. And capture. It's coming to 4 degrees, then 90 degrees of flexion. Can you capture that? And finally at 120 degrees of flexion, capture. There you go. Okay, so now we're going to see a graph. So the first thing I like to look at is this balancing graph. Now each bar is one of the post captures that we took. So the first one is at 10 degrees, second one is at 45 degrees, third one is at 90 degrees, and the fourth one is at 120 degrees. Anything above the line means in that post capture the joint is very loose, and below the line means that post capture it is tight. Our aim is to get around anything above the line 1 to 1.5 loose at each position is very ideal. Now I can play around with my implants to get these desired gaps. Now as you can see in extension, that is 10 degrees of flexion, we're at around 1.1 loose, which is okay. So I don't want to move that at the moment. At 45 degrees and 90 degrees are quite tight. So what I would like to do is anteriorize my femur, please. You see as we're anteriorizing, it's becoming a bit loose. Keep anteriorizing.
So as I go forward, you can see.
Now make the femur less proud. There you go, lovely. This looks like a beautiful graph where all my bars are within 0 to 1.5 loose. Now let's go to something known as the implant tracking.
So this is where your question
So this is
from.
a tracking page. If you can see, the red dots are the center of the tibia at each post capture on the femur. So we want these red dots to be in the center of the femoral implant near that black line. Can you show the black line? Yeah. So these are slightly lateral to the center femur, if you can see. So what I would like to do is lateralize my femur because I have a lot of bone there. So can you lateralize my femur?
I'm using my probe to check there is bone or not.
Keep going, keep on. One more. Stop. Now it looks beautiful. You can see that the center of the tibia is along the center of the femur. Rotate the 3D model, please. See, even in the back, it's beautifully tracking. That means our tibia and my femur are tracking nicely in all 4 captures. there's not going to be any edge loading.
So now I'm going to use the green probe and locate the medial most fibers of the ACL and see whether the implant is undermining it.
Can you capture on the screen? You see when he's captured, it is still medial to my tibial base plate, so I'm safe over there in terms of ACL.
Now I'm going to use the green probe and I'm going to map out where the original cartilage is. So I'm going to put the probe right anterior to my femoral implant and I'm going to capture. I'm going to take multiple points.
Capture. Capture. Now if you see that sagittal view there, can you scroll through the sagittal view?
If you can see that yellow line on the sagittal view, this is basically a conglomeration of all the points taken on the normal cartilage. Now if you can see, my implant is nicely matching that line which is made by these multiple points. So there is a smooth tracking between the implant and the cartilage and there will be no bump for the patella.
So now my planning is done. Robo comes in. It's time for the robot to take part in the action. So this is called a planar workflow where some cuts are made with the saw and some are done with the burr. Now you can see this is something known as a haptic boundary, the yellow lines that you see there. Once that haptic boundary appears, I press and hold my saw so it auto positions into the right plane of the cut. So once I've auto aligned, now I'm going to take my cut. There, my first cut is done. Now next please, go into the femur. Again, the haptic boundary has appeared, auto aligning. Once it's auto aligned,
So if you notice, the boundary won't let my saw go out and if the limb moves too fast, it shuts off.
there you go. Okay, my cuts are done. Now I'm going to change to a burr. My saw attachment becomes a burr attachment. You can see this is the burr.
So
earlier
software it was a burr only, which
Again,
is not very
haptic boundary,
ergonomic.
press and hold.
Now you can do part cut and part burr. So you should not worry if we see any red. That means the burr has gone 0.5 millimeters deep. It won't let us go any further than that.
So that's 0.5 mm. So it allows you to go that deep, but after that it will shut off. So the easier way is to finish up the periphery and then come to the inner part. It just takes a little less time to do that way.
Okay, next, the peg holes. You see that it's auto-orientating.
So that auto aligns the burr.
Next. There you go. So my femur is ready. Now I'm going to take out this lateral ridge on the tibia.
So I'll skip through this so that we can save time.
Tibial implant, place it over here.
So you can
This is a tibial implant impactor.
Once the cuts have been taken, we have enough space to take out the meniscus, and then you put in your trials.
Now get in a femur.
It is a size 3 right medial femur.
The femoral punch.
You can see it's nicely matching the non-worn out cartilage.
And I'm just going to take out the extra frayed cartilage here. And you can see how nicely the transition between the cartilage and the implant is over here.
This is an 8 trial poly. I'm going to now slot it in between the femur and the tibia. Okay, pushing it and see it nicely slotted inside.
Now that my trials are in, I'm going to now check whether it's fitting nicely. So can you move out of the way please? So now it's moving nicely. Start the kinematic capture. I'm going to give an axial pressure and take through the range of motion. You see that orange over there? It shows that my implants are in contact throughout the arc of motion. Now I recapture my my valgus stress values. First at 10 degrees, capture. That's lovely. Again at 45 degrees, capture. Okay, and 90 degrees, capture. And 120 degrees, capture. Lovely. Now if you can see the graph, The blue bars are what were pre-trialing, and the orange bars are what are post-trialing, so they're almost equally matching what I had planned earlier. Wash.
Of course, now the wash and
so
cementation.
My final fit.
After the final implantation is done, we can again have a quick check of the bars. So again, the same thing is repeated, and we just cross-check that it's still matching.
Lovely. Okay, that's great.
My green bars are also matching my orange and blue, so we're all good.
Okay, that beautiful arc of motion.
Don't forget to take out both the checkpoints. That's a beautiful looking unicondylar knee.
And you can see the patella is not too badly affected over here at all. It's just that small ulcer on the medial facet, so we don't worry about that. Yeah. So any questions, please feel to ask. Otherwise, you can head to the talk as well.
Anytime you have converted UK into TK?
Yes, initially many times when we weren't so sure about when we're seeing the X-rays and all that. But after time, maybe after the first 20, 25, we got more used to seeing the proper X-rays and the proper indications. You're talking about in the robotic?
Yeah,
robotic.
And
No, never. Because by the time we adopted robotic, we had already done more than 250 unis, so we knew how to select the correct patients by then.
So what is the excuse me.
Yeah.
What is the benefit of CT? You said it is a limited size CT.
Yes.
So if you are doing the same hip rotations and everything, so what is the benefit of the CT then?
So as I showed, we could plan the sizing earlier, beforehand. We didn't have to paint the whole joint. So now in the non-CT base, you have to reach till the posterior condyle. You don't need to do that here. All the points are anterior to the mid line. Okay. And on top of that, if you see, when we entered the center of the hip, it is just a quick rotation. It takes like 3 seconds. But when we're doing the non-CT based, you have to make sure that the accuracy comes down to 0.8. But here it just takes like 3 seconds to do it. Yeah. And mainly it's about the pre-op planning.
Hi, one question. Whether can you do this in very tight knees, uncorrectable varus, not opening, or it has to be a opening, a correctable varus deformity?
But the basic principle for unis itself that it has to be correctable, because you don't want to do any soft tissue release. Like if you think about it that way, better to avoid. But then if you think about it, I mean, more practically, you can put in a couple of degrees of varus as well. But we don't usually do it in cases where it's uncorrectable varus.
And what's the cutoff for the T-bill resection? How many mm you would?
Don't like to go more than 2.5 mm deep. Okay. So if you're going less than 2.5 mm deep, that means you're cutting too much. The range that they give us is 3.5 to 2.5 mm deep depth.
From the native part?
From the native cortex. Yeah.
Adarsh,
Sir.
this was nicely performed surgery.
Thank you.
But the tide mark, do you decide prior or the robot will tell you?
Yeah, so
the tide mark.
We tide mark, you have to check it inside with the probe, but the specialist brings it in with a approximated place where the tide mark would be. So he's matched it to the shape, and then we check it intraoperatively with the probe.
And how many times you need medial release in such a cases?
Never do a medial release.
Do it. But
we only expose that triangle, and that's it. Not more than that.
But still, I'll never go for UK in this X-ray.
Okay,
because
but
you can see patella was also degenerated.
I think this we don't consider as a degenerative for us in the last experience with
if
unis.
you go for standard criteria for UK, I don't think this X-ray fits for UK.
Actually, Satish, I think I agree with others that henceforth, the UK will be the first line of defense with our this thing. And gradually the indications also may go on increasing. Correct. Because there was some similar discussion about 4 or 5 years back in IA, Indian Arthroplasty Association, where I showed that a deformity in some 50 years old person, which was 16, 17 degrees varus.
Okay.
And we had a very strong debate between, Mullaji challenged it, and Mullaji said that, how can you do it, and I don't do it beyond 10. When I met him last in East, so he told that now I am doing for it. And when you have a tool which you will give, see, look at the X-ray, it is absolutely fantastic, and this patient will do very well.
So you meant to say no weight will go on lateral compartment or the patellofemoral?
No, I think no. See, fundamentals will not change. Patellofemoral, if medial is involved, don't worry about it.
Okay.
Lateral facet involved, I think you have to do something.
And even if you see all the Oxford literature as well, they say as long as it's medial facet and as long as it's not bone on bone, we can go ahead. And we have been doing that with good results without any issue.
So can we see lateral compartment in this video?
Yeah.
Yeah.
The lateral compartment is absolutely pristine actually. That's the first thing I do. I always check.
Okay.
Without checking, I never go ahead.
Okay.
So I'm going to flex and check for my 3 criteria.
Yeah.
My first criteria is a medial bone-on-bone arthritis. As you can see over here, it's worn out completely. The second criteria is the lateral compartment.
And one can see the degenerated ACL fibers
Yeah,
also
so
there.
this, they're afraid, but I always check with the anterior
So it's a
draws.
stable knee.
Functionally stable. That's
Yeah,
okay.
that's, see, it was a criteria for mobile bearing things.
Yes.
Now, we are moving gradually with the technology to the fixed bearing knees.
It's a
That
nice
is
bulky
one.
ACL, yeah.
Number 2, arthritic knees, they will be quite stable inherently because of the ligaments, they are tight.
Okay.
Number 3, if you, in a fixed bearing knee, irrespective of technology, if you, whatever you are doing, if you reduce the slope by a couple of degrees, it gives you a stability. And I have done that in ACL deficient knees, and it works well, fixed bearing. Mobile bearing will not work in that.
So we need to change some criteria for selection.
Yeah, definitely. We should expand. Don't do it unless you're convinced. But once we were convinced, only we started expanding.
That's what I'm convinced with this knee.
Main obstacle, I think, in UK is the patient apprehension.
Yes.
When the relatives, they start asking, but दूसरे side को हो गया तो क्या करेंगे?
Yeah, absolutely.
So I think that is where the surgeon counseling comes in picture. And what I tell my patients is that, see, if you do it today, suppose a 60 years person, now today, in India, when I was studying MBBS, 85, that time, the longevity was hardly 50. But in our PSM book, the average lifespan of Indian person was 50, and for male, it was 50, female was 52, and male was 50. Today, even India, the longevity has gone beyond 75 years as an average, including infant mortality, including everything. So we expect that our people, our patients of today will live for a longer life.
Yes.
So if this person is 60 years old, and you do a TKR, after 15 years, when he will be, say, 75 or maybe 80 years old, will you be doing a complete revision in them?
Yeah. But will it
And
be
this
needed
will last
after
for
20 years?
this will last for 12, 15 years definitely.
It will last.
Then you have chance for revision, right?
Huh?
Yeah.
Then you have chance for revision.
We can always convert to
TKR with
primary.
Maybe a augment will bail you out.
Okay.
Yeah.
Yeah,
Okay.
Rakesh, yeah.
Point taken.
Narendra, the point about longevity, which you just mentioned, even in days gone by, was actually calculated at birth. Somebody who's come to you has already gone ahead of that criteria, where a lot of people used to die as children. Now, once they're alive till 50, I can assure you they're all going to go above 70.
Yes.
Right, so please remember that. Don't equate the longevity at birth. That is a different ball game. Now, somebody who survived will survive a very long time. And so, number 2, if you do UCAS in large number for beginners who are going to take up, I would say do stress X-rays. Very
Correct.
important for you. Not only to see the medial side opens up, but also to see lateral side
Lateral
does not
collapse.
collapse.
Correct, sir.
You will
Correct.
have very subtle inflammatory arthritis. And if you see X-rays like this, which are a bit osteopenic, think that in your mind, do ESR, CRP, and even RA factor if you want to. But these days, the digital X-rays look very funny. So we can't really look at an X-ray and say if it's osteopenic or not. So we have to rely on other criteria, particularly stress views. Once you are experienced, you would know, look at an X-ray, say this doesn't even need an X-ray. But in the beginning, please do stress X-rays. 1, to see medial side opens up. Number 2, it doesn't collapse on the lateral side.
Agreed, sir.
Absolutely.
The first 300
and
cases
secondly,
we always did
one more thing which
stress
Satish asked you is that about the release. See, UK is a purely bony
Resurfacement.
procedure.
Yeah.
If you touch MCL, it's gone. So don't do it.
Yeah.
One more question. Do you do cartilage mapping?
Yeah.
Do you do cartilage mapping before going for uni?
No. So the cartilage mapping is done during the case. You mean
for decision making
No,
in OPD?
no.
If patient comes to you and you think
We don't even do MRIs. We don't even do MRIs preoperatively. It's just a simple AP lateral X-ray. Initially, we were doing stress X-rays. The cartilage mapping is intraoperative just to make sure that the implant and the cartilage are smoothly matching each other, so there's no bump for the patella. That's it. Nothing preoperatively.
Slightly different, I think, what do you say, criteria I use in borderline cases. So if suppose there is a 49 years old female who comes there or male, whatever, and it doesn't show a bone-on-bone arthritis, but narrowing of the medial space. What I do is that in those patients, I do MRI.
Right.
Patient like that, I will not do MRI at all. But if there is some sort of, this thing, then what you say very commonly is that you have got a root tear, you have got a degenerated, complex medial meniscus tear, and grade 3 osteoarthritis of the medial compartment. So those cases, if I do arthroscopy, I have seen that my colleagues, Sohail is doing that arthroscopic work. So if you do that, then these guys are never satisfied. Their meniscus again gets injured because of a degenerated surface. And that is my slightly extended indications in cases, and that is where the role of MRI is there. Role of MRI is not all the patients. Hardly, I think we do around the borderline cases who are there, and that's it. I think for such cases, definitely not.
Right, sir. We just find it easier to probably keep a backup of a TCAR instead of going for an MRI. But a lot of people do the MRIs as well.
Yeah,
in the borderline
I
cases.
think it's not necessary. If you take a pure, what is called as a ACL lateral X-ray, and the defect doesn't go beyond the midpoint, mid-coronal point, then that's absolutely fine.
Right.
So what happens if you do a clinical examination in your clinic, patient has McMurray and ADT is negative, but when you open it, you find a deficient or an absent ACL. Does that change your plan, or?
Yes, because I have done a lot of Oxfords, I still give a lot of importance to the ACL. Though it was frayed, it was nice and bulky, and it was. But if it was deficient, I have got a couple of cases like that where it looked hunky-dory pre-operatively, but when I opened, the ACL is completely gone. I just convert to TCAR. I don't take that stress in my brain. TCAR is ready.
What about your fixed bearing in those
No,
cases?
if the clinical stability is there, now this is also fixed bearing, I think.
Yes, it is fixed
and even the unis which I showed yesterday, they are fixed bearing. So in fixed bearing, if clinical instability is not there, I will still go for a UK and reduce the slope.
Yes, a lot of people are doing
generally, I give 5 to 6 degrees slope. If ACL is not there, but clinical stability is there, I will go for 3 degrees or 4 degrees.
Right.
Okay.
One more question, not to Adarsh, but the seniors in the house. Any case scenario where you will prefer HTO over uni?
Yes.
Yes.
Great question. I think these two have different indications.
Yeah, absolutely.
If you have tibial metaphyseal deformity, you go for a HTO. Whereas if it is an intra-articular degenerative deformity, you go for UK. It's very simple.
Correct. And also, if it's not bone-on-bone arthritis, unless you see kissing bones like this, don't go for uni. You will not get good results. If you are finding there's still gap left and the pain is not subsiding conservative, then you can think of an HTO. So if you're having bone-on-bone arthritis, I would definitely head for a uni. So that usually different sets of patients.
So just one question to all. Should we consider the condition of lateral meniscus also while planning for UK?
Others?
I don't know. If he had a lateral meniscus, he would be having some pain on that side. So
actually, a very relevant question, because it is documented in literature that the medial compartment, the cartilage is important, and the lateral compartment, meniscus, is important. So I think I agree with Varun. You actually examine that there is no
lateral
tenderness or McMurray's on the lateral side is not positive, grind test is not positive, that's fine. But no need to check it on an MRI pre-operatively.
Again, I'll come back to
this.
this.
See, the main inclusion criteria, and I think others will agree with me. When a patient comes to you, you ask where is the pain.
Always, yeah.
If he points here, do a uni. If he says, yahan dukta hai, global this thing, don't consider.
Don't even think about it. Yeah.
That's it. A simple clinical criteria.
So if you look at, even from the trauma cases we have seen, that if you have a lateral plateau injuries, they do very well. Because if you realize even for a normally aligned knee, 60 to 70% of your body weight is still going medially.
Correct.
And only about 25 to 30, maybe maximum 40% weight goes through laterally. And if you've got decent, even with small amount of meniscus missing, you are still looking at 10% deficiency in that knee.
Yeah.
That is pretty okay with all the symptoms. So please don't dissuade from a UKR, you can still go with it.
Right.
Exactly, and I think in last 2-3 days, maximum discussions were around UKR,
Yes,
and I'm very happy for that, because earlier I used to do UKR and then I had stopped doing it for almost 10-15 years. Because the X-rays used to look, weird. I used to do sigma partial earlier. And then I never did Oxford. I was always believer in fixed bearing. But then later on, 15 years went in between. And 2016, when I first adopted for robotics, The only application in the Navio robotic was
At that
UK.
time. Same in
that
Macro
time.
started
That time
with UK as
TKR
well.
was not there. And I took a huge risk that time to get it. And after that, my practice, my patients started becoming more, satisfied, because UK is a fantastic surgery provided you do it right. The only most important determinant of a longevity of UK is accuracy.
Correct, sir. I would say...
Forget about the mobile bearing, forget about everything. Accuracy. If you do a perfect mobile bearing or a perfect fixed bearing, ultimately technology, if you use, it is going to give you a 10, 15 years of definite painless knee. Now, how many of us can give guarantee that your knee, even if you do a total knee, is going to last more than 15? Suhas, will you give a guarantee for total knee? Nobody can give that, because literature doesn't support.
I would say robotics and uni are management in heaven.
Exactly. I think that is going to be our first armamentarium in our coming times.
Thank you, Adarsh. That was a wonderful live inbox surgery. I would like to ask the question about hip to Adarsh and even the Suhas sir. I think both are doing robotic hip. So you are doing everything, like every hip in robotic way, or you are doing some conventional, sir?
No, sir. So, sorry, you want to go first, sir? You can please go ahead. Yeah.
Whenever possible, preferably robotic.
So the next
for us,
question is,
sorry,
from
for
your
us,
side?
it depends on the patient's affordability. I'm still doing good number of conventionals, but majority, if the patient is affordable, definitely robotic.
So only affordability is the criteria.
Yes, that's
any
only
other criteria?
Of course, revisions till now have not, there are people using it in China for revisions, but it's off-label, but they are going to come up with that as well. But revisions and all are still conventional at the moment.
I think at the end of the day, revisions are the, even for the knee also.
Yes.
Revision is the next application. Even I am one of the global, persons who is, consulting various companies to develop a software. Because in because in revision, I think that is extremely important as far as the joint line is concerned, as far as where this thing is there. So we did some trial cases with Corey and mapped, the joint, that is in cases of aseptic loosening. If you put a spacer, then that chance is gone. Yes. Means in the sense, that's an infective revision, then that's gone. But if you have a uni, I revised, in this year almost 7, 8, I think Rakesh is there, unis, Oxfords, like I told yesterday, because the main reason for revision was not the implant, but malalignment.
Yes.
In which there was a, dislocation of the bearing, there was a fracture of the bearing, there was a lot of instability. So there are issues. If you are doing Oxford, it doesn't mean that it is going to give you best result.
Oxford
because
is more difficult to do,
so.
Yeah.
It is mainly the perfection of the implant. And this can, even if you see the global literature as far as TKR is concerned or uni is concerned, in conventional methods, there are almost 28 to 30% outliers. TKR can tolerate it, like Rakesh was saying yesterday, that kuch bhi karo, TKR will go on for, 10 years or so. But UK will not, bail you out. UKR will fail. So I think the best indication for robotic surgery in my practice was the UK. And from zero, now overall, whatever patients are coming, it has gone to almost 15 to 20%. Daily, we have at least 1 or 2 uni compartments.
Same here, sir. Yeah.
So I think the take-home message is that if you are opting for technology, try to, have more uni compartmental, because they will be your happiest patients.
Sir, one question. Would you do a uni if the patient is not affordable? If your package is different, but for robotic and non-robotic, and the patient is not ready to pay the extra difference, the amount, and you're still convinced that the uni is very good with robotics, will you still do a uni at the same price for the patient, or what would you work out? So the same question to Adarsh also. Because we believe that uni is really good.
I think if you want to do, now, I hope that Smith and Nephew guys are not around here, because they have only oxynium things, which is costlier. But in one of the case which I showed yesterday was a hybrid thing. I will go with the cobalt chromium with vitamin E poly and offer him that. Because all of us know whoever is doing robotics, now it is off-label. because the sensors, they recommend all the companies for one, sensors and this thing for one case.
Single use.
Whereas our experience is that most of this thing go for almost 8-10 cases. So I think that will be your experience also.
Yes, correct, sir.
And we will have to optimize this for our country people. So I will do it.
What about you?
So just like my robotic case earlier, if they were not affordable, I was doing Oxfords because I had already had experience in that. And then affordable patients robotic. But in the last 2 months, I completely stopped. Even if they want to go for convention because of lack of money, I'm giving them a discount and going ahead with the robotic.
So the take home is, I think, uni.
See, in India, because this is a economical question, not a scientific question. So I will tell that in India, all of us know that it's a volume business.
Yes.
It's not the cost business like in Dubai or in Middle East or in US, where they charge almost $30,000 rupees, $30,000 for a single TCAR. But all of us are doing in 1 lakh, 2 lakh, which is hugely this thing. Cost effective. But this thing is volume. So we need to understand that. So don't say no to any patient. When I adopted robotics for first, I think 5 years, 3 years or 4 years, I did not charge a single farthing extra for robotics. Because we had to take that science further.
Small thing I want to add, Narendra, to it, that you cannot go into robotic TKR without knowing the instrumentation without robot.
Correct.
Sometimes the robots will fail. The burr may not work, the pins may get loose,
It has
and
happened,
it must happen to,
It has
happened to
happened,
everybody.
yes.
You have to fall back on the conventional way. So please learn the conventional way also, even if you have the robot.
No, and that's what Dr. Rakesh is saying is absolutely right. I had certain cases where I have burred femur, halfway, and the robot, is something happens, your sensor moves or robot gives you a problem, and that is where your basic principles will come in picture.
I have a question to Vaidya sir. Sir, here in
You're on the
desk,
podium.
desk. You have all robots, so which is your favorite robot?
For what?
So, any case, like if you have...
himself.
See, okay, I'll tell you.
Sir, say Mako. It's a safe answer.
Yeah, Mako is my favorite because Adarsh is my favorite, and I think that is there. But Mako doesn't support us in this meeting, so that is not my favorite. So, see, there are 4 points which should be considered. This is not a simple question. As far as the accuracy is concerned, I think there is enough literature now which says that more or less all the robots, whether they are CT-based, image-based, X-ray-based, or mapping-based, or imageless, they are all equal. Now, most important thing is that how much stress, you had to take to change your day-to-day practice in your OR. We had a small study which we did not publish. What was the stress? My assistant, OT in charge, Ashwini and Hari are here. Whenever I started doing it, my first, case took, normal, conventional took 20 minutes, 25 minutes for implant. Whereas the robotic case took 2 hours. And everybody was stressed. Robotic karne wale, are baap re. That is also important. So in my opinion, as far as the OT efficiency goes, Cori is the best because you don't change your operating pattern. Only thing now, Cori, if you want to do 5 cases in a row, that is hard on your hand. That is definitely there in spite of improved ergonomic handpiece and everything. As far as, this thing is concerned, the Rosa. Rosa is very easy to operate, but it is a bigger machine. It occupies this thing. I had to learn how to position them, which will not, come in the way of my surgery. And I had to, adjust to that position. If you see the global literature, the accuracy, there is I think Sharad mentioned in his talk yesterday, there is a paper where they have given 3 stars. So Mako and Cori, they have 3 stars because burring, if you see any precision industry, all the precision instruments are done by burring, not by cutting. So the industry will use the burrs and they will do it. But burring is hard on our hands, that is definitely there. But if you are a high volume surgeon, I think the saw-based things are better. I have a limited experience about Willis. We have taken it very recently. And I think that is a midway because I don't have to do a CT scan. I am using a saw which is very good. So, like in Ishq, I told that they are not my wives, they are my girlfriends.
So one question, talking about last point. So you were saying that when you use Velis, the anterior chamfer cut is more. So does it mismatch the implant? So if it is bigger than the normal implant, then it would mismatch. So that's what I have.
I really don't know what is right, whether I was wrong conventionally or whether this is there, because when I see this chamfer more, we're very worried, and distal, remains very small. But the implant fits really fantastically well.
Okay.
So I don't know whether, because our conventional, there is a lot of literature which says that your femoral entry point, if it is wrong by 1 millimeter, it will give you 2 degrees of deformity. If you take it anterior, you will put in 2 degrees of extension. You are not taking into account your femoral bowing, which is a very major factor as far as the short Indian females are concerned. So there are, if you have a medial point, then you will have a varus or valgus or this thing. So I think in conventional, there were a lot of variables. I think that is where the CT-based this thing will be slight advantage, where CT scan, if you assess properly yourself, not the 10th class technician, but you have to spend some time to, validate those points. And that will be one of the advantage, but slightly time efficiency may be a problem. I am not using it, so time efficiency, Adarsh and you will be better people to tell about it.
If you're using the same surgery, same jigs you're using with navigation, still the chamfer is not so big.
Yeah.
Because with the instrumentation, the APCC block, the chamfer is not as big as it appears to be with the...
Even I have used the Brain Lab system for Attune for a couple of years, but you are absolutely right, and this was really very surprising. Similarly, when I started doing robotics, and I was not a very quick surgeon that time, myself, Rakesh, Satish, people on the stage, we started doing a study where we did one side with the conventional instruments and one side with robotics, and we are about to publish that, and we came to know that the sizes when you do robotics is definitely on a femoral size is one size more than when you do a conventional one. Your cuts, whatever you plan, will be more. So probably in robotics, when we are mapping, actually in the real-time mapping and CT scan, there is one small difference. When we are mapping the, in a imageless system, we are mapping the cartilage.
Yeah.
Whereas in CT, you are mapping without cartilage and you have the bare bone. So you have to, when you are planning, you have to keep it in, I am in no position to opine which is better. But in my practice, I think mapping, where I can match, suppose in a varus knee, the medial condyle has got good, the lateral condyle has got good cartilage, then I just match it. Okay, so in this thing you have to be imaginative and think theoretically in image-based, okay, the cartilage thickness is 2 millimeter, and you compensate for that. So that's the only difference.
Thank you.
Yeah, thank you everyone.
Just one thing I want to say regarding all this thing, that the question was about which system is better, and I feel it's not just the system. What does the company offer you?
Yeah.
Not in other words, but do they offer you TKR? Do they offer you UKR? Will this robot help me with a THR? And after that, does this, all the implants have got track record behind them? And I think that's what's important more than just the machine.
Absolutely right, and I think most of the companies are moving towards multiple applications, like some systems are even coming to sports medicine, for ACL tunneling, or they are coming for shoulder also. There are some companies, so we will see a lot of evolution. This is the spark. These meetings are spark because technology is going to invade our practice in a very, very big way. Like Dr. Sharan yesterday explained, it was a fantastic lecture yesterday, and I think we should be open for that. You can accept at any time of that bell curve. You can be a beginner, you can be at the peak or whatever, but ultimately we will have to resort to that.
I think two things which we want in future is patella resurfacing, if it can, the robo can get it. With the thickness of patella, we can do a image-based or imageless. We can get the patella resection and resurfacing. And secondly, the amount of downsize which we do to balance the gaps if we can quantify it, if this so-and-so millimeters will lead to so-and-so degrees of correction, so that will be really good.
We are doing a study
I think
on that as
what
well.
you are saying is right. There are three, I am working with some companies as a consultant for further developments. So in my opinion, there will be, there are a lot of technologies which will be easily adopted. For example, many systems have got pedals. You do this, you push that button. In our daily even the Alexa, listens to our voice command. These guys should produce, all the company representatives are there. So I've told them, why not have a voice control? Isn't it? Move the femur anteriorly 2 degrees. It moves. That is one thing. So wireless, which will bring more sort of sterile environment in our OTs. That is one. Number two, I think the size of the robots in the OT also is important.
Yes.
I think they should go on reducing it. And they should devise some systems like, one of the companies I told that why you want the arm to come from the lateral side? Why it cannot come from the anesthesia side? So your assistant, everybody is free. So there are a lot of things which will come. I think all of us should give these feedbacks and be very aggressive, because what happens is that these guys who do new designs depend on American surgeons who don't do complex cases.
Yeah.
You and me, all of us do complex cases. So they don't understand. A short obese female, 4.5 foot female hai, and the flexion is only 60 degrees. It's a very tough case. And these guys don't see it. So I think that is where I think Indian surgeons, because we are becoming capital of robotics after US now. And we should all come together. That's why we form this society, irrespective of what the hell, whichever company we are using. The basic principles are same of planning, executing. What is different is the way of bone cutting. And probably mapping and this thing. But even in CT-based, I think you map in the real time also,
Yes.
and then have your final plan. So I think there is a lot of scope for multi-centric, multi-system research. I think that is a take-home message for all of my friends here, that we should come up with this sort of research, be very open-minded, and have this research together. I have already talked to some of my colleagues yesterday, and I think Adarsh also, who is very much involved in this meeting as a co-chairman and always with me. So we should have something like that, which will have a multi-centric, multi-system sort of a trials.
Yes.
Thank you, sir. So as we are running out of time, so we'll proceed to our next session. Adarsh, you need to speak something?
Yeah. No, just I think the next talk.
Next talk.
Yeah.
Thanks.
So I won't spend too much time on this because most of it is covered in the video. I'll quickly run through this. Sir asked me to speak on UK with Mako, the efficiency and accuracy. So where exactly does the efficiency come in here? So I'm talking about the Mako. As you all know, I've been speaking about this last 2-3 days. There are 3 types of robots: boundary control like the Navy and the Cori, semi-autonomous like the Mako. So there's a human interaction still there, and the fully autonomous like the CUVIS, where the robot is doing most of the work without the thing. So I'm not going to show these. You've been seeing these robots in the last 2-3 days. Quickly, because you haven't seen any Makos in the last 2 days. So this is a robotic arm. I still have control over it, but it's within my haptic boundary in that particular planar workflow. So we're working within those boundaries in that particular plane. So again, a different type of classification is again image-based or imageless. Again, I'm not running through this, but we're talking about the Striker, which is a CT-based. So right now, the advantage here is the Mako, I can do the total knee, partial knee, as well as the total hip. And again, as I told, as Vaidya sir also mentioned, the marriage made in heaven is between the partial knee and the robots. So what's the need? Do we really need it? We know that AMOE can be managed with unis or total knee, either of the two. But unis have faster rehab, reduced blood loss, and fewer perioperative complications. And our own study, where we have studied more than 3,000 knees, which were done with TKR, we studied the wear patterns and the ACL, and we found that 47%, it's a huge number, were amenable for uni if you take the Oxford criteria. So this is our paper where we published just last year. So, but still, they're not very popular in India, probably because of the increased risk of revision. So, but if you see all the papers, the outcomes are really fantastic. 98% survivorship in the 1500 by Berend et al. Sward and Price et al. Showed 91% at 20 years. So the question is, are revision rates really high? Well, probably because it's a very challenging procedure. Demanding procedure with restricted field of vision. Threshold for revision is much less. If you get a uni patient with pain, versus a TKR patient with pain, you're probably going to jump for a revision in the uni patient rather than the TKR. TKR guy, you'll probably ask him to do some exercise and come back again. But you don't have that threshold for a uni. The potential for technical errors is high in unis. Poorly implanted partial knees will definitely fail earlier. So at the end of the day, successful unis depend on three things: accurate component positioning, soft tissue balancing, and overall limb alignment. So there's a lot of calculations that need to be done. So that's where the robo comes into the picture. So I'm talking about RAPCA, we call it RAPCA, so robot-assisted partial knee arthroplasty. So as you know, it's a technically demanding and slick surgery, and robotics prevents overstuffing, which is one of the most common reasons for lateral compartment wear, if you overstuff the medial compartment. So you can avoid that with the robot. So the three core features in the Mako partial knee, the enhanced planning, which I showed you earlier, the dynamic joint balancing, I can move my implants around to get a perfect balance, and of course the haptic guidance in the execution of the case. So it's a 3D planning where you're doing the segmentation like this. All these slices are put together by the technician, and they create a 3D model of that particular patient. So as we've seen earlier, we get this 3D model before the case even starts. So I can actually plan my sizing of my implants beforehand. This is of course a TKR video, but the same thing for a partial knee. So it's the segmentation is done, you get a 3D anatomy. It helps with implant sizing and alignment to the bony anatomy. The OT layout, as you've seen, I'm not going to run into this. Bone registration and dynamic joint balancing in the 4 post captures I've already shown in the video. The graph balancing, again, it depends on where you're tight, where you're loose. You have this graph where you can just adjust your tibia and your femur depending on where you're tight, where you're loose, and in which position as well. So once you get used to these 2, 3, 4 cases, you know how you can adjust your implants to get your ideal graph. Then there's the cartilage mapping, where we want this nice transition between the cartilage and the implant, which we can also do with this robot help. Implant tracking, we're always afraid of edge loading, especially in the fixed bearing implants. But with this implant tracking feature, we can make sure that it's always centrally tracking femur over the tibia. As you've seen, the burring is done with the robo. Now with the planar workflow, 2 cuts with the saw and the remaining by the burr, so it's a little bit more ergonomic for the hands. And the trialing is done. We can again check the limb alignment, joint gaps, and the range of motion, and of course the final cementation. So with the Mako, we can also do lateral unis, we can do patellofemoral, we can do bicompartmental as well. And of course, if all these are still not indicated, you go for a TKR. So you have the freedom to do any of these procedures. Till now, we haven't done any lateral compartment unis yet, because we don't have those many indications in India. So what about procedure time? Not only are we time neutral, but we're actually faster. 35 minutes is my average time. What does it mean for the patient? Yes, it does help the surgeon for sure. Does it really reflect in terms of patient outcomes? We've got reduced surgical time and blood loss, unparalleled accuracy in implant positioning, smaller incisions, less pain due to reduced soft tissue dissection, and faster recovery. So what does it mean for them? These are the striker studies. Less pain in the 90-day period. You can see robotic versus manual being the purple and robotic being the blue. You have much less pain in the 90-day period. You have 92% satisfaction at 2 years. You have again minimum 2 years and minimum 5 years follow-up in the yellow. Less is everything. They keep saying that. Less bone and soft tissue damage, less need for analgesics, less time to discharge, less need for physical therapy, and less post-operative pain. And if you see this paper by Bell et al., where you have gray as a manual and yellow is the Mako, in all the 6, that is femur, sagittal, coronal, and axial, tibia, sagittal, coronal, and axial, in all the planes, the accuracy was higher with the Mako. What about the, I'm not going to go into too much details because all these papers are saying the same thing. Gait comparison, there's no significant difference between a healthy knee and a partial knee with the Mako. So that means you're almost completely restoring the gait to pre-surgery levels. Learning curve, Mako-assisted uni has a shorter learning curve than a conventional uni. That's an important point. Adopting a robotic uni is much easier than a conventional. And what about our outcomes? This lady is a day 2 after surgery. This is one of the first patients we did with the Mako, and she's sitting on the floor and talking. That's when we were convinced that this is really a good procedure. This gentleman is almost 89. We did both the knees, partial knee with robotic. He sent me this picture, a video after a week. This man is 80 years old. He wanted to get back to playing golf. He had medial arthritis, and he sent me this video a month after. I don't know how good he is at golf, but at least he was able to play. And he sent me this video. And this is one case I want to show efficiency accuracy. Just another minute. This patient came to me just last month, a friend's mother. She had these implants in situ, and I was sure that I want to go for uni because there was no collapse in the valgus. So this is a bit of planning that I could do beforehand. I wanted to see if I can get away without taking a single screw. So this is a pre-op planning. I have not even taken the case in yet. I know probably some of you may not venture for a uni in this case, but I was quite convinced. All I did was I just checked where the screws are hitting the implant in all the 3 planes. You can see it is hitting this posterior screw. So what I did was I checked through all these slices. Okay. And then what I did was I make sure that in all the planes it's in the same position. Okay. And if you can see here, I made it a little more proud so that I'm not hitting it over here. I sent the tibia up a little bit so there's no hitting the screw during the cut. I also anteriorized my tibia so that I'm between these 2 screws. Okay, so make sure I'm not hitting the screws in any plane. And once I was convinced about these, I went ahead with my cuts, and I also made sure that my lug holes are also not hitting these screws. And of course, I went ahead with the plan. The saw made sure that it's not hitting any screws when I went ahead with the sawing part. The femur anyway, there was no issue whatsoever. And of course, at the end of the day, I managed to get away without touching any of the screws with a perfect fit, and had a very happy patient after that. So why are we getting better results? Probably we're maintaining the internal homeostasis of the knee. Haptic control gives less inadvertent soft tissue injury, and we're definitely not overstuffing the joint. That's how it's helping. And we're doing a study right now. We're comparing radiological and functional outcomes of robotic versus conventional partial knee. We've studied around 200 cases. We should be publishing this next year. Thank you so much.
Adarsh, for sharing your valuable insights. Yeah. So we have still 2 more talks to go, but before that, we'll take another engineer's perspective. Please welcome Mr. Keith Sims, who will be joining us live. Over to you, Keith.
And thank you very much to ISRJR for inviting me. A very cold welcome from a very cold and wintry Melbourne this evening. I can feel the warmth from the meeting in Pune, and I very much wish I was there. But I've had the pleasure of listening in for the last hour or so, and yeah, I think there's a lot of amazing discussion going on, and certainly looking forward to getting back to India and spending more time with you and your colleagues to learn more about robotics in India. So what I wanted to talk to you this afternoon about was really the ecosystem and really how data is changing orthopedics. So we call this CB Edge, but data, obviously, there are some very sinister elements of that. And I thought it was relevant to really start by saying that really from a Zimmer Biomet perspective, the patient is always the patient and never the product. Patient data is used to create value for patients and their care teams through our algorithm systems and products to support our commitment to the highest standards of patient safety, quality, and integrity. The privacy piece, privacy really is a fundamental human right, and Zimmer Biomet maintains robust practices to help ensure the rights of patients are protected. Patients and customers decide what they share with us. From a security perspective, Zimmer Biomet protects the data that patients and customers entrust us with through strong safeguards. Among other measures, we apply encryption in transit and at rest. We have scheduled security risk assessments and penetration testing by third parties. From a usage perspective, Zimmer Biomet will only use customer and patient data to provide the services we have agreed upon and for purposes that are compatible with providing those services. And an ownership which is very, very important. And we put the patients and customers in control of their data and have established tools and processes that give patients easy options to exercise their rights with respect to personal data about them. So I think, with this transformation and this mass grab for data, and we see it in all elements of industry and in our day-to-day lives. I just really wanted to create that perspective to give you a sense of security and also your patients as well. And as I've just said, we are driven by our mission, which is our commitment to the highest standards of patient safety and quality in our products and services. We're committed to world-class integrity and ethical-based business practices. So what does that mean to you today? So when we look at today's needs, we really look to improve surgical techniques, advancements in material technology and new implant designs. Artificial joints, which can be expected to survive decades, as a number of discussion points have been made over the last hour or so. But challenges with orthopedic care remain. Consider the patient who presents with pain several years after a knee replacement. Their x-rays look good, but this is of little consolation as they experience discomfort and pain on a daily basis. We need a solution to help make smarter decisions with objective data. Or consider healthcare professionals at every level and all around the world who are required to do more with fewer resources. We need tools which help provide care more efficiently. And as patient and caregivers rely increasingly more on technology to find and provide care, it's imperative those systems are integrated and easy to use to provide the best experience. Along the patient journey, care teams are called upon to make critical decisions that determine health outcomes. Augmenting data-driven intelligence to the care continuum powers progress in outcome and provides previously unseen clinical insights which support the best care options to be taken. Zimmer Biomet with ZBEdge technologies generate objective data at every interval of the episode of care. Preoperatively, that begins with My Mobility Care Management Platform, our app that collects preoperative mobility metrics as well as data on compliance with education, surveys and exercises. ZBEdge integrates advanced planning technologies, allowing clinicians to get accurate information on the patient's condition to help inform treatment decisions. And through the My Mobility application, care team members are automatically alerted to relevant changes in the patient's preoperative condition through signals from the gait. In the operating room, ZBEdge brings together multiple technologies including ROSA, OmniSuite, OptiView, which Dr. Vardia talked to just a second ago, that objectify the surgical experience. And OptiView really is probably that voice-activated mixed reality tool that again is going to be a part of the ROSA platform, which we'll see next year, which will be voice-activated. So again, it's creating that efficiency that we should certainly seek. Post-operatively, ZBEdge connects patients to their care teams like never before. My Mobility automatically pushes educational content to the patient's phone, and telemedicine visits and physical therapy can be easily initiated in the app. Finally, ZBEdge expands the possibilities to collect and connect data for an extended period of time with a first and only smart implant, Persona IQ. With it, care teams can remotely monitor patient activity and patients can feel connected to the care team every step of the way. Feedback loop of information gathered before, during and after one surgery to inform the next is really the way that we're going to capture data and learn more about the patients that we serve. Comprised of technologies that deliver three primary values, we're smarter with our decision making with a goal to improve outcomes, faster and more efficient care, and with better value and experiences both for the healthcare providers and for the patients. For ROSA Robotics, again, as the faculty have talked about, we need something that is efficient and integrated, so something that provides multiple applications. ROSA is really a multi-application. It's been designed to be a multi-application platform that works with you, not for you. Utilizing Zimmer Biomet's leading implants and data technologies, ROSA Robotics redefines robotics by providing real-time insights to optimize outcomes with the aim of revolutionizing the standard of care. As your market access allows and your regulatory environment allows, we have three current applications: knee, partial knee and hip, and we will be introducing shoulder and revision knee with iterations of the knee platform in the coming months. So when we look at ROSA, we can look at really elements of it, which really we have four pillars. The first is surgeon-centered. So the surgeon can maintain current approach philosophy and technique, including personalized alignment, if that's something that they choose. Technologies are only as good as the implants they are used with, and ROSA provides you with flexibility to utilize our leading knee brands of Persona with the personalized knee. The Persona knee is Zimmer Biomet's most comprehensive primary knee system, incorporating personalized implants, precise instrumentation, and proven technology. Since its introduction in 2012, surgeons around the world have implanted over 1 million Persona total knees.
Mr. Keith, sorry to disturb you. We are running short on time. Could you please give your concluding remarks? We are really short on time over here.
Yes, absolutely. Yeah. Sorry. Thank you. So I just wanted to share with you an example of the technology as it's working today. So if I could just leave you with this short video, it's really a great assessment of what the integrated health system can do for you today.
One of the patient who lives in a rural area about 2 hours from my practice. This fellow is a farmer who works hard for a living. I performed a successful bilateral knee replacement on this patient. When I saw this patient for his post-op check around 2 weeks, everything looked good and I thought he was looking at a favourable outcome. To keep track of his recovery after that checkup, I used Walk AI. After the surgery, I received a remote alert. The patient's step count was down substantially from 3,000 steps a day to around 800. The patient was showing poor gait speed and gait asymmetry based on expectations from Walk AI's wider population data. Obviously I was concerned, so I called him to ask what had happened. I said, "Listen buddy, you're walking badly, what's going on?" And he said, "I'm not walking badly." I said, "Yes you are, I know you are, so what's happened?" I said, "I want you to confess." And he goes, "I know I promised to stay off the tractor for 5 weeks, but I had to get on it, and I put the front wheel into a ditch and it threw me out of the tractor." The outcome was that I was able to intervene immediately after the event and long before his next physical appointment, at which case the window of opportunity would be lost.
Walk AI from Zimmer Biomet. To learn more, go to zimmerbiomet.com.
So I just wanted to take this opportunity to thank both Dr. Vardia and the faculty of ISJR for inviting us. And I certainly would concur with his thoughts that really Indian surgeons are at the forefront of technology innovation, and their ability with the severity of arthritis and end-stage osteoarthritis they see, the influence that technology can play. And I hope you can see that the integrated system that Zimmer Biomet are offering are really providing real-time insights with the ability to intervene at an optimum point today, and that's not a futuristic thought. So we certainly look forward to working with you in the future to develop these systems and innovations as we embrace technology further. Thank you very much.
Thank you, Keith, for joining us. So we'll be moving on to our last session. May I invite Dr. Kalaivanan Kannan to please give his lecture. I request Dr. Anup Gadekar and Dr. Rakesh Patil to serve as the moderators for this case.
So good afternoon, everyone. So the recent trends in periprosthetic joint infection. So most of the time in our unit, we do a lot of revisions and 1-stage as well as 2-stage revisions. And for each case, we used to send 5 samples, and out of which 3 should be minimum, and 1 synovial fluid and 2 tissues. And synovial fluid will make sure that it goes with the direct inoculation and routine plate method. And we have this machine, Malditov, in our setup right from 2012. And The main challenge is when we deal with the culture negative PJ patients, and we don't forget the basic criteria. We just take in account of all the endoclinic unit as well as Javed Parvezes and the musculoskeletal infection societies and the recent ones. And also you use the package guide where we give importance to the preoperative comorbidities, and depending upon that we define which patient is at a high risk. We follow all the preoperative measures to control the infection in almost all the patients, and let's make it simple as comorbidities increase, the risk of PJ is more, and the comorbidity is less. We consider them for one stage rather than two-stage revision. So these are some of the blood tests which we do for the infection case in the blood as well as in the synovial fluid, and using the radiological examination methods. Alpha deficiency was something new, but before it was like available to us. Most of the studies make it not so specific, but sensitivity is quite important. And we have been using the leukocyte esterase dipstick, where again the sensitivity is good but not specific, and it didn't add any value, and over the time we didn't been using it. The new thing we are looking for is the next generation sequencing, and this is available, but we have been in touch. So again, this will be add value to the armamentarium. And another one study is the cystine is ribosomal, where it is based on the PCR. And again, the work time is more, and it didn't add much value. We sent some of the samples where we were not able to get the organism during the first stage, and during the second stage we used this method, but again it was not so productive. And but AIMS came up with one study where they were able to isolate the organism in 22 culture negative studies. So we have to look on it. This is another one, new one, which is available, the BioFire, where the working time is just like 1 hour, and you give the sample of only 0.2 and you get the bugs. They are able to give they have a panel currently for 39, and it can be increased. And this is one of the example where there was no growth. This young lady doctor had a hip and it got infected when she came. So we took on for a 2-stage. During the first stage, there was no organism. Our MALDI showed a new bug, but most of the time we give importance when the same bug is grown in manual as well as the automated. And the histopathology was granuloma reaction. So again, ID consultant opinion taken, and for this lady we started on secondary line of TB drugs, and she went good, and we revised the failed choroid with Cohen-Wagner. And another one case where again there was no growth, but the histopathology showed culture granulomatous reaction, and the patient is on Syscon-Zostem, and we have to wait for 6 weeks. And after 6 weeks, we'll look for ISRJR. If it's coming down, we will be taking for the second stage, then we'll proceed. This is another one case where they already did a stage 1, but the ISRJR was not coming down, so they came here. We repeated the stage 1 right now, and again this histopathology showed granuloma and foreign body reaction. So this patient is on second line of drugs like amikacin, levofloxacin, clarithromycin. And for this patient, we will be using the first 3D printed augment, which by this weekend. And the another one case is like stage 1 revision, where this is an old patient and we want them to be mobile. So we remove the implant, we use a new prosthesis and all poly cement with the antibiotic loaded, and we want the mobility should be there so that they will be happy. So this is what you get the result at the end of the BioFire. All the organism name will be written, and whether you are able to isolate. For 5 cases we have done, no far we have not got anything like specific. On-table doubt and the clinical judgment is more important, because this patient was a straightforward ISRJR, everything was normal. We planned for a THR, but the intraoperative was granulation tissue. We sent a bug, it goes Staphylococcus. She completed 2 months of antibiotic and she is free. And recently we presented 3 cases of Salmonella, and all the 3 patients are from different, 2 were from Bangladesh, one own local patient, and all these had 3 identical thing of TB as well as COVID history. And the 2 patients, since they were already on ATT, we just did the surgery and completed it. The TKR lady, like she was okay, but the organism came Salmonella, we were not aware. Then we gave antibiotic only for 1 month, but the ID consultant specified he wanted another 2 months. We didn't listen, but the patient again landed up in discharge. So this time we did a DIAR, and we are continuing the antibiotic Bactrim DS for another particular 2 months. History taking is more important. This patient did the first surgery and the second surgery, everything was fine. Fourth day, and there was a pus. We sent a swab culture. It grew echinella, and echinella is like something like where history taking gave importance, and he gave important history of deep sea diving and cellulitis 3 months back, and we went on with one stage thing. We used the chemical debridement, and the procedure was done, and we give the sample for at least 45 days. Follow-up is essential, drains particular days, and VAC cultures sometimes, and the patient is good. And whenever such patient comes, do not rush, wait. Stitch abscess is quite common, and don't be aggressive in case of patients where we have to do with a dia and the results are good. Puncture is more important because this patient, when we aspirated before giving the antibiotic, she grew aglectia, which is a sign of CA colon, and she underwent sigmoid resectomy, and she is now fine. Thanks, everyone.
Thank you, sir, for that wonderful talk. We'll take questions at the end of the session. So I'd like, please take your seat on stage, sir. We have the last talk of our 3-day session today. So I'd like to invite my co-host, Dr. Sohail Sheikh. I think we should give him a big hand because he has been instrumental in the smooth conduction of this program from the start. And the last talk will be of meniscal preservation.
So I think thank you all. I'm Dr. Sohail Sheikh, the consultant arthroscopy surgeon at LOKMANYA Hospital. So we've had 2 days of intensive discussion on joint replacements. My topic is slightly different. I'll be talking on joint preservation, and I'll be focusing mainly on meniscal preservation. So let's begin. Now, what is the meniscus? It's a crescent-shaped fibrocartilaginous structure present between the femur and the tibia. The medial meniscus, as you know, is C-shaped, covering more than half of the tibial articular surface. Lateral meniscus is slightly shorter, covers more than 3/4 of the tibial articular surface. The vascular supply is by the geniculate arteries via the perimeniscal plexus. Now, there are 3 distinct zones. There's a peripheral red or the vascular zone. There's an intermediate red-white zone, also called as zone of transition, and a white or an avascular zone, which is the innermost zone. Now, in brief, the main functions of the meniscus: this load transmission, shock absorption, stability, joint lubrication, and proprioception. Now, why is repair important? Why arthroscopy surgeons after the repair? Well, a study by Bryceland showed that the meniscus is responsible for more than 50% of the load transmission across the knee. In full knee flexion, the lateral meniscus transmits 100% of the load along the lateral compartment, whereas the medial meniscus transmits up to 50% of the load on the medial side. In complete meniscectomy, the contact area is reduced by more than 50%, causing a dramatic increase in load per unit area. A partial meniscectomy, even as little as 15% to 34%, can increase the contact pressures to up to 350%. Now, how do we repair the meniscus? The ideal case would be a tear in the peripheral red zone, a longitudinal tear, and up to 3 centimeters long. The principles, obviously they have to be, and you need to visualize the meniscus, so you require to do a pie crusting of the MCLs a few times. We also need to create a favorable biological environment, which can be done by debridement of the menisci using a fibrin clot or a PRP. A limited notchplasty or the microfracture of the lateral femoral condyle can also help to augment the healing. Now, what are the techniques of repair? Well, there are mainly 3. The inside-out repair, the outside-in, and an all-inside. We'll just show a small video where we've demonstrated all the 3 techniques. So this is a medial meniscus. Medial meniscus is a bucket handle tear of the medial meniscus. And you can see the medial meniscus is in the notch. Now the first step would be to reduce this menisci back to its original location. So this is the reduction of the meniscus. After the reduction of the meniscus, we proceed with the meniscal debridement to just generate some bleeding, which will help in healing. Here you see a cannula coming in. This is mainly a cannula for an inside-out repair. 2 needles are passed through this cannula in a parallel fashion. These needles have a fiber wire attached to it. We make a safety incision and the needles are brought out to the posterior medial side. Here you can see another suture being passed through. And the circle that marks the fiber wire. So the needles, when brought outside, are cut and the meniscus is repaired in a horizontal mattress fashion. Now this is an outside-in repair using an 18-gauge spinal needle. We load a number 1 PDS through it. The PDS is then brought out through the anteromedial portal. And a fiber wire is shuttled. The 18-gauge needle is again passed, and the remaining limb of the fiber wire is shuttled again. In this way, we can achieve a horizontal mattress repair. So this is the situation post-repair. We can see a well-reduced and a stable meniscus now. It's well reduced to its original location. This lady also had a longitudinal tear of the posterior horn of the lateral meniscus. Now this is an all-inside device. Here you can see the suture going through the superior portion of the meniscus and again into the inferior leaflet. Once the sutures are passed, the fiber wire is cinched to approximate the torn ends. So not all tears are amenable to repair. Sometimes you need to do a partial meniscectomy. What needs to be kept in mind is even if you're doing a meniscectomy, we need to resect as minimum as tissue as possible. Some patients, especially the ones after a road traffic accident, end up with a severely damaged, degenerated meniscus. So in these cases, they may end up with a near total meniscectomy. They need to be sensitized about the need of a meniscal allograft transfer at a later date. A brief word on root tears. Now, root tears are similar to a total meniscectomized knee. A study by Laprade and group found out that if these tears are left untreated, can lead to insufficiency fractures, spontaneous osteonecrosis of the knee, and early onset arthritis. The Laprade group did a study on about 200 knees who were posted for a total knee replacement, and they found a posterior meniscal root tear in 78% of the patients who are under 60 years of age. So that tells you how important this root is. So whenever you find a root tear, it needs to be diagnosed correctly and it has to be treated appropriately at an early date. So to conclude, even though we've made great strides in implant design and to achieve the clinical and functional outcomes after a total joint arthroplasty, there is still no implant which is as good as a native knee. Hence, a meniscal preservation and joint preservation should be given utmost importance. Thank you.
Thank you, sir. I request you to take your place on stage. I think we had a question from the audience.
Anyone having questions regarding meniscal repair? So don't repair too much, otherwise we won't get any AMO or arthritic knees. Second thing, take home message for periprosthetic joint infection is even if you do conventional or robotic, there are chances that you may get sometime infection. So regarding periprosthetic joint infection, you can go ahead with the good thing KK had told regarding good history taking is very important. Second thing, you have to aspirate prior to the antibiotics. You send the culture, finding the bugs, and accordingly you can go with sensitivity chart antibiotics for 6 weeks to 8 weeks. And then again, if there is no growth, you can go for single stage or 2 stage. So, yes, Varun.
Yeah, sir, one question, couple of questions for Kalaivanan, sir. What is your choice of spacer, like the molded spacers or the spacer with a Steinman pin? What kind of spacers you prefer?
So, for the hips and knees, for the hips, initially we have been using the articulating spacers. Now we moved on into non-articulating spacers. So most of the socket has a small cement, and the femur we have a small double. For the femur alone, we try to use our ordinary syringe so that regular the surface, more the elution will be. And for the socket, mainly we don't want the scar tissue be there so that our revision is like quite easy. And we mix, nowadays we use only one palacos, and with one palacos we use 3 grams of vancomycin, and sometimes we add gentamicin. And for the knees, initially we have been using static spacer. Static spacer, then we found it is quite makes the patient stiff. Our number of tibial tubercle osteotomy was quite more, and the post-operative range of movement was also less, and the patellar tracking was like quite problem. So we have been making that. Initially we used to use a static spacer with the POP. Now we use then we started using static spacer with the knee brace, allowing a little bit of 5 to 10 degree of movement so that they are like fine. But in case of old patients, say like 60 plus, when they are alone, we want them to be mobile or at least confident. So we use take the implant, autoclave, and put it back with stimulants so that the concentration of vancomycin is quite good. In that case, we add intraosseous vancomycin also, and in some cases, we take a new femur and only a poly and use antibiotic loaded cement. Sometimes we can get on with 6 months to 1 year.
And sir, when you put articulating spacers for the hip, you make the patient walk on the same?
So we don't allow them to do a full weight bearing walking, but with the walker, with the knee brace on, toe touching is allowed.
Okay, and sir, choice of antibiotic for the primary surgery and the duration?
So most of our primary cases, we use the cephalosporins and the cefizime, 3 doses. One is intraoperative, immediate post-operative, and the next day morning, 2 doses. If any post-traumatic or implant in situ, in such cases, we use same cephalosporin along with the teicoplanin 400 IVOD. And in case of revision, we use after the sampling, we use Magnus-Ford like cephalosporin sulbactam combination with the teicoplanin, and we'll wait till for the culture report to come. Then we have a ID consultant who will decide the antibiotic.
Okay. Thank you so much.
Just wanted to add one point. Whenever you are using a mobile spacer, like he has mentioned, always do bad cementing. Don't so that the retrieval will be easier.
Anyone having any questions? So with this, we are in the final session. We have ended the session, and I think over to Srirang.
Thank you, sir, for the wonderful talk. I request our joint replacement surgeon, Dr. Narendra Vaidya, to felicitate Dr. Sohail Sheikh, sir. I think we should give him a huge round of applause. He has been patient and with us since day one.
I think I really appreciate what work Sohail and Dr. Godbole has done over the last 3 years. It is very strenuous, I know it. Comparing, conducting every session, sometimes stopping somebody who is overshooting his time. So Sohail, I am really grateful to you, and a great presentation also. I know it was a last session. So next time I will ensure that knee preservation and meniscus will be the first session.
Thank you so much, sir.
You know, I have seen how good surgeon Sohail is. So from LOKMANYA, what I should say, I order you to conduct a arthroscopy seminar in coming 6 months. You know, you can talk to a lot of people, and let's have something like that for arthroscopy. Thank you. So I think it was a wonderful meeting, mainly because of a completely, countrywide participation. 4 years back, I think 2017, 18, whatever. Since then, people who were absolute critics of robotics have also adopted this way, and that's a great joy for me. I am extremely proud of my team at LOKMANYA, all the surgeons, Dr. Rakesh, Dr. Anup, Dr. Satish, Dr. Ashish Suryavanshi, everybody. I think this list will just go on. But first of all, I am really thankful, and I want to felicitate certain people who have been at the background, but they have done extremely good work, and they were phenomenal in bringing success. And I have been told this by the surgeons who came from other places, that they were so happy with all the arrangements. So I'd like to call Hari on the stage. I would like to felicitate him personally. He's there with me since long time. He was there with me in all my personal health problems, and I will never forget whatever he has done for me. Thank you, Haribo, and hope to work with you for a very long time. how can I forget the contribution of Ashwini? You know, she has been always there. Sometimes when I'm disturbed, she has tolerated me. When I, am angry in OT, I think maximum times I have made her cry, and I'm really sorry for that. But she has been there around, and she manages all the inventory, implants, planning, my research, my presentations. No words are enough to thank her. So please, next felicitation is Ashwini's sister. You know, when they are touching my feet, they are making me older, and I am trying to become younger. So this is not correct. Next is Sunil Kale. You know, he is my cousin, but I think in LOKMANYA family, I think he has taken maximum scolding or maximum whatever, negative or whatever it is there. But he has always stood strong. And he has always, and this success of ISRJR, getting the sponsors, everything is to his credit. I would like to thank all the sponsors who have actually enabled us to conduct this entire list. Special thanks to Team Zimmer, Depew, Consensus, Healthium, Smith & Nephew, Mercedes-Benz, Max Merrill, Biorad Sciences, New Visions, Atharva Natures, Oliphant Solutions Private Limited, KTL Limited, Bell Surgical, MCure, Apex, ULM, AMS, Visco, then Medline, Ethicon, Cipla, Healthium, Zibon, Bayer, and Codex. So much, we are all grateful to you all to, enable this great event to be conducted in such a grand fashion. Every year, this event is gathering more and more momentum. It is very heartening for me. First meeting which we held, we had hardly 50 people, out of which 49 were critics. I think some people like Rohit Luthra is there, or Rishikesh Saraf was there. They were the early believers in technology. And then we started working on that, and then I think all of us and our patients have got immense benefit from the technology. Technology, like Sharon was saying yesterday, it is the way forward. I think we should all embrace technology like we are embracing the technology in our day-to-day life. We use mobiles, we use automatic cars. Where are the gears now? Do you want to use a car with gears with such a traffic condition? So technology is helping us in all spheres of life. So let's not be, opposite to that. I think the future is going to be, the most 2-3 important things which I would like to include in the next symposium is the pre-operative assessment of the patient with digital technology. Number 2, the post-operative rehabilitation, that has to be monitored. So there are emerging technologies we should embrace. So these are the things, because intraoperatively, I think we are on the same platform, people are embracing technologies, etc. I'll tell you a small incident. My teacher, when I was doing, who is my mentor also, and a great orthopedic surgeon, always, he'll be sort of Deepastamba for all young surgeons, was Dr. K. Shetty. But when I was doing residency in 89, 90, whatever, that period, he said that this arthroscopy surgery also is not, nothing, I used to do ACL with open method, but see where arthroscopy has gone. So the chances that this robotics, artificial intelligence, and the technology will take us, they are immense. Probably there will be a time, like Sharan was saying, that we will be doing virtual surgeries. Sitting in your consulting room, Rohit will do surgeries in Assam also. Yes, it is possible. So that is the way forward, and that's why we should be open-minded. I requested a lot of my colleagues, let's form something where I think where the industry is going wrong, which I talked to Darshan, which I talked to Balaji, I talked to Smith and Nephew guys, is that they're not involving Indian surgeons into research, in developing more products. I think whatever surgeons in US, they have to learn from India, because we do the complex cases, we have the maximum load of arthritic patients, so it is we Indians which should take the lead in technology. See what has happened in software industry. There was one time when, we were scared. When I remember, first time I may be in 5th or 6th standard, when my uncle, Captain Kulkarni, who is, behind all this, all the arrangements and all the administration of LOKMANYA, he had brought a Hitachi tape recorder. What you had, a simple tape recorder. And everybody used to be scared. Arey don't push this button. Something will go wrong. Now our children are born with the technology. They know how to use a mobile phone from day one. Even I am scared. Arey Tejo, don't do it. But they know it. So they are, this is a part of evolution. And I think we as surgeons, that we should embrace, and we should, interact with open mind. Because in India, Rohit will agree with me, all the surgeons who are there will agree with me. I was talking to Vikram Shah, and we from ISK, we have been interacting. And do you know that now today in India, we are doing hardly 2.53 lakhs of replacements, all companies put together. The projections are that by 2030, India will be doing 2.5 million, that is 25 lakh replacements. So there is no need to be competitive. There is no need to be, enemy of each other. We are very, that way, very strong-minded as surgeons. But there is no need. There is no problem in sharing knowledge, because it is the science which is going to help all of us. There was one surgeon who told me, Arey Naren, why are you teaching your fellows? They are going to be your competitors. I will not name that surgeon. We all know him. But I told him, what happens if those surgeons join us or me? They become complementary instead of being competitive. So I think this should be the vision. All of us should come together for the betterment of results, for betterment of our patients, for betterment of science, for betterment of country, to evolve and to get better, solutions, because we Indians are known for their intellect, and that's what is very important. So let's join hands and let's be stronger next time. Thank you very much. Yes. And I forgot, I'm very sorry to mention two organizations. Number one was WAMA. Mr. Patwardhan is there or not, I don't know, but he has been phenomenal in organizing everything, propagating this concept of robotics. And second is Anand Peter, who has really, let's felicitate him. And I think Anand, we all saw what the clarity of surgeries, the way it was coordinated, it was phenomenal. I participated in many international conferences, many national conferences, but the way he has actually dedicated and the way the communication, there was zero lag between the operation theatre and this. There were no disturbances, and 18, 19 surgeries in 2-3 days. I think Anand Peter deserves a big applause. Thank you very much, Anand. You are not here, but I think your team will convey my regards to you, and hope to do more and more such meetings with you. Thank you very much. I invite Pramesh from WAMA and accept token of gratitude from Mr. Sunil Kale, who is the CEO of our organization. Thank you very much. I think Vama and Anand are the best in the country. Anand, Peter and Vama. I think that takes off a lot of stress from the organizer's mind, you know, whether my surgery will be shown or not. There was one telecast which I did for North India Orthopaedic Society just a couple of weeks back on Sunday, and I understood what is excellence after 2 days in this conference. Anyway, I'll call team members of Anand Peter to receive a token of gratitude from Team LOKMANYA. I will request Dr. Mithali Vaidya to felicitate them. And the last and the most important, my organizing team in Lokmanya. So they have worked so hard, and thanks to them that I could sleep for last, so many days without taking any tension. First, I would like to call my, executive assistant Rajeshwari, and I request Ashwini sister to felicitate her. I call upon stage Dr. Nidhi, who has been actually doing all the planning of scientific sessions and taking off all the burden from my head for all organizing scientific things. And the best part of Nidhi is that she does it remotely. She uses technology to manage me. So she is never seen, but she is always there. So that is the beauty of it. So I request Ashwini to felicitate her. I call upon Shreya. In spite of Shreya, we could do this conference. She has been always, what do you say, the bad girl, I can say, in Lokmanya, because she tackles all my problems and she takes care of them. So thanks Shreya for, keeping me free of all the problems for last couple of days. And Sunil is going to felicitate her. I call upon Preeti, who is actually heading our international department, international business. She got, viewership from Bangladesh, from other countries also. So just to tell you, we had a registration of 360 plus people for the physically in the conference. But we had on Ortho TV, thanks to Dr. Sham, that we had almost a virtual on Ortho TV audience of almost 1500 people. That shows the popularity of this, and thanks to you all. So I request Sunil to felicitate Preeti. I know that Raju is in the auditorium and he is going to be angry on me because I did not take his name, but this is a combined sort of appreciation. And last but not the least, I think I will call upon again and Dr. Sohail and Dr. Godbole, who carried this program excellently well, and without any interference. And thanks for showing, my face on Amitabh Bachchan's body, I will definitely cherish that memory. And all of you, have been phenomenal. So, sure. There are 2-3 more people which I would like to felicitate because, you know, getting patients for live surgery is extremely tricky task. Because many people ask, where is NV sir? And to manage that and how to convince the patient, I think I would like to call 2 people. One of them is not here, one is here. So I will give her both the felicitations, Swapnali and Shekhar Mane. So I call Mitali to felicitate Swapnali. She is my daughter, by the way. Huh? Okay, and I think there is one particular what do you say experts who made me dance yesterday, and my legs are so much paining. Is my physiotherapy team. Without them, it is impossible to give our patients good results. So I call my LOKMANYA physiotherapy team and please give them a big round of applause. Second person. And this I would like to present myself. And I request that now I am getting older, you know, please don't make me dance so much. It was really difficult for me yesterday. When you are doing such an ambitious live surgery program, tremendous number of things can go wrong. Electricity may go, there may not be, you know, a proper coordination. So there are 3 people who were in the background who never came in front of the entire thing. First and foremost, I would like to call Captain Hemant Kulkarni on stage because he is the most important person where the telecast and everything, the internet, everything was absolutely spot on. Big applause for him. Hemant is my uncle by relation, but he is my elder brother. And we share an excellent thing. In fact, just to, on a lighter note, I think it was in 1992, you know, I'm very bad in literature, names and things like that. So my marriage was fixed. I had met Mitali, it was arranged marriage of course because no girl could fall in love with me. So after marriage we fell in love, that's fine. But then I did not know, you know, my sister's name, my cousin sister's name was Deepa and Mitali's earlier name was also Deepa. So then Hemant, who is a very good poet and a shire also, I ultimately asked him, what should be the name of my wife? So Mitali name actually is given by Hemant. So that sort of relation we share. Thank you Hemant for always speaking. How can any program, you know, be finished without name of God? So there is only one God of LOKMANYA, the great Sri Krishna, who managed the back office, the post-operative things, the patients, and the most important thing, he managed me. Thank you, Sri Krishna. Please be on stage. You know, we had a faculty of almost 90 people, 90 very eminent surgeons coming pan-India. And Ajit and Prasad have taken care of their logistics so well. I would like to call them up on stage, and I would like to felicitate them together. Dinesh also, I think, please come on stage. It is very tough because the flights used to come at 2 o'clock at night. This, and you know, surgeons are very much, you know, having ego problems and everything, but they have managed it so well. Thank you very much all. All of them. Sachin also should join here. Is he in auditorium? Yeah, correct. Yeah. Thank you, Sachin. He does phenomenal work in the periphery for LOKMANYA, and everybody's contribution is unforgettable. Thank you very much. There is one person who is extremely, extremely dear to my heart. And I think if I am having any problem, I'll call him at any time of day, night, is Dr. Galande. Please. I think people who are there. I will call upon one person who did not contribute anything in the conference, but she was the only person sitting from the first day till the last day who helps me a lot in OPD, that is my biggest sort of tension, who helps me in surgery, is Dr. Gargi. Our head of pharmacy, Amol, I would like to invite him because he has been phenomenal in getting the industry involved with us, and without his help I think we would have been definitely in difficult place. Thank you, Amol. I request Sunil Kale to felicitate him. See, basically my surgical team has been phenomenal. Now the stage has actually, if you have listened to Dr. Vikram Shah sir's speech yesterday, you always keep on learning. And my all fellows, my consultants, I keep on learning from them. Dr. Rakesh is there, Dr. Ajinkya, Dr. Sharad, Dr. So many, everybody, and I am sorry I cannot, mention everybody's name, but definitely we should, what I think is that we should become strong in academics, because that was a feedback from all the leading surgeons of India that you people are doing such a phenomenal work, and why are you not coming up with, literature? We are doing that, but I think we should get more involved in that. So I thank all my surgical team, my orthopedic colleagues who have been phenomenal. All the surgeons who did live surgery, they have given an excellent feedback about our OT staff, our surgeons. So thank you very much from bottom of my heart. And last but not the least, I think all this was possible because of the audio visual and software things which was managed from LOKMANYA's side is Subhash. Let me call upon him, call him on stage, and I request Sunil Kale to felicitate him. If by mistake I have left somebody's name, please pardon me. I think it is a phenomenal thing. This is just a beginning, and as Team LOKMANYA, which is a really formidable team, we are going to go global. So thank you very much, and see you next year. 3 cheers for LOKMANYA. Hip hip, hip hip, hip hip.
Team LOKMANYA, all are please welcome on stage for one picture, photograph. Everybody should be here, please.
I have forgotten to mention about Ortho TV and Dr. Shah, who has been associated to transmit this event virtually, and almost 1,500 people watched our program on his particular Ortho TV. So thank you, Dr. Shah. If his representative is there, I would like to call him. So if he is online, thank you, Shah. And I am really grateful to you to take this event to the next level. Thank you.